We really treasure our relationship with NCSL. Thank you, Carmen. We're so thrilled that you're here today. And while we usually, again, go in alphabetical order, because we are here in Massachusetts, we're going to start with our Massachusetts folks. Donna, where are you? There you are. I'm going to invite you up to say a few words of welcome and to introduce your wonderful delegation, current awardees and last year's awardee who was unable to join us in person. Senator Friedman, we're so glad you're here in person today. Please come on up. Any way that works for you. Yeah, we'll do Senator Friedman last.
Okay. All right, thank you. I was just getting my last-minute instructions from Debbie. Good morning. I'm Donna Mosh from the Massachusetts Association for Mental Health. Welcome to Boston, everybody. I hope it's been treating you well. We're delighted to have you here. And we are really proud to have the most extraordinary legislative delegation and legislative leadership, two of whom are with us this morning, and we're really honored to have them here. This morning, we are giving an award to one, and we are revisiting an award that was given last year to another. So I'd like to start with our current awardee, Senate President Karen Spilka. She is the home team Senate President hosting the National Conference of State Legislators. So we are really grateful to you, Senator, for joining us this morning. We know you're being pulled in many directions. Senate President Spilka is a leader in many spheres, and in her legislative career has accomplished remarkable things in economic development, education. We actually have free community college in Massachusetts, given her leadership and that of her colleagues in the legislature. I first knew Senator Spilka many years ago, before she was Senator Spilka, when she was a champion for an organization in the central part of our state, the South Middlesex Opportunity Council, that provided services to the most vulnerable people with the highest risks, providing everything from wet shelters to services for women coming out of the women's prison in Framingham, to the broadest array and deepest array of affordable housing, which is why I was actively involved with them, for people with many of whom had mental health and substance use conditions. She helped them through a number of challenges locally, really standing up for the rights of people who live with behavioral health conditions. And she's carried that on in the Senate, where she has been active in leading work on behalf of people who live with mental health and substance use conditions, in addition to the many other things she has accomplished. She's someone who's been touched by the people she knows and loves in this matter. She talks about her experience growing up in a family where that was living with family members affected by these conditions, takes her inspiration from that and has acted accordingly. And I'm a great admirer and really deeply appreciative of her work on behalf of all the people we care so deeply about, people who are at risk for or who live with mental health and substance use conditions. So thank you very much, Senator. And she is somebody who's been recognized for her work and honored by her peers in the National Conference of State Legislators. I'd also like to call out Senator Cindy Friedman, who you all heard about last year in New Orleans, but she was unable to be in New Orleans. Ironically, Senate President Spilka was in New Orleans last year, but not Senator Friedman. So Senator Friedman, since I first met her, which is, I don't know, more than 10 years ago, she has been a champion par excellence for better services, more accessible services for people who, as I said about Senator Spilka, are either at risk for these conditions or who live with these conditions. And she has displayed that in so many ways, and tackling issues at the intersection of the behavioral health system and other systems, particularly the criminal legal system. And she sponsored legislation and is the backbone of something called the Middlesex County Restoration Center Commission, which she's been leading, and I'm honored to co-chair with the Sheriff of Middlesex County, where we are developing a place where police can drop people off, ambulances can drop people off, as alternatives to taking them to jail or to sitting them in an emergency room when they might not need screening for inpatient admission. This is for people who, again, have substance use conditions or mental health conditions, and will be a true point of diversion and an important community asset. She was also critical to the passage of the omnibus mental health bill. You're going to hear more about that in a few minutes, and our omnibus substance abuse bill in the legislature. And both these bills, which she helped in the drafting of, and the Senate President helped in the leadership of the passage of, have left us in a very good position in Massachusetts with clearly defined rights and requirements for people to access care and have adequate insurance coverage for their care. And it's really an extraordinary effort. Right now, she's championing primary care reform and legislation that would also actively promote the integration of behavioral health and primary care, which we all consider to be a critical frontline resource and a way for early identification and intervention to avoid unnecessary disability for people. So I am very grateful to have these two extraordinary leaders here and to have MHA be honoring them. So I thank you.
Senator Spilkey's award's behind you.
Okay.
Senator Friedman would like to start.
Okay. So I am first going to provide this award to Senator Spilka, and then I am turning the mic over after Senator Spilka speaks to Senator Friedman. Okay. So Senator Spilka, please join us. Thank you so much for all you do.
Thank you.
And your leadership and inspiration to all of us. I really, really appreciate it.
Thank you.
All right.
Thank you, everybody. This is wonderful. Thank you. Good morning. And thank you for this incredible honor. I'd like to thank Donna Mausch for that nice, kind introduction, and for your friendship and partnership and steadfast leadership over the so many years. You went back pretty far before I even had any idea that we'd be doing this. So it's very exciting. I'd also like to thank my good friend and champion, as noted in her own right, Senator Cindy Friedman. I'm always honored to share the podium and platform with you. Congratulations, truly a champion as well. And to those attending the NCSL conference, happy conference. Take advantage of it and hope you're really enjoying Boston as well. I've had the honor of serving in the legislature, it blows me away actually, for nearly 25 years. Nothing that I originally planned on doing. Yeah, it's funny in a way. And I'm proud to say now that my office is filled with many awards and plaques that I've been given over the years. But I can safely say, and I know my husband is here, and I thank him for his support. We know that we can't do this without our family's support. Thank you. I can safely say that this award will mean more than most of them to me, because as you know, as mentioned, this issue is deeply personal to mental health as a policy topic, deeply personal. I grew up in a home raised by immigrants' children who worked hard, cared about the people in the community where they loved. My mother stepped back from her role as a social worker in raising four kids One of them, my sister, was born with Down syndrome. My father was a builder and veteran of World War II. My father had a profound influence on me growing up, not always in a positive way. He had severe mental illness and refused to acknowledge it, so the whole family felt it. There was a lot of trauma, but I look back and I do believe he gave me some wonderful, bittersweet gifts. I would not be a state senator, let alone Senate president, but for growing up in that family. As a teenager, I could see that he was struggling, and I often wondered what life would be, his life and mine, would have been if he had been able to acknowledge and receive the services that he needed. Fast forward many years as state representative, and I made a split-second decision to publicly share my story of my family's struggle with mental illness when I was in the State House in a hall of several hundred people giving an award out to an organization that I had done my first local priority, or you may know them as earmarks. It was an earmark in the budget. I was a state rep for not even 6 months, and we were in a recession, but I fought for a funding for a program for the city, then town of Framingham, for their new jail diversion program, a co-response program where the police and a trained clinician, sit in the police car, go out and respond to a situation and divert the person. There were a lot of steps and a lot of setbacks across the way, but as more and more of us have spoken out, and I thank all of you, there's a movement that has grown that is demanding that we all can access what we all deserve: accessible, high-quality mental health care when we need it. As you are aware, everyone has a story. The more I talk to people, the more people come to me, and that's what happened the first time that I opened up about my father in front of those hundreds of people. At the end, people came. I couldn't believe how many people came up to me to say, wow, it's amazing to hear your story. That's my father, or that's my child, or that's my grandparent, or that's my best friend. You know, we've all been aware of this and been intertwined with it. A family member who can't get an appointment with the therapist for months, a child suffering an acute episode, languishing in emergency rooms, waiting for a treatment bed to open up, a friend who is considering a career change due to historic level of burnout. We are not there yet, unfortunately, and there will always be more to be done. But I'm really proud that Massachusetts is now having a conversation about mental health care rather than treating it as an afterthought or silencing those suffering through a stigma and shame. That is just not acceptable. If I accomplish anything else in my 25 whatever years as a legislator, with your help, this will be a joint legacy that I will be happy to say I helped accomplish. And as I said, so I know I'm not the only one who has been in this fight for decades, so I'd like to thank all of you for being on the front line of this fight, and again, for your advocacy and your work. I'd like to thank Senator Friedman and Senator Julian Cyr, who have been working in partnership with me and continue to be mental health champions in the Senate, and all of my Senate colleagues who have made this a priority as well, and our partners in the House. I know I just mentioned burnout, and I believe there are days, believe me, there are days when I wonder, why am I doing this job? You know, Donna has heard that. Cindy, Senator Friedman has heard that. And then I think about my family, and I think about that person's child or friend or parent, and the fact that I am incredibly lucky to be in a position to help move this ball uphill and help it move mental health care in Massachusetts. And it makes my day a little bit brighter, and it gives me the energy and inspiration to buckle up and just keep on going. So when I say thank you from the bottom of my heart, please know that I mean it deeply. And thank you all for your work day in, day out. Thank you.
All right, I would like to welcome Senator Friedman. I mentioned before that she's got a major piece of legislation to reform primary care and how critical it is. She's also embedded in that a number of things that would tweak elements of the 2022 bill, the ABC Act, to make sure that some people who are responsible for paying for care don't squirm out of it. And those are very explicitly mentioned, insurance product by insurance product. It was tedious work, I know you and your staff did, and service by service, including crisis intervention services, mobile crisis intervention services, crisis stabilization unit services, urgent care, in behavioral health urgent care, which we are proud in Massachusetts to have as a service and have since the passage of the 2022 bill. So I could say many more things, but she should speak for herself. Thank you, Senator.
Thank you. Thank you. So I thank you, Donna, for that very lovely and a little bit over the top introduction. I wasn't able to join you last year, but I am so honored to have received this award, and I want to congratulate this year's cohorts, and I want to thank Schroeder and Debbie and the board for inviting me here to speak to you. And thank you to all of you here who actually work in healthcare, in behavioral health. I'm not sure there's a harder job. I'm not sure that in healthcare you find this confluence of people who are desperately in need, but actually their illness is in their head, and the pressures of a system that doesn't know what to do when you really, really need direct patient-centered focus from a provider. And so you do that work, and we are so forever grateful. I wish we could do more to put our money where our mouth is, and make sure that folks get compensated to the level that is really equivalent to the incredible work that they do. I don't have to talk to you about why mental health is important. And it's especially important for children and adolescents. And that's why I feel so lucky to be in Massachusetts. Listen, if you're at all in doubt over the past 9 months about this, leadership matters. And to have a champion like Senate President Spilka in the leadership position that she's in has made those of us who care about mental health so much more effective. Because the one thing we don't have to do is explain to her why this is important. And It seems a kind of little thing, but it is enormous because you're talking to somebody who understands the depth and the breadth of this issue. And having that leadership and that understanding and that fundamental core value that says, however messy this gets, I am in it with you, makes your job and your life so much easier. And when you're with somebody who understands the struggle of people who have a behavioral health issue, it makes your job so much easier and so much more effective. So for all the legislators in the room, your leadership matters. And I hope that you are as lucky as we are here in Massachusetts to have somebody in a position of authority where you don't have to explain to them what's going on. So I need to put that out there. I'd like to tell you that I'm all fabulous and incredible and I can do things and I can, jump high buildings and, run the speed of light, but it's the leadership that matters. And I also want to say that the leadership of our advocates matters. Donna, Fred Ryan, who was my police chief in Arlington, these are people who are there with you every moment and who have the inroads to all of these other advocates and places where they can be the champion. And without that cohort of folks, it's really hard to get things done because mental health is not easy. You know that, right? We have passed a phenomenal bill where we require a mental health check-in, where we require our insurers to pay for community health crisis intervention centers. We've put $200 million into loan forgiveness and scholarships and coverage of licensing for mental health workers. We have a portal for people to go on to find where they can find a bed for a child or adolescent who is languishing in the emergency room. These are all things that we're incredibly proud of. We'll send you the fact sheet if you want, but it's a very extensive bill. But it doesn't stop there. We are fighting with our insurers every single day because they will find a little loophole in a line in a statute and say, well, we don't have to pay for that. We have a system in Massachusetts where if a child goes to a mental health urgent care and the urgent care finds out we can service this child by just connecting a warm handoff to an outpatient therapist, they won't pay for it because it's not urgent care. So that's the kind of, you are constantly working to ensure that people get the care they need. Because as you know, there is no pill. There's no, you don't go into surgery and they fix you and you're out of there. This is an ongoing, every day, for many people, this is a chronic illness. And it means that you got to stick with them all the way through. And so legislation, while we have done an amazing job around parity, as Donna said, we have more language in our next bill because we figured out all the ways that they found a loophole. And so we will keep doing that, and we'll do it for two reasons. One, because mental health matters, because it is every bit up there with chronic health care, chronic heart condition, with asthma, with all of those diseases that we all champion. It's right up there with that. It's exactly on that same level. So we're going to continue that, and we're going to continue it because it absolutely makes a difference for all of us when people get the care that they need. So we're doing it for the patient, and we're doing it for you providers. And we cannot thank you enough for the amazing work you do, for how hard it is, and how you stick in there, even though people are sort of always telling you, oh, it's not that important. It is, believe me. So thank you so much for everything. Thank you, Donna.
Thank you to our hosts, and we are so grateful for our Massachusetts hosts, of course for Donna, and for our wonderful Massachusetts legislators. I'm going to invite Luis Perez up here, and I don't know, is Christian joining you as well? We're going to hear about some fabulous legislators from Connecticut.
Good morning. I am not bright-eyed in the morning. I'm more like bushy-eyed in the morning. Congratulations to our neighbors in Massachusetts. It's so important what you're doing because when all else fails, we can tell Connecticut legislators, Massachusetts did it. So thank you. So I'm here to introduce Representative Kristen McCarthy-Vahey. Although she's recovering from COVID and couldn't be here in person today, Representative Kristen McCarthy-Vahey sent along a brief video, which we'll share in a moment. But first, excuse me, we want to recognize her extraordinary leadership. Kristen is a fellow social worker by training. She brings that same mix of compassion and persistence to our state capitol. Over the last 6 years, the two most significant insurance reforms in Connecticut have focused on mental health access. Kristen was instrumental in both the 2019 parity reform and this year's landmark legislation. I still remember one of the early meetings gathered in an advocate's backyard with Kristen and a Republican legislator brainstorming how to turn grassroots momentum into real policy change. That's who she is, someone who listens, collaborates, and gets things done. This year, with Kristen's leading and the charge alongside our advocates, we brought 1/3 of all Connecticut lawmakers on as co-sponsors of our parity bill. That level of bipartisan support doesn't happen by accident, as you all well know. It happens because of trusted champions like Representative McCarthy-Vahey. And the truth is, without her leadership, this bill would not have become law. We're deeply grateful to Kristen, hope that she feels better soon, and her values and her unwavering belief are part of the partnership that brings mental health care into the forefront. Let's hear from her now.
Good morning to everyone at Mental Health America. I want to thank you so much for the honor and privilege of this award. But most of all, I want to thank the folks at Mental Health Connecticut, the Mental Health Parity Coalition, led especially by Christian Damiana and Dr. Andrew Gerber. They're the real champions. They are the ones who have helped to bring so many of us together. The work to care for and assure that we have parity, coverage, transparency, and accountability is teamwork. It's done together. And the real champions are those who continue to persist through what is an incredibly difficult and challenging time in our country right now. So I want to say thank you very much to all of you for being such incredible partners. Thank you for the privilege of working alongside you, and I want you to know that I will continue to support these efforts to assure that all Connecticut residents and all the residents of our country can have full access to mental health care and treatment to be as healthy, safe, strong, and resilient as they possibly can be. So thank you again, and have a wonderful morning.
We have another legislator, Senator Jorge Cabrera, who also became ill and could not join us today, but Christian is going to be introducing him.
As Senate Chair of the Insurance and Real Estate Committee, George took on one of the toughest fights of this legislative session, and unexpectedly he won. Through difficult negotiations, he got our bill voted out of committee, despite intense industry pushback, and also the opposition from his own co-chair on the committee. And when the bill landed on the Senate floor, George didn't stop. He kept negotiating, bringing along nearly every Republican senator, and also earning support from his House co-chair. Most of all, he did it without sacrificing the heart of the bill. It's a real reform that has access components, it has transparency, and finally accountability for insurers who aren't complying with our parity laws in the state. And he was able to do that through consensus and through bringing folks along. So we're really glad to have George's support in adding real enforcement to our mental health access laws. And we're so grateful that his leadership comes from a personal place, seeing access in his district be nowhere near what it needs to be and deciding to do something about it in our state Senate. So we're grateful for his tenacity, his belief in continuing to do what's right, and we're looking forward to continuing to find common ground in the next legislative session and beyond to get real insurance reform in our state. So thank you to Senator Cabrera.
Thank you to our friends in Connecticut, and we're going to do a little geography neighbor to the north, and it's my pleasure to introduce Representative Amy Roeder from Maine, and she has been, come on up, Amy, she has been a wonderful champion for peer services in her state. And she's been a great friend to Mental Health America. I'm going to hand you the award. We're going to take some pictures, and I'm going to let you talk about your work. Yay. Thank you, Sid.
Thank you very much. I'm delighted to be here. As many of you might know, in Maine, we have several issues facing folks that are seeking mental health care. We're doing a great job in reducing the stigma, but access remains a problem. And my own district in Bangor is one of the epicenters of the opioid epidemic in our state. So there are a lot of challenges. We have staffing shortages, which means that there are fewer mental health professionals in schools. And one of the most recent articles I've seen shows that domestic violence survivors are spending longer and longer in emergency shelters because we have a lack of housing. Everything in Maine seems to be tied together. But there are some bright spots. I want to call out especially the fact that our Speaker of the House had the good foresight to put a mental health care professional on our Appropriations Committee. As we all know, a budget is a moral document, and now ours has a champion of mental health care on that committee. And also, our Assistant Majority Leader in the House is also a social worker, Representative Lori Gramlich and Representative Holly Stover, who is on the Appropriations Committee. I also want to look at the bright spots in Maine. And I'm originally from Minnesota, which means I'm genetically unable to say anything good about myself, so I love talking about the people who are amazing. In my committee, we heard a bill from Representative Christy Matheson, and that provided a rebuttable presumption for PTSD for first responders. We had a provision that was a pilot program. It was scheduled to sunset this October, and the firefighters in particular came to us and advocated for themselves with Representative Matheson's able support. We passed it. It is in the budget. We had such a small budget this year. We were really afraid of budget shortfalls, but we got that one in. Also, mental health care workers at our 2 state hospitals had been fighting to get an early retirement package because we know that perhaps being 65 and working in a mental health care facility that has great physical demands and great demands on your own mental health, maybe you can't last that long. Maybe you need a little bit of an early retirement. And these folks had been fighting for that early retirement for 20 years. And in every year that I've been on the Labor Committee, we were united. Bipartisan support, unanimous bipartisan support to move that into the budget. This year, after 20 years of fighting, it finally got into the budget. And I also want to talk about just the people in Maine that are doing amazing things. We knew that we had an issue with folks coming out of incarceration who were in recovery to secure jobs and to secure housing. One man by the name of Scott Party was fed up, so he bought a house. And then he bought another, and another, and another. And now there are, I believe, 18 Fresh Start Recovery residences, one of whom is my neighbor. And after a lot of stigma in the community, We are all embracing the Fresh Start Sober Living houses as wonderful neighbors. In fact, if you bring them cookies, at least my neighbors, you'd never have to shovel your driveway. I also want to call out the fact that we funded 5 free clinics in the state of Maine. One is particularly close to my heart because I got to volunteer there, Knox Clinic in Rockland, Maine. When a person goes to Knox Clinic to seek that free healthcare, they are also given some time with their mental health care provider, because they know that sometimes people don't know what to ask for when they need it. So everyone is assessed for their mental health care, they're set up with treatment plans, and then they're connected to groups as well. I remember sitting in on a women's group, and the best thing about it was all of the women said, yeah, we're okay. What can we do to help other people? And it became this chain of care that continued throughout the community. I am grateful for what they do there. We are also doing a lot of Housing First funding because we know that a lot of our unhoused folks have mental health care issues that they have not yet addressed. We know that Housing First is a priority, and I'm delighted to say that we are funding that in the state of Maine. Lastly, we almost lost our low barrier shelter in Bangor, Maine. We knew that if our low barrier shelter went unfunded and closed, it would be a cascade throughout the state with catastrophic effects. People I know and love and care about would have died on the streets in a harsh Maine winter. And to all of my legislators out there, please follow my lead as you see fit. The entire Bangor delegation got so annoying that the Appropriations Committee had no choice but to put $7.5 million into the budget to shore up the low barrier shelters. So if all else fails, please tell your Appropriations Committee that you will show up outside of their house with a boom box unless they put that funding in. To everyone who is working on mental health, for my family, for the families of Maine, thank you. Thank you for all you do. I am so deeply appreciative and so deeply honored. Thank you.
Thank you, Amy. Oh, you're welcome. Thank you. You're going to hear a lot. You hear a lot about social workers and about how not only our legislators, but our advocates and everybody in this room, being annoying is our superpower. Hey, where's Heidi? I'm going to invite up Heidi Strunk from our MHA of California, and she's going to tell you about a wonderful legislator who, again, at the last minute couldn't be here in person, but Heidi's going to share some wonderful things she's done.
Good morning, and we'll make up some time for us this morning to share with those who are able to be here in person. I'm Heidi Strunk, the President and CEO of Mental Health America of California. Excuse me. I'm pleased to honor California Assembly Member Mia Banta as our 25 legislator champion. While she's unable to be here today, I will present her with the award once I get back to California. Assemblymember Banta is one of 80 assembly members in California. She's been representing the 18th district of the San Francisco Bay Area, including Oakland and Alameda, since 2021. She serves on 5 standing committees, including the chair of the Assembly Health Committee. She also serves on 10 subcommittees, including the Latina Inequalities and Status of Boys and Men of Color. She also serves on a budget subcommittee, which is #1 Health Committee. Prior to serving in the Assembly, Assemblymember Banta had served on numerous nonprofit organizations. Today, we're specifically recognizing Assemblymember Banta for her work as both chair on the Assembly Health Committee and for sponsoring Bill 489. This bill specifically will prohibit artificial intelligence platforms for representing themselves as licensed or registered health practitioners. As of today, the bill continues through the California legislature with bipartisan support. Assemblymember Bonta, we thank you for your outstanding work and leadership.
Thank you. Thank you, Heidi. Okay. It is my pleasure now to introduce the Colorado folks. For those of you who don't know, even though I work for national and I work in all the states, I actually live in Colorado. So I'm going to invite up Wendy Buxton Andrade to come and tell us about a wonderful legislator from Colorado. Come on up, Representative Puglisi. Okay, there we go. Yes, there we go. The award is ready up front.
Good morning. My name's Wendy Buxton Andrade, and I'm the Vice President of Government Affairs for Mental Health Colorado. Have to use the good old glasses here. Colorado State Representative Rose Puglisi is the first generation U.S. citizen and the first woman in her family to have the opportunity to go to college. She graduated from Villanova University and went to get her JD from St. John's University School of Law. Representative Puglisi is a single mother of 2 children, operates her law firm representing rural counties, and was twice elected Mesa County Commissioner and currently serves as the House Minority Leader. Rose Puglisi has earned the reputation of being an effective elected official by bringing people together with common goals, working to increase transparency in the levels of government, and taking partisanship out of politics to find innovative, collaborative solutions that benefit all of Colorado. Rose has worked hard to improve the health system in Colorado, passing Senate Bill 25-182, the temporary suspension of Medicaid requirements, Senate Bill 23-195, calculations of contributions to meet cost sharing, Senate Bill 24-86, breast cancer screening fund transport, House Bill 1270, Patients' Rights to Try for Individualized Treatments Act, and House Bill 25-1293, Drug Overdose Education and Opioid Antagonists in Schools. Rose Puglisi has been a champion for people over politics, and I am proud to call Rose one of my friends of Mental Health Colorado. She has been a great state leader in helping us to bridge the gap between the parties in Colorado. Rose and I have served together since we were freshman commissioners and have always found a way to support each other in our mission to promote a healthier Colorado and nation. Congratulations to Rose on being mental health champion, outstanding leader.
Thank you all so much. Thank you to Mental Health America. Thank you to Mental Health Colorado for nominating me for this wonderful award. And to my best friend, Wendy Buxton Andrade, for all the work that she does and has done over the last over a decade in mental health and access to healthcare space. So thank you so much. I'm incredibly honored to be here. And an interesting theme maybe is that I'm a conservative. I'm the House Minority Leader, and sometimes it can be a challenge to talk about mental health issues and finding available resources for mental health when you're in the minority, but also making sure that you can get bipartisan support. And so I'm incredibly grateful for this opportunity to talk to you for just a couple of minutes about my experiences, but also to continue to advocate for children and families, and especially veteran services around mental health. addressing the opioid crisis in Colorado, access to fentanyl for our children that are causing devastation in our families. I have been really dedicated since my time as a county commissioner overseeing human services to rural health care and access to rural health care, but especially again for our children and families. I remember a story that really sat with me about a family in rural Colorado, and these children needed to find a home, and they were sleeping on the floor of human services because there was no place for them to go. And so making sure that we have access to resources for children, for families, to keep them safe and help them grow into strong individuals is really important to me. I just want to share a personal story very quickly about my daughter. I went through a high conflict divorce a couple of years ago, which leaves, as we all know, lasting impacts on our children. And when I moved from rural Colorado to Colorado Springs, I thought for sure access to mental health services for her would be easier, right? It's more difficult in rural areas. But what I found was the need was greater in some of these more urban areas, and access to mental health professionals was very difficult. And so while my insurance covered it, I did not, the waiting list was 6 months before she could come to see anybody. And so I've been incredibly dedicated to making sure we understand, and I'm working on eliminating the barriers for more mental health professionals, especially for children in our communities. So it's an endeavor I took on about 2 years ago. We're still not quite there on what the solution is, but I think it's incredibly important that every child and every family have access to mental health services so they can be stronger, and especially within their healthcare plans. I'm a single mom. I work 3 jobs. The legislature is my passion project. But I think, for me, I have the ability to pay private pay so that I don't have to wait and have my child on a wait list. Not everybody has that ability. And I think it's incredibly important that we continue to take away those barriers to access so that our children and families can be strong and safe. So thank you so much for this award. I'm incredibly honored, and I really look forward to continuing this work with all of you, not just in Colorado, but throughout our country. Thank you.
Thank you. We think that the pictures are really important too. We really do. And it is our pleasure and our privilege to see them in legislators' newsletters. So for everybody who's getting an award today, when you put it in your newsletter, we would love to see it. So drop me a line, Debbie Plotnick at mentalhealthamerica.org, MHA national.org. Thank you. I got to remember our new. It's been a few years, hasn't it? Anyway, drop me an email with your newsletter. We love to see your pictures in your newsletters. Okay, now I have another privilege. So I'm about to introduce the antithesis of the social worker, and I mean that in the best possible way. Representative Michael Bergen from Iowa. I've had the great privilege of working with him on a number of task forces over the years, and I love that he is dedicated to mental health throughout his career. He'll tell you about it, and also just quietly moving things along, unlike some of us that are a little bit out there. Michael, come on up, please. Let's get that picture. Look at Sid. Thank you.
Well, thank you so much, Debbie. Thank you for Mental Health America for this honor and mention. I've got a few notes to mention. So many people, lives affected by mental health can point to a date and time or an episode, a time and place that starts their advocacy, starts their role in making a difference. My date's January 6, 1997. It was a date that I sat down as a newly elected county official, and we were choosing committee assignments outside of our board work. The first committee was a Department of Human Services Advisory Committee. There's 5 members. Well, what's this do? Well, no one really know. The person that served on that was no longer serving. And my comment was, I don't know anything about Department of Human Services. I'll do it. And within a few minutes, I was serving in the Department Agency on Aging, our county county home facility with a residential care facility, and then our community mental health. And it's been a journey. My background is as an accountant. I didn't come with this with a personal attachment. I came to it as a funding responsibility and a policy development, and I've become a policy wonk in the area. So for the last 28 years, it's a continued path. After 8 years in county government, I served 12 years in early childhood, and now at 9 years in the state legislature. I don't need to talk to you about mental health and explanation, but one of the things that I hold foremost in my sights as I work in this area is recovery. There is recovery from mental health. We need to find the pathway. It's a long and tenuous struggle, and it's often accompanied by substance use, whether it's tobacco, alcohol, medications, that we need to look at them combined in a process. I'm going to note just a few of the challenges or frustrations that I see that we need to continue to work at as we look at addressing the issue as it comes to us as legislatures. It's often around one of them, a crisis situation, where we're putting a lot of public dollars at the forefront to overcome a crisis, whether that's law enforcement's involvement, emergency room at the hospital, that commitment process with our judiciary, that immediate critical care that's done. And we need to change that focus to prevention and early intervention and a long-term recovery aspects to reduce those aspects. And I think we're making progress in that, but that still becomes the focus, that attention point. Second frustration or area concern is that we tend to look from the public funding perspective of it's Medicaid. We're looking at how we're dealing with the impoverished people in our communities that we're funding with Medicaid or with government services. When mental health and substance abuse issues affects the whole population, regardless of your economic background, and it's something that's across the board. But our policies is looking at one sector, and I think that we fall short when we don't look at a broader perspective. And that it reminds us we need to step back and look at some of these issues. A third area is how we treat children and adults and the transition between the two. Children are certainly not small adults. They need different treatments. They need different supports, and they go through a period of transitions to adulthood. But then as adulthood, we have some challenges. So we need to be mindful of that, how our systems and bureaucracy get set up to pocket those and silo them, and then we got to have a better, smoother curriculum, continuum of care. And I'll make a couple of comments that I see about working as an advocate with policymakers. I'm going to use what I find to be a really rude word, and that's ignorance, but I think that it is so appropriate in that I deal with 100 representatives in Iowa, and we've got fewer than 10 that are informed
on mental health and the impacts, the ignorance abounds, and that's the barrier that we need to overcome in advocacy. And we can do that in a couple different ways. One is to those personal stories, but I think personal stories or an individual representative's background and experiences that drive a number of activities. I mean, that they have priorities there and experiences that they're adept in, public safety or agriculture or education that they're championing, that they're working on, and they need a broader perspective. They bring their own small biases, and we just need to broaden that perspective. They talk about two sides of a coin, two sides to every story. And as we look at complex issues, they're multifaceted. They're gems with many different facets of perspective. And we need to get back and take in the whole picture. And so to do that. And one way to overcome, I think, that ignorance is to help identify a colleague in the chamber that is a champion, that is that you can support that idea or that amendment. And I think the second aspect is to make sure, to realize that just like recovery, this is a long process, and we've got to take those wins and make those steps on that path to recovery and in an incremental process, and recognize those and acknowledge those wins and continue to move the ball, because we can't fix it all at once. Even major legislation that makes a difference, you're following up the next year with the tweaks and the technical corrections. And so we need to take those processes. And so I encourage you all in your work, in your advocacy with the policymakers, in your work with individuals, and then on your own path to recovery. I wish you well, and thank you for your acknowledgement today.
Thank you. We're getting into the home stretch, folks. It's with great pleasure that I now introduce Carrie Blumert from our MHA in Oklahoma. And she's the new executive director. It's our first time meeting her. And she's got some wonderful legislators, another one of which I've had the great pleasure of working with on some task forces. But she'll tell you more about it. Come on up.
Thank you, Debbie.
You bet.
Good morning. My name's Carrie Blumert, and I am the new CEO of Mental Health Association Oklahoma. How many of you have seen the Broadway show Oklahoma? Okay, good. It looks a little different than that now, but. So we have 3 legislators that we have recommended to receive this award. 2 of them could be here today. And a lot of what we do at Mental Health Association Oklahoma is provide housing for people living with severe mental illness and provide street outreach teams to go connect with people who are experiencing homelessness and get them into supportive housing and treatment for hopefully for long term. And so each of these legislators have supported bills that help tenants and help people seeking mental health care. So I am going to talk a little bit about Representative Pei, who you'll get to hear from in a moment. And then I think my friend Debbie is going to talk a little bit about Representative A.J. Pittman, who is also here with her mother, former Senator Anastasia Pittman. And so I know both of them from my time as county commissioner. Where's my Colorado county commissioners? And so I also transitioned from serving as an elected official to now my dream job at Mental Health Association Oklahoma. But Representative Daniel Pei is the chair of the A&B Human Services Subcommittee, the vice chair of the Children, Youth, and Family Vice Chair of Children, Youth, and Family Services Committee, and he's also a member of the Health and Human Services Oversight Committee. So some of the legislation that he has introduced, particularly in the area of affordable housing and helping renters. Senate Bill 128, which unfortunately was vetoed by our governor this year, but I think this will maybe come back again in the future, but it would have extended the eviction timeline from 5 days to 10 days. It would have extended the timeline between an eviction filing and someone's court date. We have one of the quickest eviction timelines in the nation in Oklahoma. So once you are served your eviction, you have 5 days to make it to court. It's a very, very quick turnaround, and so that bill was trying to make it 10 days to give tenants a little more time to stay housed. He also introduced Senate Bill 275, which created the Oklahoma Workforce Housing Commission to implement plans for the expansion of affordable housing. He also introduced House Bill 2015. This bill would have held landlords accountable for damages and provided tenants with additional options for recourse, including protections from landlord retaliation. He also helped pass Senate Bill 251 related to mental health and substance abuse services, expanding the services eligible for funding under a line of funding we call the County Community Safety Fund. The expansion included funding for mental health services and substance use jail intake screenings, as well as jail reentry programs. And then this year, he has worked on getting an interim study approved to address youth homelessness. This study will evaluate current outreach efforts, identify underserved regions, and develop actionable strategies. And I believe this is part of a fellowship that Representative Pay has involved with NCSL. So I'm going to have Representative Pay come up to the microphone, and then I think I want Debbie to help introduce Representative Pittman.
Thank you, Carrie. Good morning, everyone. I am honored to accept this year's Legislative Champion Award from Mental Health America, and I want to sincerely thank MHA, the Regional Policy Council, and especially Mental Health Association Oklahoma for your tireless commitment to our fellow Americans. This award is incredibly meaningful to me, not just because of what it represents, but because of who it honors. It's ultimately not about one legislator or one piece of legislation. This award belongs to the advocates, outreach workers, peer recovery specialists, and mental health professionals who show up every single day, often without recognition, to care for others. I dedicate this award to all the folks on the front lines who listen without judgment and who never give up on anyone. As a co-chair of the Mental Health Caucus and chair of the Appropriations and Budget Subcommittee on Human Services, I've learned that empathy and compassion are not just good qualities in a person. They're essential ingredients in policy making. That's why I authored House Bill 2012 this year to continue harm reduction services in Oklahoma, because mental health policy should meet people where they are, not punish them for where they've been. I worked with the team at Healthy Minds Policy Initiative on this bill, and since 2019, Healthy Minds has been a leader in Oklahoma on addressing policy challenges around mental health. Their research estimates that 1 in 4 Oklahoma adults, that means about 768,000 people, experience mental illness, and 584,000 have a substance use disorder. That scale demands both compassion and long-term strategy. Mental Health Association Oklahoma understands this better than anyone. Their work, by offering housing, peer-led support, street outreach, advocacy, and recovery services, is rooted in the belief that everyone is worthy of dignity and care. They don't just treat mental illness, they support the whole person. And they do it with grace and grit, day in and day out. In Oklahoma, we're also seeing leadership from our tribal governments and nonprofits. They're developing culturally responsive care, expanding access, and filling critical gaps. They're stepping up, and we must keep showing up for them as well. Empathy is powerful. It breaks down stigma, it builds trust, it creates space for healing, and we need more of it in our policies, in our communities, and in each other. Showing your vulnerability to others isn't a sign of your fragility, it's a sign of your humanity. Thank you again for this incredible honor. I accept it on behalf of every frontline worker and advocate who inspires me to do this work. And let's continue to lead with empathy. Let's continue to fight for a mental health system that sees, hears, and supports everyone. And let's remind the world that compassion is not a weakness, it is a strength. Thank you so much.
You want to do the word? AJ, come on up. Yeah. Okay. Carrie's going to hand Representative Pittman her award, but I just wanted to say that it's been my great pleasure to work with her on a number of national legislator task forces, to listen to her speak, to see the wonderful mental health bills that she has put forth over the years, and her deep commitment to the people of Oklahoma and the understanding of how important culture is to the people and how that always shows up in your bills. And we'll be hearing more about the importance of culture a little later. I'm going to get off the stage so that we can hear from the representative.
I know it's early, but good morning. It is such a pleasure to be here with you today. Like she said, I'm State Representative AJ Pittman. I am a proud member of the Seminole Nation of Oklahoma, so I greet you and say Ishtango, which is in my native tongue, hello. Mental health is something that has always been in my family. I was born to someone who gave me her face, her name, and her job. God has jokes. But she was a longtime mental health provider, educator, and advocate. And so this is something that I have been passionate about for a very long time. I am deeply honored to receive this recognition from Mental Health America. Thank you to the Regional Policy Council. Thank you to Debbie and the MHA team. They do such amazing work, and they keep up with all the work that we do as well. And that is just a testament to their commitment to service and serving our communities. I had the pleasure of serving on a national task force that was created and convened by SEED, as well as CSG, with Debbie and my good friend, Miss Madhuri Jha, who's also a board member of MHA, who had to leave early. But I want to thank her for introducing me to this amazing organization. But we got to serve on this national task force where it convened providers, family, stakeholders, legislators, mental health workers to talk about mental health policy, disability policy, whether it be in rural communities, whether it be in barriers. And out of this task force was a framework was created that is now a living document that educates other elected officials on the information that we study, provides them the data, but also provides them legislative changes that could help reshape our communities as it is for mental health patients, as well as people who have disabilities. I want to say thank you to the practitioners in the room, the advocates in the room, and the families who are on the front lines of mental health every single day. This award means so much because of the legislation we are being recognized for. House Bill 3836, also known as Handle with Care, was not just about policy, it was about people. Handle with Care was a bill that sought to create a statewide system for law enforcement to send a note to a child's school if they came in contact with them in a traumatic situation, so that those providers, those educators, those school counselors, those school nurses, those school resource officers could handle that child with care. Not telling them what the situation is, not giving them any detail, but saying their homework may not be done today and we don't need them penalized. Saying their house could have burnt down and they're in different clothes today and we need to show them some compassion. And so that bill was so important because we have so many children dealing with trauma. We have so many kids navigating that. And we wanted to make sure that not only our law enforcement was able to do that, but that also it gave the school an opportunity to provide wraparound services in those emergency situations. It was about children in our classrooms whose trauma too often goes unseen, and the teachers and school leaders who are expected to do more with less. It was about creating a bridge between law enforcement, schools, and mental health professionals so that when a child is impacted by violence or crisis, we respond with compassion, not punishment. I have seen firsthand how trauma shows up in our babies, how it ripples into our communities, and how ignoring it creates long-term barriers to learning, health, and opportunity. This work is personal because sick kids can't learn and sick people can't earn. However, I know that when we lead with empathy, and legislate with intention, real change is possible. So to my colleagues who also won this amazing award, congratulations. To the staff, to community members, and especially to the advocates who helped me with Handle with Care, I say thank you. This award is yours too. I accept this honor on behalf of the constituents of House District 99 for allowing me the privilege to serve them each and every day. I also accept this honor for every child in Oklahoma who deserves to feel safe, seen, and supported. May we continue to build a future where trauma is not a life sentence, but a call to action. Thank you so much.
Thank you, Representative Pittman. Congratulations, and thank you, Representative Pei. Congratulations. Our final person, I think, being recognized today, almost final. Final person from Oklahoma is Senator Julia Curt, and she could not be here today. She is our Senate Minority Leader. And I met Senator Curt almost 10 years ago in a basement during candidate boot camp. We went through training on how to run for office together. And we became very, very good friends. And she will pick up the phone anytime I call, and she fights so hard for her constituents, and she fights very hard for people who are forgotten about and don't have access to what they need. So I was disappointed she couldn't be here today, but I believe there is a short video introducing Senator Curt.
Thank you so much to Mental Health America for this 2025 Legislative Champion Award. It means a ton to me. In Oklahoma, we're working really hard to find bipartisan solutions. No matter the political spectrum that people are on, trying to make sure that we find those things we can agree on so we can make progress. I've worked really hard around housing and that intersection with mental health and homelessness. Thank you to Carrie Blumert and the Mental Health Association of Oklahoma for this nomination and for their hard work, because your direct work for people matters, and we'll keep trying to find those policy solutions that are going to solve those deep challenges for folks. Thank you, thank you, thank you.
Thank you. And alphabetically last, and certainly not least, is Senator Craig Deeds from Virginia. And sometimes it takes us a while to get the legislators to come in person. We had to ask Representative Pittman a couple of times. She was supposed to join us a couple of times ago. And the same thing for Senator Deeds. And we really wanted to offer the opportunity to our just retired, and boy, we're going to miss him, Executive Director of MHA of Virginia, Bruce Cruiser, and from Renee Norden from Fauquier County, and because of Bruce's retirement, he's off having fun, and Renee was unable to be here. But they have a video introduction, and they're going to talk about the amazing things over many, many years that Senator Deeds has done, and why we are so thrilled to have him here in person today. Please come on up, and please play the video. Where's our video?
Good morning. I'm Bruce Cruiser, the recently retired Executive Director of Mental Health Virginia, representing Heather Orrock, the new Executive Director, and myself. Unfortunately, neither of us could be with you today in person, but we're excited to say a few words in support of State Senator Cree Deeds. Currently a resident of Charlottesville, Senator Deeds has served over 30 years in the Virginia legislature. He is arguably the most effective legislator in Virginia, having passed more bills than any other member of the Virginia General Assembly. After losing his son to mental illness in 2013, Senator Deeds dedicated his life to reforming our broken mental health system. He fought to establish the Behavioral Health Commission, implemented mobile crisis services, and he achieved historic comprehensive investments in community mental health services. Senator Deeds and the Commission have addressed some of the most challenging issues of the decade, including restructuring the entire system of services and funding. Solutions may take several attempts, but he never gives up or loses hope, and he keeps everyone trying until they find what works. His life-saving work has earned him recognition nationally as a foremost champion for mental health reform. And last year, Mental Health Virginia gave him our Lifetime Advocacy Champion Award. He has inspired many by turning his pain into action and advocacy for people living with mental health challenges. We are proud that Mental Health America is presenting Senator Cree Deeds with this award.
Senator.
I've only got about 45 minutes to talk. I apologize. Thank you for this honor. I'm touched and incredibly honored. My wife, Siobhan, back there is do part of the credit. A whole lot of people, you don't accomplish things by yourself. Anybody that knows the legislative process knows that. You've got to build bridges to people. The only thing I will say is that we have to remember that our focus has to be on the person in crisis or the person who's ill. Our focus can't be distracted by the jobs that hospitals provide or by the people who respond to the crisis. Our best investments are those that are made to keep people out of crisis in the first place, to keep them healthy in the communities in which they live, and that's got to be our focus the whole way along. Thank you so much for this honor. Have a great day.
Thank you so much. Thank you. Okay, all of them, they're fabulous. Let's hear it from them. What you got? Yeah. What you pointing at? Me. I am. I'm going for it. Okay, you're going to hear from me all day long. But who we really want to hear from now, please help me welcome not only our leader, our beloved leader at Mental Health America, Schroeder Stribling.
Well, thank you, Debbie, and thank you all. Wow, what an inspiring morning so far. I just have loved hearing from all of the awardees, the remarkable work that you're doing in your communities. Many of you know, as a social worker myself, I have spent most of my career on the ground working in community-based solutions for mental health and for basic community needs for well-being. And I just am so inspired to see all of the good work that's taking place, and so grateful that we have the opportunity to honor and uplift all of this good work here at the Regional Policy Council. So I only wanted to offer a few brief words of welcome and of gratitude today. I had the chance to visit with many of you affiliate leaders last night over some excellent Boston seafood. I think we can agree. That was great. Thank you very much. And as usual, it was really inspiring to hear about the work that all of you as our affiliates are doing across the country in your communities, from warm lines to supported housing to day centers and arts programs. You are a determined and committed and creative collective, and you're really innovating to drive community-based solutions and improve the mental health of your entire regions, and that's where it's at. So we are so grateful and inspired and honored to be in that work with you. And to our Regional Policy Council leaders from MHA, thank you for your continued advocacy. You've really made our RPC the place to be, and it's great to be here with all of you and with all the advocates and champions that you have assembled. And again, to our partners, the elected officials and public officials, we really honor your commitment to public mental health. Your efforts to uplift your communities, you know, are vital, and we know are vital. And not only are you changing and saving lives at the local level, but you're also providing an example for the rest of the country. And that is so important, and that's a large part of the work that we do here at the RPC, is to lift that up. Lastly, a huge thank you to our Mental Health America staff, to Debbie, our stalwart leader for RPC, and to all the other staff of Mental Health America, Alicia and Catherine and Sid and Susan and Stuart and all of those who make this day what it is. We are grateful for your contributions. So today we're focusing on a core issue for Mental Health America and for all of you, which is ensuring and expanding equitable access to care. Your dedication to that, to access to care across the immediate needs, crisis needs, prevention needs, recovery supports, all of that. And we heard all of that in what you had to say today. You're working on that across the country, from Maine to Colorado to Oklahoma to Iowa, Virginia, Connecticut. It's really inspiring. And it's never been more vital or more urgent than it is today. We know that in this country, nearly 60 million adults, over 23% of the population, experience a mental illness during the course of a year. And yet we also know that less than half of those receive the treatment that they need. More than 122 million people are currently living in areas with professional shortages. We heard some of that, the impact of some of that this morning. So in those areas, we know that just about a quarter of the needs are being met. Even people with mental health, with insurance, face barriers like provider shortages, high out-of-pocket costs, ghost networks, long wait lists, especially in rural communities and especially for marginalized groups. So as you know, the need for your access and your creativity and your advocacy is clear. The burden of these untreated mental health conditions is impacting not only those families and those individuals, but also all of our communities, as you are addressing. Your work is rewriting the story for millions of Americans. Rewriting the story. You are ensuring that mental health is not just a privilege for some, but it is a right and a reality for all. And it feels incomplete to leave the moment without acknowledging that we are all touched by this issue, and I am touched by this issue, by access. I know we all come here today with our stories from our work, our careers, and our stories from our own hearts and our own families. My family has been directly affected. My father, who died young, for him, access to real mental health support could have made a difference, certainly a difference in the quality of his life. But in the 1970s, now a long time ago, all that was offered to him was a very harmful conversion therapy, which really deepened his own self-contempt. For myself and for the younger generations of my family who have lived experience, finding help that is both effective and that is dignified has been a challenge, even for me, with the connections and the resources that I have. So none of us have to look very far in the web of people that we love and that we know and that we work with to know that we are all affected by this. This is an equal opportunity issue, and we are here to ensure that we have equal opportunity solutions. So I'm very grateful that we are not alone. We are together in this challenge and in this fight. I'm glad to be here with all of you. I thank you. It's an honor to see the work that's being done and to be in a room of such inspiration and commitment. I thank you for your unwavering commitment, and on behalf of all of my board and staff colleagues, I welcome all of you to this Regional Policy Council, and I wish for us yet another inspiring day as we move together forward. Thank you.
Thank you, Schroeder. Whoops. Thank you, Schroeder. We have heard about wonderful things happening in the states, and of course, we have to pay attention to not only what's happening in the states, but what's happening federally, because they go hand in hand. What happens in one place affects some things that happen in the other places. So we have invited my colleague, Mary Giliberti, who is our Chief Policy Officer, to talk a little bit about what's happening federally and how that really affects everyone in this room and the work in this state. Mary?
Good morning, everyone. Those of you who know me know I've been doing this for a very long time, so Debbie decided to set me a new challenge. Could I summarize 6 months worth of federal policy in about 10 minutes? I accept the challenge, and here we go. I'm going to be highlighting mostly things that our continued advocacy is needed, because there's just a lot to talk about. And I'll be here all day, and as you know, I'm a federal policy wonk, so if you want to ask me any questions, you'll make my day. So let's start with what's going on in Congress. I have to start with a heartfelt thank you. More than any time in the 3 decades I've been doing this, do Congress folks want to hear from people in their districts and in their states? And you all have stepped up amazingly. I mean, we have done so many visits, calls, emails, you name it, and you all have really worked with your networks, and we could not be more grateful, because we could not do this without you. The reason Mental Health America is a powerful force in federal policy is all of you. It's the only reason. They don't want to talk to me, except that they know that I talk with you. So what has gone on? You might say, hey, Mary, but they did pass the big bad bill, and they did, but I want to remind everybody that we did not get a block grant for Medicaid, and that would have been catastrophic, and it didn't happen, and there was lots of conversation about the need for Medicaid, more so support for Medicaid than I've seen in a long time. Now, there will be cuts, and I think that's an area of continued advocacy for all of you at the state level. We know from the changes in provider taxes, state-directed payments, and I can explain all of that in more detail for those who want to hear it, but there will be cuts at the state levels. So we need to be vigilant to make sure those don't fall on people with mental health and substance use issues. I want to highlight the work requirements for a minute, because that affects the expansion population and has the potential to kick a lot of people off the program. Due to language that my colleague, Tim Clement, suggested and was accepted into the bill, states have to use their data to figure out if people are exempt. I'll say that again. States have to use their data to figure out if people are exempt.
That is really important. We have exemptions for people with substance use conditions, with disabling mental health disorders, in substance use treatment. Those 3 exemptions, they have to use their data. So if you're a data guru or you know one in your state, please come talk to us. We are going to be doing a lot of work on technical assistance to how that exemptions can be used and what data can help. Tim and I are on a mission to make sure we keep as many people on Medicaid as possible, and we really need your help to do that. With respect to appropriations, we all need money to do this work, right? We had good news last week. The Senate reported out their appropriations bills. We saw either level funding or slight increases, including to mental health research, which you may recall the president's budget really decreased. So the Senate bill was very different than that budget. In a welcome way. And SAMHSA, the Substance Abuse and Mental Health Services Administration, was allocated resources. It was not put into a new administration for a healthy America. Now, whether that will hold ultimately, we don't know. That's just the Senate bill, but it was, again, a positive result for us. We're waiting on the House bill. We think it will likely be not as good news, and then what will happen in September. At the end of September, we'll either have a continuing resolution. That means all the money stays the same from last year. We could have a shutdown. We could have some bills. Nobody knows at this point. So stay tuned. Advocacy, we will be asking for more advocacy on appropriations. The administration, and then there's a question about whether there will be a bipartisan health package. If there is, all the bills you've heard us talk about, whether it's ghost networks, early intervention, safe step back to improve access to meds, we will be fighting to get that in. It's like a feeding frenzy to get your bill into the bipartisan package, and we will be in there working with all of you if that comes to pass. And again, nobody knows at this point. The administration has been issuing some guidance and executive orders. There's no way I can cover all of them. I will just touch on a few. The one a couple weeks ago on homelessness, mental health, and addiction. I think that's something to pay a lot of attention to in your states. It talks about commitment statutes. That's generally a state issue. It also criticizes some programs, evidence-based programs that we've already heard about, Housing First, harm reduction. So there'll be a lot of opportunities in states to educate on these programs. As of yet, we just got the EO. We haven't seen it yet conditioning federal funds on some of this, but we're going to keep our eye out and certainly educate you if we see that going forward. The other guidance that came out, and this one you might not have heard about, was from the Department of Justice on civil rights. And I really want to urge all affiliates to review that with their legal counsel. As some of you know, I worked in the Office of Civil Rights. These are not interpretations that are consistent with decades of civil rights law, so it's very important to read them and to understand them. And they criticize or suggest that some words that we commonly use, like cultural competence, like lived experience, cannot be used as a proxy for race and ethnicity and other, in their view, impermissible classifications. So that doesn't mean that we can't continue hiring peers and things like that, but you will want to talk to counsel about how to phrase things so that they're clear that these are qualifications for jobs. And so I just want to urge you to review that. There have been, a MHA report, Make America Healthy Again, that was issued. It had some really helpful discussions of early intervention, prevention, social media, which were very consistent with positions we've taken. It also raised some troubling conversations about children and access to treatment, particularly medications. As of yet, that has not translated into policy. We're expecting another report out in the coming weeks, and we'll certainly keep you updated, and we're keeping our eye on that as well, really trying to focus on behavioral health integration, which we've heard a lot about, as a way to make sure there's more access, not less, right? And there was encouraging news I want to point out in the physician fee schedule rule. So and anybody know what the physician fee schedule rule is? That is a 2,000 plus page regulation that I have the great privilege of reading every year. And it lays out the payment for Medicare. And why is that important? Because Medicaid and private insurance often follow Medicare. So what did it do that was helpful? A couple things. It adopted some behavioral health integration codes to add on to its advanced primary care case management, had lovely language about how important behavioral health integration is. That was great to see out of the new administration. It also changed the way they're valuing services, and this is probably one of the most important things. The American Medical Association sets the prices through a valuation process that then CMS usually adopts. What that means is kind of the fox guards the henhouse, and they generally favor specialists over behavioral health care and primary care. For the first time, we've been trying to talk about this. People have been trying to break the AMS lock on this for decades. The administration said, we are going to look at other data. We are going to question these procedures that cost so much, and that it's a zero-sum game, so that frees up some money for primary care and behavioral health care. So we are in favor of that big change. So those are the positive things, right? So we have to look at what's positive too. I will conclude, because again, I'm racing to get done, with parity. I know my colleague Donna is going to talk about state parity work. So just leading into that on the federal side, there was a regulation that came out during the Biden administration. The employers, through their trade association, EPIC, challenged that regulation in court. The administration said, please pause the litigation because we are going to make changes. They said they might modify the rule, they might do a notice of proposed rulemaking again. So the litigation has been paused. There will be continued filing, so we're watching that. And of course, if there's an opportunity for comment, we will be back to you to do the same thing we did last time, which was generate thousands of comments about the access issues you all have heard about today. So that's my wrap up. I'm pretty close, right? Pretty close. Wait, should I end there? Do you have time for questions? No. Okay, find me for questions.
We knew she could do it. And Mary's going to be here all day for, when you really want to get wonky. She loves it. Speaking of wonky, Donna Mach is going to come back up, and she's going to dig into parity again at this state level. And I appreciate everybody's patience. And after Donna speaks, we're going to take a little break. But welcome back, Donna.
Thank you.
Yeah, absolutely. Let me get better your way.
Okay, thank you, everybody. Oh, yeah, great. Let me see which way it goes. Okay. So, good morning again. I'm delighted to be here to speak about parity, which is something that the Massachusetts Association for Mental Health has had a long commitment to advancing, and we had exquisite assistance from the two legislators who were honored here this morning, Senator Spilka and Senator Friedman, but we have a long list of people who've been a champion in Massachusetts. So this is just a brief agenda of what we're going to talk about, some of the historical parity events in Massachusetts, what is happening now in Massachusetts with health insurance benefits coverage. More importantly, as we've learned, the need for a focus on parity enforcement initiatives, consumer protections, and an outstanding and as yet unaddressed, and probably underlying most of the problems in our care delivery systems, the behavioral health reimbursement rates, which have not yet been made whole and equal to those in other areas of healthcare, and a few comments on implementation. So Massachusetts Association for Mental Health actually filed a case. We were the complaining party in a case that went up through the courts in Massachusetts in 1982. It was against Travelers Insurance, who was denying access to basic outpatient mental health care for their covered lives. And that case went up through the courts in Massachusetts, affirming the complaint and the right that insured persons had to an outpatient benefit. So this was early days, but really they were covering inpatient care, but arguing about any outpatient care at all. That case was challenged and appealed by Travelers Insurance, which I dare say had a lot deeper pockets than the Massachusetts Association for Mental Health. We were very fortunate to have a private law firm providing pro bono help to us, and Tom McGuire, whose name those of you in the room who are behavioral health economics junkies would know, he cut his teeth on this case as doing the actuarial work and the demand analysis for the case. It was affirmed by the United States Supreme Court in 1983, establishing for all insurance plans a base of 10 or 12 outpatient visits a year. Again, very basic, but a beginning. And then again in 2000, we came back after the Kennedy-Katzenbaum Act, which at the federal level began to address parity issues, with Senator Kennedy as our United States Senator representing the state. We'd always had a close collaboration with the senator and his staff, and we filed and passed the first Parity Act in Massachusetts in 2000. In 2008, we went back at it, recognizing the advances in the federal Mental Health Parity and Addiction Equity Act. And then in 2022, the omnibus bill that Senator Spilka and Senator Friedman spoke about today, which is, by the way, over 200 pages long. I'd happily send it to any of you. It covers a lot that you can only imagine. But this act addressing barriers to care underscored everything in the Affordable Care Act and actually went further in Massachusetts. It went further in, here we go, sorry, in several important ways. It required both our Medicaid division, the Mass Health Program, and Division of Insurance to regulate commercial plans. Mass Health had a very robust behavioral health benefit, but commercial plans did not. So in addition to the core requirements of parity, it called for an annual mental health wellness examination with no mental health cost sharing, which is really critical to early identification and intervention. That was to be provided, and it called for coverage of collaborative care and evidence-based practice for integrating behavioral health in primary care. It also established in the private insurance sector what we had long provided to our state employees' families, which is coverage for dependent persons who are over 26 years of age. Most insurers would let you carry, your kids till they're 26. You can carry a disabled family member beyond the age of 26 on your insurance plan. It also covered some intensive community-based treatments for children and adolescents that the insurers had been resisting covering, and it required the private insurers to pay for the first time for medically necessary emergency services, including mobile crisis intervention and acute crisis stabilization services. It also, not on this slide, required them to cover urgent behavioral health care, and it set up a financing structure to do that. Parity enforcement, since that law passed and since all of the parity laws passed, has really been our challenge. Our Department of Insurance was really slow to take up what were actually required duties under Chapter 177 to regulate and enforce parity among all of the insurance carriers in the Commonwealth. It required the Department of Insurance to actually submit an annual summary to the legislature of their work, and because we recently reviewed the 2022 and 2023 reports, which were nearly identical except for the change of the date, sadly, they were late in filing those and have been really slow to do much. But we have a new commissioner of insurance and a new associate commissioner of insurance who have more of a focus on behavioral health care, and we are hopeful that more will be done. It does require the Department of Insurance to perform behavioral health parity compliance examinations every 4 years, but if there is a complaint filed about a parity violation, they're to actually do that examination within that same year. And it requires them to evaluate any complaints within 90 days. there's a complex methodology, which I won't go into, but I'll have some notes in the next slide, for how to review and analyze compliance with federal and state behavioral health parity laws. And our law requires that there's compliance with both federal and state laws to the extent that our state law, in some cases, exceeds the requirements under the federal law. And it's a detailed analysis that breaks down treatment authorization data that looks at the rates of penetration. That is, how many people in the population are using or have had access to a behavioral health service, and to provide discrete data on the number of days for each type of covered service, and how many days, what has happened with the requests associated with that care, what's the percentage of care that's been authorized, modified, denied, or appealed. Now, this is all data that the insurance companies have, but they weren't voluntarily sharing. And also tracking the number of consumer complaints. And finally, they need to provide information about what corrective actions they've taken with the plans. All right. There are non-quantitative treatment limitations you might be aware of in the parity legislation. And these get at those tools that insurers have used too effectively over the years to deny people access to care, and distorted in their application to be different than the way they apply them when it comes to other healthcare conditions, like prior authorization. Often imposing prior authorization on behavioral health services when they would not be imposed on any other healthcare service. You do not have to have prior authorization if you're in an emergency room having a heart attack to be admitted to a bed in a hospital to be treated for your cardiac condition. In many places, you have had to have prior authorization while you're waiting in an emergency room to get into an inpatient psychiatric bed. This is a violation of the law. I'm not going to go through every one of these, but they're often used. Step therapy, requiring people, we have some folks here today who are very familiar with the abuses of step therapy, and I'm sure many of your states have had legislation requiring people with mental health conditions to go through a number of medications, whether they might work for them or not, in order to get to the one that their physician knows best to prescribe for them. So we're trying to get at all of this stuff in the Massachusetts law to track it, document it, and expose it, and further expose denials of authorization, payment, and coverage. So there is a grievance process that each carrier is required to establish internally that would allow people to request the appointment. It's very difficult to advocate for yourself, and as many people in this room can attest, even with the experience all of us have, to help someone through the complaint process. In Massachusetts, an individual can request the appointment of an authorized representative to act on their behalf in the appeals process, the grievance process. And it sets out notice requirements that the plans have to provide regularly to the covered members of their plans, to lay out for them what can be done with an expedited review process when there's a denial of coverage. It requires an Office of Patient Protection, and that office has developed a process for referring matters back to the Department of Insurance and to the Office of the Attorney General for compliance violations. And the OPP is required to monitor denials and identify any trends over time. So they too report to the legislature trends over time about the violations and the nature of the violations. With all of that, sorry, I'm having a try. I don't know if the batteries, oh, there we go. No? Okay, I'm going the wrong way here. Am I supposed to be pointing this somewhere else? Yes, okay, got it. I'm sorry, I'm an idiot with this stuff. There we go. Okay, so I would, the big thing in parity that is not yet addressed, and the place where plans continue to make a lot of money at the expense of the care of the people we advocate for, has to do with the reimbursement rates. And by and large, these have been haphazardly addressed. That's the nicest thing I can say about it. But effectively, even in a state like Massachusetts, which has a high per capita number of licensed professionals and is considered to be a relatively strong system with relatively strong access, we have a huge access problem. Why? Because more than half of our licensed providers choose not to take insurance. They are therefore unavailable to people, as was said earlier by one of the legislators who spoke. They are unavailable to most people who cannot pay out of pocket. They cannot even take the risk sometimes to pay out of pocket when the provider says they'll fill out a form that the person can subsequently submit to their insurance company, which, by the way, will reimburse them at a fraction of the cost because it's out-of-network care. So these are much lower rates of reimbursement. And to illustrate, in 2024, the Research Triangle Institute, April of 24, published a report. We can get a link for people to it. It was a follow-up to years of reports from Milliman looking at the rates of reimbursement across every state in the United States by licensed discipline as compared to licensed disciplines of similar levels in primary care and in specialty health care. So here in Massachusetts, and actually pretty much across the nation, the payment for an office visit, the reimbursement for an in-network office visit, was much lower for behavioral health. And here in Massachusetts, unbelievably, and I never mentioned this in front of psychiatrists because of or students, like we have our friend Keen here, who's a budding medical student at Dartmouth. He's our summer intern. I hate to mention this, cover your ears, Keen, but in Massachusetts, a physician's assistant gets a higher rate of reimbursement than a psychiatrist or a psychiatric nurse or a psychologist for the same procedure. I mean, simple common sense would dictate that be addressed. And that pattern of discrimination exists across the states. You can look up your own state's profile if you read that report. Our Department of Insurance has been required since August of 2022 to issue regulations on a provider rate schedule, to set a minimum schedule of payment rates for evaluation and management services. They have yet to do that, and to do that in a meaningful way that all the insurers are pressed to adopt. Some of our insurers are better than others. We're hoping that example that some are setting is one that will be followed by others. There are some great tools that are available to states if your Department of Insurance is wrestling with what it can do to regulate these things. These are complicated things to assess, but the Mental Health Treatment and Research Institute, that's part of the Bowman Family Foundation, has developed a set of very highly regarded tools, a model data request form to assess parity compliance issues, and an audit tool for states to use. We're examining it here in Massachusetts. We'll see what we can do to persuade our DOI to adopt some of this, but I would encourage people to try to promote this with their states. Finally, I just want to say some of the steps we've taken on implementation. I, as a former state government person, I spent 10 years in the Department of Mental Health in Massachusetts, another 8 in the Department in Rhode Island. I recognize that when you are given an, in quotes, unfunded mandate, even the most responsible of bureaucrats will struggle to get the job done. So I actually, in the face of these requirements under Chapter 177, worked with other advocates to say we need to get more money into the Department of Insurance budget to enable them to hire a couple more staff to work on this. And we asked for $500,000, and Ways and Means gave us $250,000. 1 minute, I'm over? Okay, 5 minutes. Oh, okay, wow. All right, I'll be finished before then. So a year later, I go back to try to get it back up to $500,000, and Ways and Means says to me, Donna, we've been here before with you. You advocate for these things. We give the money to these state agencies, and they don't spend it. Guess what? The DOI never spent 1 cent this year. We are not going to increase this. So at least they agreed to continue with the $250,000, and this year, DOI is finally hiring some staff. We also advocated for budget language that would require them to submit reports to the legislature, which I talked about earlier, and we got actively involved. I want to credit Jess La Rochelle and Kate Alaconte. They worked on putting this together, putting comments together on the legislative reports that the DOI was submitting and underscoring the Department of Insurance lagging performance on parity enforcement. We have had, in a polite way, to call it out. And I say that, I do it and say, look, I'm a former government official. I get this. I know the pressures, but we've taken a step to give you more staff, and you have an obligation to act. And we have now briefed the new DOI commissioner, and we were very direct as advocates. We have a partnership with other organizations, Health Law Advocates, Healthcare for All, NAMI, and others. And we together go and talk to them about these issues, and we've underscored the problems with parity enforcement. And they've agreed for the first time in years to meet regularly. There's now a monthly meeting with the behavioral health advocates, which gives us a chance to be in constant dialogue with them. It's progress, but the job is not nearly done. We have a lot ahead. I am watching closely Connecticut with your new law and the success I hope you're going to have in implementing that. And Connecticut also passed about a year ago a law creating a mental health ombudsman, a behavioral health ombudsman, that sits inside the Department of Insurance. Luis and I talked last evening. I happened, through a personal connection, to know the gentleman who's just been appointed to the job, Howard Zronsky. And I'm hoping maybe sometime we could have Howard come to Massachusetts and talk with us about what he's done to establish that office. And Luis, who was instrumental, I want to congratulate you, in getting this bill passed and getting this established. So thank you. And I want to just say one more thing. Thank you, Luis. That we have with us Mr. Fine in the back from Chicago, who's probably the only person in this room. Feldman, I apologize. Forgive me. I should have brought your card up here with me so I didn't blow this. Sorry. Mr. Feldman, who is probably the only person in this room who has successfully sued an insurer on a parity violation and succeeded, so I applaud you. Okay. We can send you more information on the 200-page plus. Oh my gosh. Yeah, there we are. Happy to send you more information on the bill, and if anybody has any questions before we close, happy to answer them. Okay. Yeah.
Thank you all so much. One of the things that I always think of as magic happens here at the RPC meetings. And that's why we go into detail on things, because I know that other states are going to go back home and do phenomenal things like Massachusetts has done, like our friends in Connecticut, whose bills just keep getting stronger and stronger and better. And that's why we go into this. We're going to take a break now. Somebody in the back, Kat, tell me how long we should take a break and what time we should be back. I think we're running a little bit over, but not terribly. Is 15 minutes good? Let's do 10. Even better. Thank you, Kat. Okay. 10 minutes. Restrooms around the corner. I think there's some coffee outside, and I'll see you back here soon. Have a chance to fill their coffee, tea, whatever, because we're going to get started. So come on back in, please. I'm gonna keep things short and sweet, Pierre-Louis.
Oh yeah, just say, here's your speaker.
Well, I'll maybe say a minute more than that, but all right, we're good. Everybody
Should
good?
I move the slide to get them?
Yeah. Yeah. Okay. Now, Jay was just giving a 1 second there. All right. Oh, there we go. Hi, everybody. Welcome back. I know everybody's been sitting for a long time, and we've got lots of people to hug and kiss. And the line in the restrooms, at least in the women's room, was getting a little long, so I got this. But I want to try to keep us on track. And we're about to talk about something that matters to us that I referenced a little earlier with Representative Pittman from Oklahoma, the importance of culture. And we are so fortunate to have Pier Luigi Mancini with us. Not only is he the national expert on this topic and many others, he's the chair of the board of Mental Health America National. And we're so honored that he stayed here with us, to be here with us in Boston, and to speak to us today. So I'm going to get off the stage and turn it over to Pier Luigi. You bet.
Thank you. All right. Good morning, everybody. Oh my God. Okay. Come on. So I'm going to move fairly fast because, again, very short period of time for such a big theme. But I'm glad to be here with you today. I love Mental Health America. I love being part of this board, and I'm so grateful to everything that all of you do that really makes Mental Health America how great it is because of you. And I met many of you last night, and I hope to meet the ones that I haven't met yet. So I'd like to start with a quote kind of to ground us about language and culture. So originally, Nelson Mandela said, when you speak a language, English, well, many people understand you, including Afrikaners. But when you speak Afrikaans, you know it goes straight to your heart, to their heart. And then it was modified, and people try to make it easier. They didn't want to say Afrikaners or Afrikaans. So if you talk to a man in a language they understand, that goes to his head. If you talk to him in his language, that goes to his heart. And I think that that's what we need to look at. So when I look at the importance, language is not just the spoken language. There's many ways to communication, but it's the bridge to dignity, to understanding, is the bridge to healing. Any of us that have been in another part of the world where English wasn't spoken and we needed to communicate with someone, we know how difficult and how bad we felt that we could not get our message across, especially if it was an injury. Right? And if you go somewhere and you hurt yourself, the first thing is, does anybody speak English? Right? It's the first thing we do, and we have that expectation. Well, when that doesn't happen, it creates a lot of issues. So I want to invite you to start looking at it through a different lens today. Because I want to speak not only about the spoken language, but also our communities who are deaf and hard of hearing, who are also suffering in silence because there is no infrastructure. We have very few clinicians still that speak American Sign Language, and these are individuals that also will have mental health issues. So we had that. And even with the best intentions, simple but critical truth, even with the best intentions, our systems fail to connect those most in need, especially when language and culture are barriers. And I present to you that the reason that happens is because no one at the table that's discussing the issues of access is aware or has experienced this issue. So people are making decisions and they don't have the information, the background, or the understanding, or even the solution. So, after this today, you're going to be experts, and you're going to be the ones that may be sitting in a table one time where it's not being discussed, and say, Pier Luigi, that really good-looking guy, said, we need to speak up about this. So, because language and culture, and culture is just the way that we express our emotions, even how we describe what is wrong with us, right? So our story, my personal crisis is going to be described from my ethnocentric view. That means where I grew up, who I grew up around, how we expressed mental health issues or didn't express mental health issues. And unless I learn something different, I'm going to keep repeating that. So just really briefly, we continue to grow. I know that again, we're in a very strange political area, but every part of the world that I've lived in, kids are growing up speaking multiple languages. Here, unfortunately, we don't do that very well or very much, and I think it's a limitation. But what happens is that we have, all of your states have multiple people that speak other languages. Sorry, I didn't mean, I keep changing here, thinking it's changing there. So when we talk about this, if I were to ask you what are the languages besides English and maybe Spanish that are spoken in your state, very few of us really have that understanding unless we're exposed to that, right? But when you look at Chinese, Tagalog, and Arabic, these are languages that are very much spoken everywhere. And where people are coming from, most of the immigrants in the United States are coming from Mexico, and that's been established. Many people just stayed here when the borders changed. So they were already here. So their backgrounds, their family, their history is from Mexico. But when you remove Mexico, what happens? You have India, Cuba, Guatemala, Canada, right? So after Mexico, look at the whole stretch of Canada, Philippines, Vietnam. So there's people from all over the world that are settling in the United States for many years. But what happens is you have the challenge, and every state, from 2% in Montana, so Montana has 2%, but look at the middle of the country, 5, 8, 14%. And then, of course, California has the highest number of born outside of the United States. So if you find your state and said, okay, 15% of the people in my state were born somewhere else, there is a percentage, a high percentage, who are still learning how to speak English. And anyone that's learned a different language understands that to master a new language can take 3 to 7 years. So if I just know, my work English, for example, my mechanic is Bali. Bali is from Serbia, and Bali can tell me in English everything that's wrong with my car, right? And it's going to cost $700 because it always costs whatever it is, $700. And but if I ask Bali to tell me about his emotional well-being or emotional struggles, he doesn't have the English ability to do that, right? So we need to look at that, and then we have the racial and ethnic diversity. So all this information is available to us. So when I consult, when I talk to organizations about individuals in their serving area that they're not reaching, I go to this information. So, well, did you know that you have 12,000 people in your service area that speak German as their primary language? Which, of course, is a very popular language. As you can see here, once you remove English and Spanish, you have Portuguese, Navajo, Vietnamese, Korean, Haitian. That's the third most spoken languages in those states. So again, if you find your state, said, wow, maybe you knew that, maybe you didn't know that. But there are people in those communities that will still encounter mental health issues that we're not reaching. So when you look at the cultural lens, culture is everything about us, our values, our beliefs, our communication, our traditions. Right? So what do we do? Why do we do the things we do? Is because our ethnocentric view. That's how I was raised. And unless someone tells me different or I learn different, I'm going to keep making the Thanksgiving turkey the same way that people made it in my family. Right? Sometimes there are things on the table and we make these things and we don't know why we make these things, right? But it's culture. So that's part of what we're doing. But it also want to clarify, culture is not your ethnic group. Culture is not your geography. Culture is not your language. They're not exclusively those things. It's a combination of how we express ourselves. Early on, I took a girlfriend to meet my family. My father was Italian. My mother is Colombian. And so very passionate, to say it that way. And 5 minutes into the visit, she says, hey, honey, why are you guys fighting? I said, we're not fighting. We just talk like this, you know? It's whether we're happy or, you never know, right? It's the same expression. Actually, whenever I go to Italy twice a year, when I come back, my hands, you know I've been to Italy because my hands are all over the place. So we continue to work on that. So the barriers, you know, main barriers to care are things that we know. If I cannot tell you what my issue is in a way you can understand it, I'm going to be misdiagnosed. I'm going to be given the wrong medication. I'm going to be given a treatment that does not help me. And in some extreme cases, we've had involuntary commitments because of one word that can change the entire discussion. Interpreters can be great, but many interpreters are not trained. We don't have a national interpreter certification like the courts do. We don't have that for medical. Every state is different. And most of the qualified or certified interpreters that I've met don't speak our language. They don't speak mental health language. And that's dangerous because if they're interpreting a diagnosis and they don't know it, they'll make up some word that then the clinician makes a decision on bad information. So what's the case for linguistic competence? You know, there are legal issues. There are legal implications of why we need to do this. Right now, as you know, there's many challenges to this nationally, politically, but it's just a delay because these are needs. Not only they're protected by laws, but they're needs. They're human beings. They're people that we need to serve who are suffering, and we need to make sure that we have the tools to do that. So there are very difficult decisions that need to come up, but the case is there because if we don't do this, we will continue to have people suffering in silence. So what can we do? You know, there is institutional solutions, actionable steps. Everyone needs to be able to know what the languages are that are in our service area. We need a language plan. You know, if I can't afford an interpreter, you know, that's reality, right? Finances are reality. And I need to figure out what else is in my community that I can use to help these individuals. But we need to stop ignoring some of the people that need us that are not able to be there. By the way, this presentation is available. I don't know if we can send the handouts to everybody. Yes. So here's a call to action and conclusion. So linguistic and cultural responses is not just about compliance. It's about justice. It's about dignity. It's about making sure that we fulfill our missions, that everyone that we care for has the opportunity to access the tools they need to live their best life ever. I mean, many of us in recovery, we are living our best life ever because someone opened a door for us. Someone listened to me and understood me and guided me as to what I needed to do, right? So we need to continue to ensure that and be able to have people do that. So a couple of things. I'm going to close. It's a 4-minute video, but I think it's really impactful. But if you haven't done this, there is an implicit test. And I wasn't saying encourage, but I actually challenge you. And in October, when you come to the conference, you can tell me. Take this test. It has many different ways. People say, hey, man, I'm not racist. I don't discriminate. Well, I don't know, because that's also based in my ethnocentric view, right? If all I heard my life is this group is this, that, and the other, then that's all I know. By taking this, it's eye-opening. It's free, it's anonymous, and it gives you a score. And it has many different categories. So it's not just race and ethnicity, right? So you can go to different categories and learn about that. So I'm going to close with this. Do I just click for it to play?
Dr. Martin Luther King Jr., in a 1968 speech where he reflects upon the civil rights movement, states, "In the end, we will remember not the words of our enemies, but the silence of our friends." As a teacher, I've internalized this message. Every day, all around us, we see the consequences of silence manifest themselves in the form of discrimination, violence, genocide, and war. In the classroom, I challenge my students to explore the silences in their own lives through poetry. We work together to fill those spaces, to recognize them, to name them, to understand that they don't have to be sources of shame. In an effort to create a culture within my classroom where students feel safe sharing the intimacies of their own silences, I have 4 core principles posted on the board that sits in the front of my class, which every student signs at the beginning of the year. Read critically, write consciously, speak clearly, tell your truth. I find myself thinking a lot about that last point, tell your truth. And I realized that if I was going to ask my students to speak up, I was going to have to tell my truth and be honest with them about the times where I failed to do so. So I'd tell them that growing up, as a kid in a Catholic family in New Orleans, during Lent, I was always taught that the most meaningful thing one could do was to give something up, sacrifice something you typically indulge in to prove to God you understand His sanctity. I've given up soda, McDonald's, French fries, French kisses, and everything in between. But one year, I gave up speaking. Figured the most valuable thing I could sacrifice was my own voice, but it was like I hadn't realized that I had given that up a long time ago. I had spent so much of my life telling people the things they wanted to hear instead of the things they needed to, told myself I wasn't meant to be anyone's conscience because I still had to figure out being my own, so sometimes I just wouldn't say anything, appeasing ignorance with my silence, unaware that validation doesn't need words to endorse its existence. When Christian was beat up for being gay, I put my hands in my pocket and walked with my head down as if I didn't even notice. Couldn't use my locker for weeks because the bolt on the lock reminded me of the one I had put on my lips when the homeless man on the corner looked at me with eyes up, merely searching for an affirmation that he was worth seeing. I was more concerned with touching the screen of my Apple than actually feeding him one. When the woman at the fundraising gala said, "I'm so proud of you. It must be so hard teaching those poor, unintelligent kids," I bit my lip because apparently we needed her money more than my students needed their dignity. We spend so much time listening to the things people are saying that we rarely pay attention to the things they don't. Silence is the residue of fear. It is feeling your flaws, gut-wrench guillotine your tongue. It is the air retreating from your chest because it doesn't feel safe in your lungs. Silence is Rwandan genocide. Silence is Katrina. It is what you hear when there aren't enough body bags left. It is the sound after the noose is already tied. It is charring. It is chains. It is privilege. It is pain. There is no time to pick your battles when your battles have already picked you. I will not let silence wrap itself around my indecision. I will tell Christian that he is a lion, a sanctuary of bravery and brilliance. I will ask that homeless man what his name is and how his day was, because sometimes all people want to be is human. I will tell that woman that my students can talk about transcendentalism like their last name was Thoreau, and just because you watch one episode of The Wire doesn't mean you know anything about my kids. So this year, instead of giving something up, I will live every day as if there were a microphone tucked under my tongue, a stage on the underside of my inhibition. Because who has to have a soapbox when all you've ever needed is your voice?
Thank you all so much. I'll be here the rest of the day, so if you want to talk, I would love to talk to you. Thanks, Debbie.
Thank you. Thank you. Thank you. Thank you. Wow, that was really something. Thank you, Pierluigi. We're going to talk about something that matters to every one of our MHAs, that matters to all of our industry partners. It's all about employment and about where people work and what employment can do. I'm going to invite Ben Harrington. You're going to hear more from Ben later because Ben is one of our wonderful Regional Policy Council representatives. We've got Carrie Zeiss from Tampa Bay Thrive, my wonderful colleague at MHA National. Tracy's going to go up. And you've already met Louise from Connecticut. What I'm going to do, Ben, is we're going to bring up another chair unless you want to moderate from the podium. What would you? Very fine. Please welcome our panel. Yes, I will. Thank you. Thank you.
Debbie was so close to the edge, it got just a few to turn. Yeah. Yeah. So it was kind of funny when Mary Galiberti is telling us how she is officially a policy wonk, right? Yeah. So I am a recovering history major. So that means I remember all sorts of stuff and I can't let it go. But I also want you to know that I am also a certified mental health nerd. And I hope after we lead into the panelists' comments, you've seen a foundation of facts. The historian in me says, focus on the facts. The nerd in me says, keep finding those facts. So, I just pointed you. Is that what I do? Okay. So, let's talk about a few facts. Before 2020, we always talked about 1 person in 5. 2020 changed all of our lives, whether we want to admit it or not. But the business case fact really got changed when the U.S. Chamber of Commerce came out and said, hey folks, 51% of employees nationally are struggling with their mental health. Now that's a fact. What we also don't know is you peel back the layer of the onion on that fact, and there's one more important one. We are all in this room connected to the health field. It's 81% of health care employees are struggling with their mental health during the pandemic. So that's huge. So how do we really get there? That's the thing y'all might want to know. And this is where the real mental health geek in Ben shows up. Okay? So that's a true confession. 1/3 of all people who developed COVID during the pandemic would develop in a 90-day to 180-day period what's called an adverse psychiatric condition. That's not been making stuff up. That's published in the Lancet, the British Medical Journal, and many others, use that. So that's a huge percent. But now let's put it into a context. Anyone have a quick guess how many people had COVID in the United States? Come on, throw it out. Schroeder, what's your guess? We had 20 million, 50 million, keep going. Todd said 100. Before they stopped recording the data, hint, hint, it was at 107 million. So now you take the Lancet prevalence piece and put it to that. That's 35 million people that got added to the need mental health continuum that was already stressed and folks were having trouble accessing care. Think of that, 35 million more people jumping in the pond. That's why the COVID era is so impactful to our whole conversation today. So on the right as you look at it, you get to see all the talking points that are now made so much easier with the business community, depending on what geeks them out, right? So think about this from a corporate culture, and I know some of our panelists are really into the corporate culture, right? But more people are looking for an employer that supports mental health, right? From the retention consideration, more people are reporting they're going to stay at an employer that supports their mental health. We also know concretely now what the return on investment is, right? It's a 4-to-1 return on investment. That means for every dollar we invest, we're going to have $4 that we save as an employer somewhere, whether it's in retention, whether it's in culture issues, whether it's in healthcare spend, et cetera. So we're going to save some money. So the other thing I would want to share with you is cost containment. This is something that I've geeked out about for 20 years. Claire Miller knows that. And then she put me on the phone with Joe Feldman, and God, we were supposed to have a 30-minute call, and it was an hour and a half. Because, you get 2 mental health nerds on the call, and it's tough. But here's the thing that you need to hear. So setting the stage, and this is from Inseparable at the National Association of Insurance Commissioners. Behavioral health, mental health and substance use disorder treatment is underutilized. Duh, we know that. But what it results in is higher physical health care costs. Let that soak in. Behavioral health care is underutilized, and its result is higher medical costs. So our friends at McKinsey can cite this stuff, Milliman can cite this stuff, et cetera. Let's focus in on the middle one, the Milliman. Individuals with mental health and substance use disorders have a 3 to 6 times higher physical health care costs. Now, that doesn't mean it's because they have a mental health condition, right? What it means is they're churning higher medical costs because the docs, the systems are searching for a better outcome for the healthcare condition, heart disease, diabetes, cancer, obesity, and they're not achieving that expected outcome, so they're going back and trying it all over again, over and over and over again. They're churning healthcare costs, when what you could do, peel back the layer of the onion and ask yourselves the question, we're not getting a good outcome for diabetes. Why is that? We've got the best insurance plan. We've got evidence-based practices. Why aren't we getting it? The reason is there's untreated depression going on with that individual. Same with heart disease, et cetera. So I wanted to lay these facts out for you so that you would have them. And all my stats that are in these slides do come with a citation. So when you do log on after the meeting and you want to get the slides, the last page in the slides is going to have the citation. So you know the sources, so you know I'm not just making stuff up. But I am your confessed mental health nerd. So you know that with the help of Claire Miller and Joe Feldman, we got the sources all right, so thank you. So now let's turn to the panel. So the panel, you've heard me lay out very briefly a foundation for making the case for mental health in the workplace. So let's start with you, Carrie. Carrie Zimmerman is the CEO of Tampa Bay Thrives in Tampa Bay, Florida, has a great coalition of employers that she's engaged with. She's a Maine native, went to MIT, and she's fabulous. And the Tampa Bay Thrives Coalition is the MHA affiliate there. So what's your immediate response to the facts that I laid out?
So can you all hear me okay? So we were formed, our coalition was formed in 2019. I was employee number 1 in 2020. We are a convener. And I started January 2020 at the time that the world exploded around mental health concerns, and I needed to pull together a coalition of people who wanted to continue that energy to make change when there was so much noise. And you add to that, I'm in a state that has some complicated politics around how we're going to address mental health from a systems level.
Yeah.
I had to quickly mobilize around how was I going to get to systems change strategies using data and storytelling to make this continually in front of our leaders so they knew exactly what they could do to help support their community, their employees, and drive some change at a system level, which we measure pretty, I think I'll talk about that later, the research study. Okay.
Yeah. Luis, what's your response to the facts?
So, a couple of things. One is that you reminded me that very early on when the state of Connecticut shut down, there were essential functions like banking that needed to go on. And I got a call from the Connecticut Credit Union League because the credit unions, serve a lot of unions. And first responders were one of those people that were coming to do their banking. And the tellers were experiencing compassion fatigue because they were hearing all these horrible stories from their customers. And fortunately, we had been paying attention to compassion fatigue. We're a large service provider. So we had all of these self-care kits that we were able to bundle and provide to all the credit unions in the state of Connecticut so that they could then start doing self-care with their employees. So very interesting about the data, nerd. But there's a real part of the story with concrete example.
Yeah. And so Tracy Weeks is the Chief People Officer at Mental Health America, and you know, your position is slightly different. You work with the C-suite, and you try to keep the C-suite on the right direction, right? Yeah. So, what's your response to the slides? Yeah, I know
it's a hard job. Let me say. I will say, as a self-professed HR nerd, and everyone knows that, we are not really trained to deal with things that are chronic, right? Our job is to kind of deal with things as they come and make them better. And the difference is that now in these environments, people are dealing with chronic conditions or chronic wellness that you have to be mindful of and that they're managing daily. So when you think about things like stress and burnout, if I send you on a 3-week leave, that doesn't mean that you're not dealing with those things in 3 weeks when you return. And so I'm fortunate enough at Mental Health America to have the opportunity to experiment positively, is what I say, in things that are creating environments that are culturally sensitive, but also culturally responsive to what's happening on a daily basis with employees. And I would be remiss if I didn't give a quick shout out to our Bell Sealers, who there are many of you in the room who have made a specific pledge to focus on these things on a day-to-day basis, and it actually gives us some very great data on what's working and what's not working as you look to creating these environments that are welcome to daily conditions.
That is a great segue, and thank you for the assist. So just so you know, there are a number of Bell Seal recipients in the room. Would anyone from an affiliate that is a Bell Seal recipient, would you raise your hand? Yeah. Yeah, that's such a fantastic commitment, and it really demonstrates the care and support of your employees in all sorts of ways. And also, fun fact, translates to how you can actually assist various employers in your area. But Carrie, I wanted to segue to you, because you've done some actual research in your community, and then you've translated that for your employers. Could you tell us about that process?
Yeah, absolutely. So as part of understanding the systems change impact that we were having, we implemented, and I have copies in case anyone wants to see, an annual resident mental health report that allows us to get a baseline of how we're doing in the areas of access, stigma, and navigation across our multi-county region. And as part of this, we've also been able to embed timely additional elements like loneliness, which is a new initiative for us, parental attitudes towards youth mental health, and in this next round, we're going to be talking about the impacts of major weather events. As part of this, delving more deeply into county by county, what's going on in our area, which gives me the ability to cross-cut this data and overlay it with the MHA screening data, which is incredibly powerful when you're talking to people who make decisions based on what they can see in terms of what's happening with their constituent base. Some of the questions that we delve into, for instance, is like, how are you struggling with mental health? How does it show up for you? And we see things like 39% of people say that they're struggling with concentrating at work and all of that. And then you get down to this year it was 9% of people who are missing work. And when we delve even deeper and ask how many days, and these are employed people, right? Yeah. These are people who have health benefits most likely through their employers. 9% of them missing work. How many days are you missing? Well, that average for us this past year was 8 days. So you apply the math on that to our region, and it ends up with a stunning 785,000 days that are being missed a month, 8.8 million days being missed a year, and that's missed days. Doesn't go into all of the things like difficulty concentrating, inability to sleep. So when you put this case in front of employers and then you have something like the Bell Seal program, which you can bundle together for them, to say not only is this important for your productivity, for your retention, and for the health of the people that show up every day for you, here is a way that I can help you understand the policies, procedures, and practices that can most beneficially impact your employee base. It's kind of a 1-2 punch that seems to really resonate. We overlay stories on top of that, but it makes it very, very tangible when you can directly translate that kind of productivity loss and impact.
So you can also put it in another context. Every state in the country will publish its BRFIS data, the Brief Adult Risk Survey data, and in that is poor mental health days. And they're only serving adults, are surveying adults. So most of those adults are working, so you can put it in a context. You can Google your blue-collar workforce in your county, you can Google your white-collar workforce, and then you can start to see what the average per capita income is, and you can do the math, and it gets to huge money being lost just from poor mental health. We haven't even talked about the absent days. Luis, I want to turn to you. Mental Health Connecticut, I believe, was the very first Bell Seal recipient, Platinum Bell Seal recipient, and I think one of the kudos to Mental Health Connecticut is your focus on culture. Would you expand on that?
Absolutely. So before we get to culture, intention, and being able to have a very intentional approach, not only from C-suite, not only from supervisors and managers, but from the line staff. And in order to do that, you have to show your intention. So we believe that our strategic plan is not something that you do every 5 years and you put it in a shelf or you put it in a drawer. You actually work it. You give updates to everybody in the organization about how you're doing on your goals and action steps. And one of the action steps that we put into the first strategic plan, I've been with the organization for 13 years, was staff development and staff supports. So that's where we started in terms of building the culture. We also started doing an employee satisfaction survey on culture. Saw great increases for the first 3 years, and then it plateaued. And we went, what's happening? We haven't, we've actually improved our supports and our training and our staff development. We have trained our managers, not just being managers, but being leaders in the organization. What's happening? And somebody very smart said to me, you're not doing the right testing. You should be testing climate, not culture. You can have a great structure that supports all of those things, but climate is how people are experiencing what you have set up to do. And boy, every year since we've been testing climate, it has plateaued, but it has plateaued at like 95% satisfaction. So I'm okay with that.
Good, congratulations. Miss Tracy, this might be awkward. Okay. I know sometimes in corporate America, the HR vice president or chief people officer can sometimes have a tough time trying to convey important messages so that right decisions can be made. Yeah. Yep. So from an HR perspective, chief people officer perspective, what data or trends around mental health in the workplace do the C-suite, CEO, CFO, COO, whoever's in the C-suite, what do they need to hear from you to make effective decisions to help the mental health of their employees?
Yeah. Well, the data that you presented is definitely representative of some of the things that we've started keeping an eye on as HR people. Usually we deal in qualitative, right? Qualitative feedback. And in order for us to make an impact, we started having to move to the tangible, quantitative responses and feedback. Reports like the Bell Seal specifically in this place, and our Bell Sealers have told us, they're able to now take back and use with their C-suite managers to prove some of the things that we have been saying over the last 30, 40, 50 years. 90% of them have reported, and this is why they're on that Bell Seal island, that they are now using, like Luis said, mental health awareness as a strategy, not just as a campaign, right? And that's different. while you have a 5-year strategic plan, integrated within every part of that plan, have you listed that mental health awareness is important and how is important? How does it trickle down through your policies, through your procedures, through your actions, and through your accountabilities that you're holding yourself to and everyone else in the organization is holding you to? Also, employees are telling us that having a voice in an organization is a part of having a culturally aware climate and the importance of that. And so I spend my time really asking leaders, have you asked them what they want? Have you asked them what works and what doesn't work? And a lot of the times we're just afraid of the answer because we know it might not be good. And so I always tell my leaders, we're going to start at 0, right? Let's start at base and then we build from there. But if you ask the questions, it will help you put things into place that actually have the greatest impacts, not just what you think is working. And also get feedback on when you need to make updates, changes, or implementations in those environments. And then that data kind of serves as a point of reference to you, and you can even see the trends of, is this working? Has it worked? Did it have an impact? Did it not? Do I get rid of it? Am I wasting time? Am I wasting money?
Yeah. Good. All right. Hey, Catherine, how much more time do I have? Okay, well, I'm going to ask one more question, and then we'll turn it over to the audience to kind of ask questions of the panelists. How about that? So, Carrie, you know I'm a confessed mental health nerd. I got all geeked out when you sent stuff to me, and I love acronyms. They have a thing that they're doing down there. It's called IYK, YK, and it stands for if you know, you know. Tell us about that, please.
Yeah, I love the If You Know, You Know campaign. We just did a day of filming last week, actually, and it's our awareness campaign. So, established in 2020, our focus, our 3 pillars of focus are navigation, access, and stigma. We waited to focus on stigma until we had better pathways for navigation and access, and then we went deep into the stigma campaign. And so we too believe that individual voice, I think the days of people designing a solution absent the voice of the people who you're trying to influence, it's dead. There's just too much information out there. People have way too many choices. If you build it, they will come. Does not work. That was our first big experiment, was a program like that. So now we're searingly focused on how do we elevate the stories and the needs and the desires of the individuals in our community and match it to the data. And that's where If You Know, You Know came to be. It is a video, a social, a text-based campaign where individuals in our community share their experience using that If You Know, You Know hashtag. So that meaning that if you've walked in my shoes, like we share a commonality around understanding this state that we don't even have to use words for. And we've elevated the voices of so many different kinds of individuals. Our aspiration is to have as many stories as we have people in Tampa Bay. And we've had some real leaders step up to the plate for us. And in addition to individuals whose stories are so poignant, so real, that they are going to move parents who don't have college educations and who are struggling with their kids navigating grief, loss, and stress in school. So,
she's also being a little bashful, folks. In some of her documents, there are significant numbers of business and governmental leaders piling in on that whole concept and coming clean and talking about why they support mental health of their employees, that sort of thing.
Can I share? So one of we did Recovery Month stories when we have a really strong media partner that does world-class content and who basically we just cover their employees' costs and they video for us. But we have a Fox News anchor who filmed her recovery story with us just this past week. She's got a bipolar disorder, she has an eating disorder, and she's been sober for 18 years. And the punch of someone like that coming up, like in a state that doesn't really fund mental health, and saying this is why it's important. And she talks about why sometimes her depression, she needs a day off. She can't go in and anchor the news that day. And for her to elevate that story for people who will think she is everything is super powerful. We have a WWE wrestler who's on King's Court right now, also sharing the same. So,
Okay, so I know there's got to be some questions in the room. I do have a list of backup questions. So, but let's see who's got a question in the audience. Surely Joe Feldman, Claire, your inner geekness is coming out. What's on your mind? Ask away. Come on, Joe.
So I think the work in Tampa sounds great of having employers saying, hey, this is in our own self-interest. And so, I mean, I'm keen to read more in this study that you published. I've thought long about, why is it that some of the stats on this page and on the previous one that Ben had put up just don't seem to be persuasive to enough employers.
Can I hold this up? I brought a couple copies of things. So this is not only is this for employers. This is Tampa Bay Business and Wealth. It's a magazine that goes to the C-suite. We purchased as part of a year-end campaign a gatefold inside. It has an "If You Know, You Know" story by a sheriff who had a mental health. So like again, bringing faces that you might not think of. It has the qualitative case and the quantitative case inside. A letter about the urgency. What you can do as a leader, and more importantly, we delivered this with a sticker, get involved, to every single legislator at the beginning of the session this past year to say, you need to care about this. Our motto is together for a better tomorrow. It needs all of us, and I feel like our job in Tampa is to amplify the resonance and make sure that every single person can find a role in this fight, no matter what you believe in kind of the general political sphere. We got to be in this together because it matters to every single one of us.
Great. Okay. Yes, Barb Johnston.
I'm going to grab a microphone and take it.
Yep.
I'm very loud.
Yeah.
It's about the recording. It's about the recording.
So I love your data, and I'm sure it's getting through to some, but I've spoken with some CFOs who've, when we talk about do they know what the utilization is of their behavioral health benefits, they don't know. And what a lot of companies are doing, because they're getting, if they don't have an EAP, for example, they're doing these workarounds where they hire these extra navigators, so it's a whole extra position to help people access care. I'm just wondering if we focus on the C-suite encouraging the insurers to provide the data about utilization of their behavioral health benefits. Have we used that approach at all?
I do. Specifically, and this is probably no secret, but at Mental Health America, we use our benefits more than the national average. But it starts at the C-suite, not encouraging, but leading by example, and permeates throughout, what is requested of not only the C-suite, but also of every employee in the organization. And what we usually do is we make a separation, and there is no separation. We all work together, and we are the same. So we lead by example and our own lived experience, which as an HR person, when I first started, I was like, you're telling me what? I'm getting used to it. But I really admire that what we are doing is saying, you should go take care of yourself. Here's what I did to do the same last week, and really being in communication and in relationship with each other to be vulnerable about that. So creating, the C-suite is the leader of it, but they really have to live it and show example. Because also what employees are dealing with is not only fatigue, but we're scared to be ourselves and show our weaknesses in environments. And if you lead by example, you will see that then employees will live out loud, and that's an example in itself.
Barb, the other response to that is, if they say, oh, this isn't in our company, we're not using a lot of behavioral health units of service, ask them what is going on with the big four medical conditions: heart disease, diabetes, cancer, and obesity. That's where they're chasing high utilization, and they can't get their hands around it. And between Milliman and the Montreal Heart Study, both of those very respected entities will report, you got to peel back the layer of the onion. if you want the better health outcome. Because if you don't identify in the 40% of heart attack patients their untreated depression, they're going to have the next one, and it's going to be the big one, right? And so Milliman says to employers, hey guys, it's no longer the big four, it's the big five. Yeah. So. Any other questions?
I'm coming,
Claire.
Claire. I'm coming. No, it's about the recording. It really isn't.
I was just wondering if folks could talk about, I think a lot of times we hear incredible success stories like the ones that you've shared of, you know, what you've been able to do, but can you talk about some of the first things you did to even get to a point where, you, I mean, the amazing story of the Fox anchor, to either build a relationship with employers, or what were the first initial steps that created some of the success in terms of getting employers to stand up and engage?
So again, we are a brand new organization, and despite a pretty splashy launch, because of the timing with COVID, you know, I really had to make sure that I was investing strategically with our resources to support that. So, you know, part of it was saying, okay, I'm gonna purchase some ad space and also try to upsell what they give me, you know, hit the nonprofit angle to say, like, I got to get this in front of eyeballs. And so really strategically investing in your communications function, while it might sound like it's sort of a luxury, it's critically important. Because that is the way that you're going to get through. We learned that with our warm line that we stood up. That was the first project we did. That's where I learned that if you build it, they will come. Does not work, because we had free psychiatry. We had next day referrals. And despite there being a paucity of those, you know, services available, people didn't utilize them. We had less than 10 utilizations in a year of the free psychiatry contract, which made me go, what's going on here? So we brought in behavioral scientists to actually understand more. And that's when I realized, like, we have to invest in pulling up those stories, those facts, like that information to a level that's visible, because there's so much information overload right now. You have to help people cut through the noise. You got to make sure that your message is resonating above and beyond everything else, which means you got to spend a little bit, honestly.
Yeah, I think that you also need to know what you don't know. And by the only way you're going to know what you don't know is by asking yourself, what is it that I don't know? And as you were talking about peeling back that onion, there's nothing wrong with course correction, right? And people are afraid that if you course correct, you're showing a vulnerability, or but it's not. It's about being curious, right? And if they're not coming, why is it that they're not coming? For us, it was we're not a brand new organization. We're 117 years old, so. The perception out there was that we were this very traditional organization that was not looking, both internally as well as externally, to change the environment. And so bringing somebody in that did blogs, you know, bringing in social media was the first thing to show up as a innovative current organization, not the old Mental Health Association of Connecticut, or the Connecticut Council, or Connecticut. Yeah, but it was the Connecticut Council for Mental Hygiene, right? That was our first name in 1908. Yeah. So changing that around was pivotal, because that also enthused the staff about saying, oh, I need to also improve the way that I'm doing my work. And seeking out assistance with development and training and moving to the 21st century.
Okay. What else? Well, let's wrap this up and give Debbie some time back. But listen, thank you all so much. And this panel is fantastic. They will be here all day. They're taking future gigs. Yeah. Thank you all.
Thank you, thank you. While we're talking about employers, employment, and mental health, first of all, you're about to meet somebody who's really special. And if you don't know her, you will. And if you do know her, you'll agree with me that she's very, very special. And I'm happy to say she's my friend. Jamie Belsito, and she's the founder of an amazing mental health organization about maternal mental health. And Jamie's also a former Massachusetts state legislator, and we gave her one of our champion awards a few years back, woo-hoo, and the nerve of the redistricting that made her district go away. But for our good fortune, it put Jamie back into policy in working for maternal mental health. And Jamie's going to tell us about the economics and why it really matters to pay attention to moms and their mental health. Jamie, come on up.
Love you. We talk about some weighty stuff around these parts, but we have fun, okay? So good morning. Where's my little clicky? What do I do? What do I point it down here? Oh my God, it worked. All right, fantastic. So my name's Jamie Belsito. Thank you for the introduction, Debbie. And can you believe I couldn't show up for the award because the meeting was in Hawaii? How dare they? How dare they? That was just too bad for me. But what did I do? I sent a video. All right. So I'll talk about the economics, but I have like part Mary Gilberti in me, and then I got part legislator in me, and I've got the lived experience. I'm all over the place is what I'm trying to say. But yes, this accent is real, and I will keep you entertained. Okay. So I founded the Maternal Mental Health Leadership Alliance in 2019 because something revolutionary started. Not only did I meet Debbie Plotnick in D.C. and Mary Gilberti, but we started talking about the reality of maternal mental health, which was and continues to be called postpartum. Who's heard this term, postpartum? Okay. Well, postpartum means a lot of things, but it seems to be the one sound bite that people will say if you're not feeling yourself. I mean, let's be honest with you. Who's given birth that hasn't felt themselves? And the mental health part of that is the most prevalent of conditions in pregnancy. Mental health complications. All right, so I'll go back. So I founded this fabulous organization because we started talking about it at the federal level. We started talking about complications of maternal mental health at the federal level, and it was a confluence of regular mental health, maternal health, and an infant mental health, okay? And we knew we needed to keep what I always talk about, the Brady to the Gronk, okay? Does that resonate to anyone? So we needed the Brady to the Gronk on this issue and make sure that we kept the ball in play because we were not going to just say, hey, we're going to talk about this and then walk away from it. It needs to be part of an ongoing specific conversation. All right, so this is me. That was me a couple of weeks ago because as Mary insinuated and indicated, I don't think any of us haven't been not on the Hill for the past 6 weeks, like all the time. And then there's my daughters living their best life. I mean, come on. So they are amazing. I was a mess, and I couldn't find help. And I gave birth here in Boston, right? Adele gets her vocal cords done here. We got like more titles in the entire sports world, and I couldn't find help if it were literally to save my life. And I almost lost my own life due to these complications. And that to me was unacceptable. So I will continue to talk about these issues from a policy standpoint because I love policy and I love data and I love people, and we deserve to have healthy societies as a part of it. So, okay. I'm going to keep peering over my shoulder. We're going to talk about MMH policies by state, and these are I'm going to go back. Here are the states that we're going to talk about, okay? Anyone from these states? Mass, Kentucky, Illinois? Holler at your girl. Okay. So, and we'll talk about, it's just the right thing to do. I mean, there's nothing more American than baseball, apple pie, and healthy families, okay? We are going to make America healthy again, friends. That's what I'm trying to say here this morning. But I'm going to start at the high level. What's the current national landscape on this? So we're doing a great job. And I say that tongue-in-cheek because our stats for maternal mortality, if you haven't read about it over the past terrible years, it's terrible. We are not doing well. And what's one of the leading causes of maternal mortality? Suicide. That is unacceptable. Absolutely egregious that it's 2025. It is 2025, right? And I'm standing up here talking about something that happened to me 15 years ago, and it hasn't gotten any better. That is unacceptable. Race and ethnicity, a breakdown here. And we're still waiting on figures post-COVID. We're actually understanding that some of the figures got a little better. I don't know how, because we know that substance use went up during that time, especially use of alcohol, and now we have states that have, legalized cannabis and all other sorts of things. There's issues all over the place. But this is the racial and ethnic breakdown on these facts and figures that we have as of 2020, and they're not looking good. And then by country, boy, if we want to come in first on something, we are coming in first on this issue, and it is egregious. Absolutely. Who are my parents out in the audience? Keep your hands up. Put 2 hands up if you're a grandparent. Okay, thank you. This is not the way that we want to be looking forward for our future. If we're talking about young people entering the workforce, and we're talking about trauma by environmental issues, by gun violence, by constant media discussion on maternal mortality, and then we're showing these figures, we have a serious mental health issue that hasn't even born itself. That's a little tongue-in-cheek, I guess. And we are not doing well here. And our health system has not made it any easier for us to do that. So I want to say thank you to the legislators who are out there and to the advocacy groups who are making sure that services are going to be covered and that folks are going to have access, because that's the only way we're going to keep people healthy. Preventative measures. It's just to really hammer home the problem here. Look at that red line, friends, okay? Mental health conditions are the leading cause of death for white and Hispanic women. Leading cause of death for black women is cardiac and coronary conditions, and I want to unpack that a little bit. When we take a look at how different cultures and different populations can manifest, sometimes you see, at least I've also seen it with myself, my stress or anxiety can manipulate itself into physical ailments, right? We know this, we see this. And so we're continuing to see that communities that are disproportionately affected by a whole host of issues that are stressors and societal failures, in my personal and professional opinion, continue to bear the brunt of poor health outcomes. Oh my God, but then there was this. Anyone seen this number before? The 24/7 maternal mental, yay, I see a head shaking, I see people. Friends, our executive director, Adrienne Griffin, if anyone does not know her, she's about all of 6'1", a former naval officer, a UN officer. She was in Somalia. She served in the United States Navy. She was one of 8 women in the Annapolis Naval Academy. And she'll say it straight to your face, the hardest thing that I ever had to get through was postpartum depression with my second child. And she said, boy, did I wish I had a number to call in the middle of the night when I was the only one up and had been up for hours with my son. And so we went to Congress and we worked our butts off with a bunch of advocates. Thank you, MHA, working with us on this as well, and MHLG and NAMI and everyone. And now this is a thing. It's a text line, it's a call line, and it's available 24/7. And we are so grateful to be working with the 988 folks on that, and the domestic violence folks, and all of the folks that know that we need to get folks help immediately. The call time on this is less than 30 seconds. And because we don't do data that much in this administration, and I'm just saying that because we know it's the truth, we haven't gotten any updates on what the actual call numbers have been, but as of December, it was over 62,000 families, and it's sisters, aunties, memes, daddies, pregnant people, it's everybody. You pick up the phone, you can get help, and it's localized help, community support. It doesn't matter what language you speak, what community you're in. You don't need insurance. It's just there for all of us. So please put this in your back pocket. And for those of you who have affiliates or out in the community, you can also go onto this website on HRSA and you can order stickers. You can order 8x10s that go, put them in the coffee shop, little cards to hand out. There's a lot of material that can be left behind. Then we have our maternal mental health and substance use disorder programs that we absolutely worked day and night on to get into our federal appropriations, and that was in 2016, and we've had another round 2. We are now in our second round of funding for these programs, and they are incredibly successful. Anyone from a green state on here? What can I see you? Raise them high, raise them high. Awesome. Anyone utilized any of the state psychiatry access grants? I got one. They are available, and they are available to pick up the delta of perinatal psychiatrists, because we have workforce shortages. Boy, do we have one in perinatal psychiatrists. And so what we've done is created, with the help of Congress, and help of HRSA, which made it into the Senate LHHS, as Mary was saying, we're not looking to replace what we already know is working. But any mom, pregnant or postpartum, can go to their general practitioner, can go to their OBGYN, can go hopefully to other birth workers. We're seeing that the calls are being received, but you can call your state program and get a screening done. You can get that done from the pediatrics office as well and get localized support. So friends, we are working at the Fed level to get supports to the community level, and that's what this is all about. Okay, so state level solutions. I'm going to go in again because these do save money, right? They save money. Was it Ben? You're like right here. The guy with the lobster shirt on last night, friends. That's what I wanted to say. He was just talking about, the 5 biggies. I mean, we know for a fact that readmissions for psychiatric challenges after giving birth are the leading cause of readmissions into the hospital. That's going to cost a lot of money. Why not just change some laws and make sure that insurance is covering things and take care of people, and then you reduce costs? It's what I always call low-hanging fruit. But here's the drum roll, please. On the cost part, in 2019, Mathematica did a report on how much money it's costing the United States for untreated maternal mental health challenges. Again, the number one complication of all pregnancy and the leading cause of maternal mortality. $14.9 billion. That's a wicked lot of money, friends. If you add in inflation right now, it's up to about $17.5 billion. That's lost wages, that's readmissions, that's loss of a job, that's a whole host of issues, chronic illnesses, physical illnesses, you name it, issues with the breakdown between the family, the mom, dad, baby dyad, because it's not exclusive just to moms, but it's the most prevalent are moms. This is a systemic family issue as well. It affects the school systems, it affects health insurance, it affects all the things. So if we take care of mom, we take care of children, we have healthy societies. Please vote for me in 2028. Thank you. I've just wrapped it up right there. Okay. He clapped and I'm in. Buddy, I got a sign-in sheet. I'm going to get your name. Okay. All right. So Massachusetts, so I am a former legislator. I was very thrilled to put the maternal mental health language into a final bill that was signed into law in August 2024. It was a big year for maternal mental health. We licensed midwives and lactation consultants because that's who women are seeing. We now have postpartum depression coverage. We had it with our Medicaid population, and they actually figured out a way to screen mom and baby in the pediatrician's office and have two separate numbers to charge because, you know, that $5 that we're giving the doctors is a real incentive to want to screen folks. That's a whole separate issue is the payout, right? But we did it, and Mass Health was doing that starting in, I think it was 2015 or 2016. It was a while ago now. And we expanded our home visiting program. I don't know if there are other areas or folks in this room that utilize home visiting. Any show of hands again? Colorado, beautiful, beautiful. And so that's where you're meeting people where they're at, right? You have to meet people where they're at. And we're seeing states expand this opportunity because for myself personally, I'm sure for others here, you know, having a second cesarean with a toddler, when my husband was traveling and flying to California every other week, I really getting into the car and driving a couple of miles in the middle of a New England winter to go to some probably was not on my top of the list. But having someone come see me in my house and check in and see how things are going, that we want to meet people where they're at. We also have made it so that our Department of Public Health issued regulations and annual reporting requirements so our legislature knows what's going on so we can be proactive. Okay, so insurers, private insurers now must cover the screenings and pay for it. Annual data reports from plans and providers have to go to the Department of Public Health on this. We also made it so that our private insurers all have to kick in, I don't know, we'll make it up, $8.23 because everything's so obscure these days. I chose 8.23. They all have to pay into our public health system because public health, again, another novel idea we found out really matters, especially during things like a pandemic. And we have our Department of Public Health. I personally think they're phenomenal. They're incredible people. They've been doing this a long time. They come out with our reports, and that's something we're going to be looking at. Our metrics getting better because we need metrics. Another thing that we did that was incredible is we created this maternal health access and birthing patient safety task force, okay? And this is addressing issues that we saw in Massachusetts. We had incidences of severe maternal morbidity rise with our differently abled communities, neurological differences, physical differences. We heard Ben talk about as well, you know, individuals who are, or maybe it was Pierre Luigi, but individuals who are deaf, who are blind. These are folks who also give birth and that need to have services. And Kentucky, any of my Kentuckians in here? Oh my God, my lone soldier. Hello. Your Republican-led legislature, and I say that coming from like a super Democrat legislature, put the health, mental health and wellness of families above party lines. And that's what we should be doing when it comes to mental health. We know this. We know that that's what we do. We know that this is not a partisan issue. This is an everybody issue. and nobody gets, so none of us are getting out of this place alive anyways. Well, today we will. But, you know, everyone knows someone, if it's not yourself or your sibling or a parent or a child, just everyone knows somebody who's been affected by a mental health issue. Again, this is a bipartisan issue for us policy folks out there. And the Kentucky Cabinet for Health and Family Services developed educational and screening tools because they know their communities. And that's really where the CBO piece comes into this as well. And the substance use part of this is so important. A little tidbit that we've done here in Massachusetts is when we see an neo-abstinence syndrome baby born, we are not penalizing the family. We're not taking the baby away from the mom, and we're not penalizing the family. We in our hospital systems have said the best thing we can do is keep mom and baby together, and we will watch them, whatever those, in the DCF folks need to work on that, but there is a lot of progress in keeping families together and addressing the comorbidities of mental health and substance use. HRSA funding. Federal funding is so important with our programs that we're working with. When it comes, the Fed money goes to the state money and goes to our communities. And so we're fighting very hard at all of our corners of the globe, everyone in this room, and we'll continue to do that. But Kentucky, again, has not only a state-funded program, but they have a federal-funded program as well. Illinois, snaps to Illinois. Who are my Illinois peeps out here? Just the one. I'm getting, but at least I get like representatives from every one of my states here. Pritzker signed off on a awesome bill. Not as awesome as Maura Healey's bill, but it was pretty good. No one laughed. It's okay. But this also, again, mandatory screenings for maternal mental health. These, I mean, again, friends, it's 2024. Like the book, The Yellow Wallpaper, was written in, I don't know, 1900. They called it milk madness. That's how, like, it's just, we're finally making progress, but states are paying attention. And so the mandatory education in the hospital settings, Medicaid coverage for doulas, lactation consultants. Let's stop having trained surgeons be the ones, aiding for birth. Let's get back to the right birthing centers, right? I mean, my grandmother would have been way easier to deal with than that person that I'll never see again. Also, home birth access. This is another big movement. Yes, okay? Another big movement. Our midwives and trained, God bless you, certified nurse midwives have been purposefully not allowed into the hospital because they've not been looked at to have the same grade of knowledge of birthing babies as an OBGYN. That is false. They are different, but they should be able to work together. And that's the way we're moving on this. And this is actually helping exponentially the mental health and wellness of pregnant moms and getting back to cultural roots. And the Black women's community in DC that I work with, boy, not only do they all have PhDs, but they're also doulas. And I am so embarrassed every time I hang out with that crowd because I'm not doing enough. And this is where we need to keep going, is making sure that birth is safe, and those will actually help our mental health outcomes. And insurance, again, who deals with the DOI here in their states? Who's dealing with the Department of Insurers? All the time. Need to make sure that not only the parity, but the access and the payment and all the things. And that's something that legislators can do. Work with your legislators, make sure that they're leaning in on that piece. Because a bill is only as good as it being, you can't do unfunded mandates and all these other things. They need to have teeth in it. And task forces. I'm not a big fan of a task force for the sake of a task force to post on your Instagram or make you look good on your Facebook, but actually do the work. And the folks that are appointed to these task forces are there to do the work. So reporting mandates, a lot of folks don't like mandates. Take out the word mandate, make it accessible with mental health outcomes for the family being the goal. And we absolutely have to talk about racial equity when it comes to mental health outcomes. And that's especially so important for our birthing people and our moms and our dads. It absolutely is part of the puzzle. And we will continue to talk about the Maternal Mental Health Leadership Alliance, and I ask our legislators to continue to talk about it and continue to have those conversations. Provider education, that's always a tough one, but that's really where the rubber hits the road, is the education part. And if there's anyone wants to work with the Maternal Mental Health Leadership Alliance, we do great trainings. We can do webinars. We have an unbelievable amount of information. We just sent around our palm cards. Palm cards. Palm cards. It hurts, friends, it hurts. But I want you to, flip it over. There's a QR code on the back of that. Sign up for our newsletters. We have an unbelievable database of resources of training. Let this be supplemental to what you folks are doing, especially if you're working with moms or working with individuals who are in recovery or parents in recovery, et cetera, et cetera. We have a plethora of information that's available on our website. I like how you say it better. Cards? Palm cards. It's your mouth just stays right here. Palm cards. It doesn't have to move around, and there's not a lot of inflection and stuff. But thank you. But I just want you guys to know this. I can't say enough to MHA. I have a brother with bipolar and substance use issues who has just been so sick as of lately. It has flipped my family's life upside down again. I might feel like I'm 16, but I'm not. I mean, we're going on 30 years of continued chaos of someone who was misdiagnosed, undiagnosed, has, almost bankrupt my family. My parents can only do so much because once they're over 18, we all know, not much else you can do. I have a child that we're finally getting on the other side of severe eating disorder. My own anxiety, I love it. It's my little friend. I have it right in here. My little pocket pal, Jamie, and her anxiety, OCD. We all deserve to live healthy lives, fruitful lives, lives of accomplishment and joy and pain, and being able to talk about those things. My one question I wanted to ask about work is there a generational issue in acceptance of talking about mental health? Because I'll tell you, our parents' generation was you were a functional alcoholic or you just didn't talk about it because it would embarrass your family. And I'm very hopeful that that continues to change, because once we are able to talk about the elephant in the room, it takes the steam right out of the issue. And I want to be able to do that for moms and for families. And if there's any way I can do that with you folks out there, I'm there. And I'm just grateful to be surrounded by folks who know all of the hard parts of what mental health challenges look like, and that there is a light at the end of the tunnel. And I value the relationship and will continue to work on this anytime I can. And thank you for the opportunity to speak to this crowd today. Thank you.
I think you all see why I love Jamie. And take it from a Philadelphian. As hard as it was for you to say palm card, do you know how hard I have to work not to say I need some water?
It's the Charles River, not the Stuckle.
That's right, she said that right, Skookle. Okay, anyway. Thank you, Jamie. And Jamie, you hit on things that were so important. I mean, I'll tell you, I am a mother and I am a grandmother, and I'm an old hippie chick, okay? So, I get this about the midwives and the home birth and all the rest of it. And we're going to talk about another thing that really resonates with this old hippie chick. So I'm about to get personal here. And for those of you who've known me for many years, I talk about my family. I talk about the fact that every gray hair says Ashley. my darling, wonderful daughter, who just got married again. I'm so excited. We're going when we get home to a celebration of her marriage. And Ash says to me that I should thank her for my distinctive, what used to be silver mane, which is now white, and the direction of my policy career. So it's always, always personal for us. And what we know is people need access to what they want and what they need, and that there's lots of different choices. And we know that people are often making choices that sometimes involve some street drugs that put them in danger. And so we're going to talk about psychedelics, and we're going to talk about psychedelics in ways that are coming up in the states and coming up, maybe not so much federally, but coming up in ways for people to get that if, in fact, that is their choice. And I am so thrilled that we have Professor Victoria Littman with us from Harvard Law School. And she not only is going to talk about the legal aspects, she's going to talk about the spiritual aspects. When I found out she had a master's in divinity, got very, very excited, because those of you who are Mental Health America affiliates know about our spirit and mind work and about how important this is and how these things come together. Sometimes they're conflated in ways that aren't true and are a little scary. And we know that we have to overcome lots of prejudices, but we're really all about helping people get what they want and need in safe, effective, accessible ways. So please come on up. Any way is good. I'll come down. After you come up, I'll come down.
Hello, that is a tough act to follow, huh? No, I'm also a mom, so definitely a lot of that hit close to home, and I'll just give a shout out to where I live, Rhode Island. We actually have private insurance-covered doula care. We're the only state in the country to have that, so that's a huge blessing in my life, so, and the work you do, incredible. Yeah, so thank you for that lovely introduction as well. My name is Victoria Littman. I'm a fellow in psychedelic law and spirituality at the Petrie Flom Center for Health Law and Policy, Bioethics, and Biotechnology at Harvard Law School. I'm also a visiting professor of law at Roger Williams in Rhode Island, so kind of local. I don't know if there are any Rhode Islanders in the room, but please come find me. Yeah, we should connect. I focus my research and my academic credentials, I guess, reflect that on religion, also psychedelics, tax, which is more interesting than it sounds, health law, and more recently, given what's happening in the world, the relationship between federal power and state power. Yeah. But I'm really glad to be here with you all today to talk about a topic near and dear to my heart. And before I jump in, I know you've done a lot of hand raising, so we're not going to do too much, but I do want to get a sense of the room. How many of you have heard something about psychedelics recently? Like podcasts there? Oh, a lot of you. Okay, yeah, it's a hot topic in the news. It's everywhere. How many of you are curious? You're like, this could be interesting. I want to know more. I came to this talk. Okay, great. How many of you are skeptical or like nervous? You're like, these things, okay, we got a few. I think that's fair, right? I think that's totally reasonable. And I guess I just want to say, wherever you are, whether you're curious, cautious, excited, energetic about it, you're in the right place, right? My goal today is to help you connect some dots. I'm going to assume, right, you don't really know anything about psychedelics. I know some of you do know a lot about psychedelics. I saw the wonderful sponsors of the event. But, what these substances are, generally what they do, how they're being regulated. So I'm going to give you the crash course, right? I teach psychedelic law, but I'll give you the accessible. And then some of the questions that I think really matter in these policy debates when it comes to mental health, healing, and access. And I'm going to do my best to leave plenty of time for questions. I already forgot to start my timer, but we'll do our best here. So what are psychedelics? Generally, and no slides, so I'm going to try and keep it conversational and keep you engaged. But start thinking about questions, because I will leave time. The classic psychedelics are typically known as psilocybin, like magic mushrooms, LSD, you might have heard about acid, right, counterculture, mescaline, which is in peyote, and DMT, which is the main ingredient in ayahuasca, which all of these are things you may have heard of. There's also sort of like emerging, not classic psychedelic compounds like MDMA, which is a psychedelic amphetamine or ecstasy, or ketamine, which there's a huge debate in the psychedelic world whether or not that's a psychedelic, but is being seen as a psychedelic. Generally, psychedelics, and we're going to talk about the legal pathways, but people are excited about psychedelics because they see them as a potential treatment for a variety of mental health disorders: treatment-resistant depression, treatment-resistant PTSD, anxiety, other types of substance abuse, end-of-life distress. Even actually, there's now a movement, just in the spirit of the last talk, right, on mothers with postpartum depression using psychedelic mushrooms to help. So there's a lot of really exciting research. There's also this history, which I'll touch on and pertinent to this talk, right, of the religious use, the cultural use, the sacramental, sacred use of these, many of these same substances by indigenous populations, native populations, and now new emerging religious organizations. And yeah, some of the effects, I think it can be hard if you've never experienced or taken or talked to anyone, right? What are the effects? What does it do? Why is it so powerful, right? So the reports in the scientific studies and anecdotally, right, it alters your perception. It changes how you see things. It allows you to process emotions and access trauma, kind of takes down your fear response. And it does give rise to what the research literature calls CERT experiences. I won't give too many acronyms, but that stands for spiritual, existential, religious, or theological, right? So people are having these profound, life-changing, altering experiences. Not every time, but a lot of times. Enough that it's showing up in the medical scientific research, even when that research is not looking for these religious or spiritual aspects. So that's a little bit of background. We can talk more in the Q&A. A little bit about the legal pathways. So when we talk about psychedelic law, there's usually these three pathways. So pathway one is federal, which we could debate whether there's things happening or not. You might see it in the news. We have some federal agency heads that are really excited about psychedelics, but that may not translate into access. But right now, all of the psychedelics that I just mentioned, except for ketamine, are Schedule 1. Meaning completely federally legal, just like cannabis, right? Don't tell that to the cannabis dispensaries all around here. But totally federally illegal. But there is, I would say, somewhat promising federal research on psychedelics, particularly MDMA for treatment-resistant PTSD, psilocybin for treatment-resistant depression, a whole host of studies. There was news last year, about a year ago, I guess, where the FDA did deny an application for MDMA-assisted therapy, and I think that highlighted some of the challenges of the FDA model. Specifically, there's a lot of questions because right now the FDA model requires that the psychedelic be prescribed with therapy. So it's not just, oh, you're going to go get a prescription for your antidepressant. You're going to go and do a psychedelic-assisted psychotherapy, and that gives rise to a whole bunch of regulatory challenges, including the fact that the FDA doesn't regulate therapy. And it's very hard to standardize that therapy, and that therapy may give rise to some ethical challenges. Even in this FDA-regulated research, there were instances of abuse and harm that occurred between a therapist and the patient. So the FDA model, one model, I think eventually in the next, I don't know, I mean, who knows what's happening with the FDA right now, right? But we anticipate that the FDA will approve a psychedelic-assisted psychotherapy. You are seeing that companies are starting to move away from the therapy model into maybe a at-home guidance model, similar to maybe what you've seen with ketamine or methadone. There could be a lot of different models, and people are debating that. But certainly the FDA model is the slowest, I would say, right now. And you all know this because of the work you do, right? The traditional medical model may not be accessible to that many people right away. Insurance coverage, having to rule out other treatment options, right? There could be a lot of barriers. But the FDA model, certainly a major model. The second major model, and this is the one that I get the most excited about personally, is the state level reform model. Do we have anyone here from Oregon or Colorado? A few? Yeah, okay, cool. How about New Mexico? That would be a wild card, yeah. So those are the three states that have passed state-level reform, changing the legal status of at least some psychedelics, right? And when I teach this, it gets very confusing because you're like, are these medical programs or not? And it's like, who knows? It depends what you mean by a medical program. I would say New Mexico is the most explicitly medical. It just passed in April, so yet to be implemented. It's more similar to what you might have seen on what we call second-generation medical marijuana laws, where you would go to your doctor and you have a qualifying condition, and then you have access to psychedelics. It's a little, specifically psilocybin in New Mexico, psilocybin mushrooms. It's a little unclear where you could do the psychedelic, whether you'd have to like do it at, if you could do it at home, or if you could do it at the doctor's office, or what that looks like. So a lot to come on New Mexico, but exciting potential. Just psilocybin. Oregon also is psilocybin. They passed the Psilocybin Services Act in 2020. So that is the most mature. And they provide for on-site consumption of psilocybin under the guidance of a facilitator. So there's a lot of questions. We'll get into what all that means. But in practice, it's very expensive. You have to go use a psychedelic on site with someone who has been licensed by the state. And Colorado is doing sort of a similar model with that on-site consumption, but they include 4 substances. So in their law generally. So in Oregon, just psilocybin. New Mexico, just psilocybin. You know, psilocybin is seen to be probably the safest of the psychedelics right now in terms of the risk profile, so I think that's part of the reason, and has a huge potential for helping people and a lot of evidence. But Colorado includes psilocybin, DMT, mescaline, not from peyote to discourage misappropriating native use of peyote, and ibogaine, which you, especially if you're around Texas, you've probably heard a lot about ibogaine. People are really excited about ibogaine. If you're curious, ask more in the Q&A. But in Colorado, they have this on-site regulated model. In Colorado, it's called a healing center. It's going to start with psilocybin and possibly roll out these other substances. But Colorado also has this decriminalized personal possession side. So I feel like I've given a lot of legalese, so I'm going to try and like step back for a second, right? We got on-site consumption, medical, New Mexico, psilocybin. Oregon, on-site consumption, psilocybin. You don't need a qualifying condition. We don't know if it's medical, regulated by the Department of Health. Colorado, called the Natural Medicine Health Act, not regulated by the Department of Health. You don't need qualifying conditions on the health side. And then they have this personal use side, which is if people ask me, where should I go to do psychedelics in the US right now? Colorado. Colorado, Colorado, Colorado. They just rolled out this healing center model, but on the personal use side, you can possess, cultivate, and share any of those substances, except for you can't share ibogaine, but you could cultivate and possess ibogaine. And you can get paid or remunerated, is what the law says, for services accompanying the sharing of substances. So if this feels like a loophole gymnastics, it kind of is. But the idea is you could, in Colorado, legal under state law, tap into the network of people sharing and providing services related to psychedelics. You can pay someone to sit with you and provide harm reduction services while you consume psychedelics, and this is legal under state law. And so far, the federal government has ignored it. So, and we can talk about that. But, and one thing I find exciting, and this leads into the third pathway about Colorado, is that you can also provide spiritual or religious support services under this model. And it doesn't require the state government to decide whether you're a religion or not, because it doesn't matter. You can be providing harm reduction services, you can be providing spiritual support services, you could be providing, quasi-therapeutic in compliance with your own licensing services, and it's all legal under state law. So you also see churches popping up to provide community-based integration, therapeutic spiritual support, and access to people. So that kind of leads to the third big pathway. We got federal FDA, state regulated, and then religious use. And that is an area I've written and thought about. I think I'd say the TLDR here is that most of the churches that are out there operating are illegal. There are a few churches that have been able to navigate this federal exemption process with the DEA to be federally illegal, and they are regulated like other medical providers. They have DEA regulation, DEA numbers and tracking and storage. But there's a huge number of churches popping up all over the country with a variety of these substances and more. MEO DMT is very popular, especially in the South. So far, the federal government has taken hands-off approach. And in my work, I talk about some of the challenges that result from this not legal but not prosecuted environment where people are harmed going to these churches, right? And I mean in all these pathways, right? But psychedelics are not inherently harmful, and I wouldn't. I think that it gets sticky when you start talking about the harms because people want to say, no, we don't want to talk about the harms. People, there's stigma, right? But look, people get harmed going to psychedelic churches by other people. By abuse, by financial abuse, sexual abuse, physical abuse, emotional abuse. People are very vulnerable under the influence of psychedelics. So it's very ripe for harm. The other thing that makes it very ripe for harm is the lack of legality. So we've even seen, right, in Florida, there was someone, unfortunately, who passed away after attending a psychedelic church service. And part of what led to that was a fear of calling emergency services. It's like, we don't want to call 911. We're all doing something very illegal here. So in my work, I've said we should push all of it into a legal framework, even if you want to debate whether it's sincere or not, so we can regulate it, so we can make it safer. Because a lot of people who are seeking access to psychedelics because they hear about this potential for mental health benefits, because nothing else has worked for them, or just because they want to improve their wellness and it's an access point, they don't have other choices. Really. I mean, going to Colorado is the only state. It's not really a feasible option for most people. So I really want to protect all of those people by bringing this, I would say, gray market religious use category into the legal side. And so those are the big three pathways. See how I'm doing on time. Great. And so I think, now you have a sense of the legal landscape. I think I want to highlight some important questions and tie it back in with the religious, spiritual questions that I write about and think about. So I think one of the most important questions in psychedelic policy in general is, well, one, should people be required to have a facilitator, right? Like many people who do psychedelics are like, I don't need someone to be there around me. I could just, whether it's I'm going to take my microdose and live my life, or I'm going to, go by myself, be at my house by myself and take mushrooms by myself, and that will be a healing experience for me, right? There are many people who feel that way. And on the other end, there's this view sort of in like the, FDA clinical context that if you're going to do psychedelics, that you need to be with an MD, 2 MDs, right, of opposite genders who sit there with you for 12 hours while you sit in a lab setting and take a psychedelic, and they like watch you and talk to you. And this is truly, so then that's the spectrum. And I'm not saying, I think it's fair to say that there might be different situations that are right for different people, but when it comes to regulation, it's a really key question, right? And along that spectrum, you'll see, for example, in Oregon, the facilitator model, you're not required to have a college degree, which was supposed to be an access thing, which I think there are good arguments in favor of that. The requirement to be a facilitator under the Oregon model is to have a high school diploma and to take one of their state-regulated facilitator training courses, and then you are licensed to provide psychedelic therapy. In Colorado, psychedelic services, not therapy, because you're not necessarily a therapist. In Colorado, they had this dual licensing model, which now is sort of bleeding into Oregon, where they have a clinical license and a non-clinical license. And the clinical license is supposed to help people who are clinicians kind of grandfather that in and allow them to practice under their clinical license. Initially in Oregon, you couldn't even co-locate. So even if you were a licensed mental health professional and you wanted to provide psychedelic services, psilocybin services, you had to have a separate building. You had to pay like double rent. You had to, it's really challenging because there's a lot of concerns, which you can all imagine, of practicing, providing healthcare services in a federally illegal substance. But in Colorado, we're seeing kind of this dual clinical model where you could possibly practice under your clinical license. And we're seeing a sort of favoritism within the market for those clinical providers, which is kind of pushing out non-clinical providers. I'll say in general, if any of you are like, oh, maybe I want to be a psychedelic therapist, it's a very oversaturated market. There are way more facilitators than there are healing centers. And in general, these businesses really struggle due to federal illegality, right? Banking challenges, commerce challenges, insurance challenges, similar challenges that the cannabis industry faces, these state-regulated businesses face, which is why I've said it, and I'll probably say it a few more times, the Colorado personal use side, I think, is the model that other states should be thinking about and practitioners and providers should be thinking about. But I've also argued in terms of this facilitator question that chaplains and spiritual care providers should be a part of that model, whether that's in the education side of developing training programs, or in the clinical FDA context, having a chaplain as part of the care team, or training existing clergy and other religious leaders in providing psychedelic support. If I think this goes back to choice and agency. If someone wants someone there while they're doing the psychedelics because it makes them feel safe, I think we really need to care about who that person is and make sure that they are well equipped to provide competent, supportive care and be really aware of the risks. So in the work I've published about psychedelic chaplaincy, I highlight the risks, which, in layman's terms, brainwashing, right? Someone is really vulnerable. They're really open to new ideas, to the set and setting, where they are physically, their mindset, and the wrong person in that situation and even if it's not an ill-intentioned person, just someone who's not trained and equipped to hold that space for someone, to not impose their own view on someone, that is very risky, ethically, societally, personally. And so I think bringing chaplains in as part of that conversation, spiritual care providers, is not just ethically important, but also medically beneficial. So I know you have this excellent work group at Mental Health America. So you all know that spirituality, relationship to community, connectedness, like all of those things contribute to mental wellness and mental health. And we've seen that also in the psychedelic studies, which is really interesting, that in some of these studies, the intensity of the CERT, spiritual, existential, religious, theological experience, is actually correlated with the healing capacity. So if we can put people in an environment where they're having these spiritually significant experiences, that might actually contribute to their healing, which is, right, the whole goal of creating access to these substances. I think it's also worth considering peer support, integration coaching, all the different models for mental health support. Again, going back to some of those barriers to the traditional healthcare model for many people. I think there's going to be multiple points of access. There already are. But what I've also argued is that no matter who does the facilitating or guiding, access should come first. So I have an article from, I don't know, now a couple years ago called Why We Need to Talk About Psychedelic Dispensaries. And I know that when you hear psychedelic dispensaries, you're like, oh my God, people are just gonna go buy psychedelics and do psychedelics. People are already buying psychedelics and doing psychedelics. But in this model, right, we could actually have protections for people if they are harmed by what happens once they take the psychedelic home. We could do more education. We could, I have a friend in New York who proposed a permit model where there would be education built in to being able to access psychedelics. So I see it as being realistic that people are already accessing these drugs and making it safer for people to access them. And, offering it in a dispensary model would not mean that people couldn't take it from the dispensary and go to their therapist. It would just mean the therapist wouldn't have to jump through a million hoops to be able to do that. And it would mean a person would be able to actually go to their existing therapist and take the psychedelic within the framework that they're already comfortable in, within the therapeutic that they're already comfortable in. And maybe we want a training program for therapists, right? There's a lot of work to be done in this area, which many of you are better equipped to do than I am. But I'm just trying to give you a sense of like the policy landscape and some of the big questions. And this facilitator access question is huge. And I think I'll finish up in just a minute just to say that I really think we need to move beyond this sort of binary. I think that a lot of people are like, oh, well, is it going to be the FDA or is it going to be like the farmer's market? That's what we talked about in Colorado. There's, people can just go buy it. And it's like, is it going to be this or is it going to be that? And you see it with cannabis too, right? Like, am I going to have to go to the dispensary or am I going to buy my hemp seltzer in the liquor store? And it's like, we're still figuring it out. We don't know. But I think we should be thinking about multiple points of access for different people, education, and considering the real facts on the ground, which is people are using psychedelics all over the country, all the time. So, it is such a good example of the way that our federal policy just doesn't reflect, the lived experience of people on the ground. But I think we increase safety and we increase access through regulation, not prohibition. And that this safe, meaningful use that we all aspire to does depend on thoughtful legal structures. And that mental health policy should include spiritual care, personal choice, diverse support systems, which I know you're all a part of. So I thank you for having me. I hope you learned something. I look forward to questions.
Victoria, I'm going
going to start with a question, if I may.
Sure.
Got my mic turned on? Thank you, Jay. So thank you. That was wonderful. By the way, I mean, I've mentioned several times that I live in Colorado and our farmer's market. This nice fellow sits there with a sign that says free shrooms, but I'll sell you something else. So just saying. But my question is about infrastructure. I want to give a shout out to my friends at J&J who have really, in many ways, set infrastructure with esketamine. And I wanted you to elaborate a little bit more on how, like some of our MHAs have esketamine clinics. So they have a safe place for people to go. They have people to be there with people, and how perhaps this could be a more than one substance stop, and something our MHAs might be interested in.
Yeah, thanks for that question. I mean, I think it highlights one important thing, which I want to emphasize, right? That you can say this big bucket of psychedelics, but actually each of these substances are unique, and they have different risk profiles, and they have different lengths of time of session, and they have different needs in terms of support. I remember when the ketamine clinic, I don't know, maybe it was even 5 years ago, there was a lot of excitement around we're going to develop these clinics and we're going to roll it out. And I don't think that people in the more traditional psychedelic world were naive to the fact that this was a way to set up infrastructure, to say, oh, we can set up ketamine clinics, and then once MDMA gets approved, we can just add MDMA. And I think in line with my comments, right, that will be an access point for some people. And the critical questions of who's the facilitator, how's insurance going to cover it if it does, and what protections are in place for ongoing support for patients are still all just the most important questions. I will say there is a little bit more concern with ketamine and esketamine due to what has been observed as the more addictive nature of ketamine. People are not running after DMT every day in the same way, and it's not used as much recreationally, although that's changing too. But I think eyes wide open about the risks that could come with different substances. But I think I'm a big proponent of utilizing existing infrastructure. So in an article that I put out recently at the Cato Institute, I proposed that we should be selling mushrooms in cannabis dispensaries, right? Let's just use the infrastructure that's already there. So I think it's the same idea. Let's use the infrastructure that's already there. If it's working for people and we can just add more substances and beef up support and beef up education, I think it's a great access point.
I'm from Oklahoma, and you sort of just answered my question. We have legal medical marijuana, and we have a state OMMA, Oklahoma Medical Marijuana Authority. And it's very well run. It's very easy to get a medical card. I hear you saying that essentially that authority could add in other substances and just use the same model of a dispensary where you have to go get a card and all of that.
Yeah, that's my hope. I mean, I'm also looking at the reality here, which is states are hurting for money.
Yeah.
Right? So we saw which many of you know, right? We saw Massachusetts, they almost passed a proposal this past year that looked like Colorado's. It was a voter ballot proposal. I think one of the challenges on both the state side and the citizens voting side was it was going to set up a whole new regulatory body. Yeah. It was going to use a bunch of money from the taxpayers before it made a dime. Yeah. And that's just not feasible in this current environment. You're seeing also a similar proposal in Alaska to Colorado, which will be interesting to see what the voters there do. But yeah, my latest pitch, and I have a friend working on it in New York, I'm going to work on it a bit in Rhode Island, is to, you don't want to say to lawmakers, this is a way to make money, but in this environment, if you're going to come to them with something and it's not going to make them money, I don't think it's going to be feasible. Yeah. So I'm trying to balance, okay, what is the barrier? Should they have to get medical cards? Different states have different requirements in terms of how difficult it is to get a medical card, and we don't want to leave people out because they can't get a medical card. Yeah. But certainly I'm looking towards that, of cannabis entities regulating psychedelic mushrooms, because all of the dispensaries are already there, the regulations are already there. We'd have to amend the state cannabis law, and that would be the hardest part, versus passing something new.
Okay.
Yeah.
Thank you.
We have a question right here.
Hi. Well, first of all, thank you so much for this presentation. I have a question about, so we had a psychologist from Oregon do a great webinar for us on the link between regular cannabis use and an increased likelihood of developing psychosis or schizophrenia, especially for those who are genetically predisposed. So I'm curious if any of these models include research on potential mental health implications for psychedelic use? And if not, if you think they ought to be?
Well, there's a question there on correlation and causation, but when I get asked questions like that, and this is me, being honest in a room of people I'm just trying to talk to here, I'm like, we create widespread access to things that we know are much more harmful, like alcohol. I always say, I can go buy a keg. There's no possession limit on alcohol. I could go buy as much alcohol as I want today and put it all in my car and drive down the street and kill myself with just drinking it or driving while drunk, whatever. Right? So I'm not saying that. Do I think that we should research more about long-term health effects? Sure. Do I trust that research is going to be able to capture all of the variables at play? Like, do people who are predisposed to mental health disorders, are they more likely to use psychedelics? Like, I don't know. I think just like in the cannabis context, where now we even see that the Health and Human Services has said, hey, people using cannabis in all these states at the recommendation of their doctor, that's medical use. Right? So I think just getting to that mindset on psychedelics, and I'm not saying you're asking me in like a hostile way. I just think I get this question all the time, and I'm like, but I could go kill myself with alcohol today. And no one's asking that about alcohol, right? No one is, maybe historically we shouldn't criminalize alcohol, but we decided that's not what we do. And we don't do that with guns, and we don't do that with pharmaceutical drugs that people can access, and we don't do that with cleaning supplies. So I just think it's a double standard in a way. But I do know that, the new psychedelic czar at HHS, Matt Zorn, has been writing about, and he used to be an industry, so like it's kind of a funny switch, has been writing about, what is the role of the FDA? Is it about efficacy or about safety? So I think there's like a question on what should be the barrier in order to make a drug legal, and then there's a question of, do we want research so that people can go in eyes wide open? Absolutely, which I think is what you're asking. Yeah. No, I didn't feel that way.
Hands? Questions? You got one.
Hello. I was kind of intrigued about what you said regarding psychedelics being used to access trauma easier. I was just wondering if this were to be used in a medical setting, is there like a standardized treatment for it, considering that different people react differently to different psychedelics?
That is one of the hardest things about FDA regulation of it, of psychedelics in general. I think especially people look at MDMA as impacting the parts of your brain that put up fear. So there's been and I think this is a pitch of pharmaceutical companies, or maybe this is therapists seeing what's happening. I'm not either of those. But people have always had this line, right? Like, one psychedelic therapy treatment is like 10 years of therapy in one session. And I'm not sure it's fair to go that far. I don't know. It depends on the person and the drug and what their experience is. But certainly in the altered perception that happens when you are under the influence of psychedelics, you're more able, we've seen that, more willing and able to access trauma. Now there are questions about priming someone and opening them up to trauma, which we've seen in some of the pharmaceutical trials, where if you tell someone we're going to access your deepest trauma, and then they do, and then they don't have ongoing support, that can be more harm than good. In terms of the standardization of these models, like I said, I think that's one of the biggest challenges that Lykos, whose application for MDMA-assisted therapy was denied last summer. That was one of the biggest challenges they had. They had a training module, like a manual. There are some critiques about whether or not their therapeutic model is good or not, partially because it involves touch, which is a slippery slope to physical harm, in my opinion, but debated. It's hard to standardize that treatment and scale up access. So I think that is why my answer to that is, I don't think that there's an easy way to standardize, and I don't think we should tie access to the treatment. That way people can seek out the type of treatment that they want with a trusted provider already. It's a good question.
I wonder if you could comment on the implications of broad access, defined any way sort of that you want, with quality control of the underlying material. Thanks.
Oh, yeah, that's a great question. And you're seeing that, on the cannabis side, like the bigger you scale these companies, the lower quality the product can be. And there's a whole other, kind of consideration that I don't think I've touched on at all, which is like, are we talking about the naturally occurring psilocybin mushrooms that people grow in a box under their bed or something, or like lab-created GMP synthetic psilocybin. And you're seeing that kind of separation in the states. The states are all legalizing like naturally occurring versus the therapeutic model is all synthetics. And so to answer that, quality control is hard as you scale up, as that's true of any good, right, of any product. I think there's also this sort of like internal debate in the more like cultural advocacy side of whether or not the synthetics versions are as powerful as the naturally occurring substances. We see that with cannabis too. Like Marinol is an FDA-approved cannabis-derived drug, but anyone who's taken Marinol is like, it's like cannabis without the good parts. Like there's a whole like it's called like the entourage effect that people talk about in cannabis, and we think it might be true also in psychedelics, where the whole plant matter actually matters, but that's also hard to control at scale. And so I don't have a good answer for that. But my recent article is called "The Future of Psychedelic Regulation is Local," and it's because I think the answer to that is local. Local grows, local state reform, smaller networks. Just like I prefer to buy my meat and produce from my local farmer's market, I'd prefer to buy my mushrooms there too.
Okay, everybody. No more questions. Well, I'm really excited to hear what you have to say about this emerging field and all of it. Well, I mean, we haven't gotten into all of its implications, but the myriad of implications. So I want to thank you, and I hope everybody else will join me in thanking Professor Littman. Thank you. Thank you. Okay, folks, it's time for lunch. Woohoo! We're going to be back here promptly at 1 o'clock, and we're back on schedule. Lunch is out. How was lunch, everybody? Everybody enjoy lunch? Yeah? I know I did. That swordfish was wonderful. Okay. Are we ready to get back to being serious and doing work? Sure we are. So, as you know, today's theme is about access, how it's good business, it's good policy, and it's good for people. And what we mean by access is what people want and moving barriers out of the way. So I'm really thrilled about this panel where I have some of my dearest friends here. My dear friend Barb Johnston, who everybody knows from MHA of NJ, and Barb is one of our regional policy council reps. She's one of the people that makes all of this work. I know you all see us at meetings a couple of times a year and on webinars and things, but our reps, who you'll hear from all four a little bit later, are the people who keep in contact all the time, who give the affiliates a call, who convene monthly calls where everybody can share information. So we've got Barb here as our moderator, and Barb's also going to be talking about our subject matter today, long-acting injectables, and I know that Fred doesn't like that term. Tell me what you like.
Long-acting formulations of antipsychotic medication.
There we go. See, that's a lot longer than LAIs, but I'm with you on this.
What's the acronym? Oh boy, I left government a long time ago. So.
Okay. Anyway, and I'm really excited to have Fred Ryan here from Alkermes, the former police chief, as Donna pointed out, who really knows an awful lot about what it means to be a person who keeps getting caught up in that criminal justice system. And he's done a lot of phenomenal work to deflect people away from it and divert people out of it. And I have the privilege of also being connected through that work about how we always think about people with mental health conditions do not belong in the criminal justice system at all. So I'm really happy that you're here today. And we have Patrick Stone from OTSCA, and we truly appreciate our long-time partnership. And they have some wonderful things that people often choose, especially in the area of schizophrenia. I want to also say that a number of our other industry partners in the room also have LAIs, or whatever we're going to call them, And everybody was invited to be on the panel, and it's okay if you don't, because they want to hear from people who have, not that everybody doesn't have expertise, but what really matters to us is the choice, not the particular formulation or the particular company, but that people have access if this is something that works for them and they want to continue this way. So I'm going to get off the stage and I'm going to turn everything over to Barb Johnston.
Is this on? Great. Hi, everyone. Thanks, Deb.
You bet.
Deb, you just did my whole piece, but that's all right.
Sorry, Joe.
No, we're here about access today, and we're here about LAIs or
long-acting formulations of antipsychotic medications.
like I said. Right. So just a personal story to start out. How am I interested in this? Well, I've been interested in it for a long time, but most recently, a family member or two, actually two family members came through our family support group and asked us for help, for access for their loved ones, because the pharmacists in New Jersey do not inject, do not actually give people their dosages of LAIs in our state. And we are not alone. In addition to New Jersey, it's Wyoming, Nevada? New Hampshire. Thank you. And us and two territories, Puerto Rico and DC. So all of the other states do have access to pharmacists giving these medications, but in those other states do not. So we got very interested, and these family members are very interested in working with us for advocacy. So that's one piece. The second piece is, I know I'm dating myself, but I'll go for it anyway. In the 70s, I worked in deinstitutionalization. And we were, actually I ran a program that brought individuals out of state and county hospitals who've been there for 30 years, 40, very, very long periods of time, and brought them into the community. And it was an amazing and highly successful initiative. We had tons of money, but almost everybody had no experience with compliance. And we had many, many, many people on long-acting injectables, and it was highly successful for them to live in the community until they became acclimated to understanding compliance and more independence. So it was just wonderful. And then third, a board member of ours who serves on our policy committee, who's very helpful, and was talking to him about it, and he says, quote, I have a 22-year-old male that I've been treating for 2 years, who had a very difficult adolescence. He's been on an LAI for 3 years and has not missed a month. He just became a certified auto mechanic. And that's another success story. So we've got lots of these. We're going to talk a little bit more about it today. I'm going to give you more information on our speakers. Deb did a cursory. But Patrick, welcome. From Otsuka Pharmaceutical, Director of State Government Affairs and Public Policy in the East. And you're currently the Director of State Government Affairs and Public Policy. And you began your career in the Maryland Senate as an aide in the Senate for 2 legislative sessions. Following a few years as a defense contractor, you returned to government affairs at Stateside Associates, where you were a manager of the Legislative Affairs Division. And after departing there, you joined National Psoriasis Foundation and was tasked with starting a state government affairs program. And at Otsuka, you're currently charged with driving mental health access legislation and protecting company interests in 13 state regions, including the state of Maryland, where you reside with your wife and 2 boys. And when not lobbying, you'll find him somewhere on the water in the Chesapeake Bay.
Thank you, Barb.
You're welcome, certainly. We have Fred Ryan. Welcome. You're Director of Policy and Government Relations at Alkermes, and formerly, as Debbie said, Chief of Police of Arlington, Massachusetts. You're the Director of Policy and Government Relations, and the company, Alkermes, is focused on developing innovative medicines for serious mental illness, addiction, and other central nervous system disorders. In your role, you lead strategic engagement with policymakers, advocates, and stakeholders to advance access to evidence-based treatment and support systems for individuals living with behavioral health conditions. And prior to joining Alchemies, you served as Chief of Police in Arlington, Massachusetts, where you were nationally recognized for pioneering community-based approaches to mental health and substance use. So welcome and thank you.
Thank you. It should say, grew up in the projects, public housing projects about 4 miles here, the son of an alcoholic who treated her serious mental illness with alcohol. And as the police chief, I had shame around, my mom being in my jurisdiction where I served as chief of police. And so that's what it should say, Barb. Okay. Yeah, grew up in the projects 4 miles from here. Thank you.
So we're going to tell you a lot more about LAIs and the impact, but I'd like to first put this out to Patrick. So what would you say are the most significant policy barriers limiting access to LAIs with people with serious mental illness?
And I'll let Fred come in here as well, but, prior authorization in step therapy is something that I think is a significant barrier, when we're talking about a patient community, that continuity of care, right, immediate treatment when that doctor-patient relationship comes to the point of someone agreeing to start an LAI, any delay in care through prior auth or a step therapy protocol is unacceptable. And oftentimes I think we hear insurers say, well, that prior auth took only 4 hours for it to come through. When you're in crisis, that's a lifetime, right? So we find that to be unacceptable, and we'll talk a lot about, some of the things we're working on in the States on that.
Exactly. And how about from the patient perspective?
Well, the whole notion of patients and providers should prevail, right? Any policy that gets in between a patient and their provider, we're going to, scrutinize quite closely. One area that, and Patrick's intimately familiar with this, is payment for reimbursing LAIs within inpatient settings of care. And this is where we need the help of our MHA state affiliates, is that in most states in the U.S., think about it, inpatient therapeutic environment with your provider and the support team, and LAIs are not are wrapped into the daily DRG rate, the bundle, and not able to be reimbursed or carved out separately. Now, we've done some work with our partners at Otsker and others, where in Massachusetts, Virginia, Georgia, and Illinois, we've been able to work to create a carve-out for reimbursement for LAIs within inpatient settings of care in those states. And that can be done both legislatively as well as by the executive branch. In Massachusetts, we met the governor and her policy team and educated them on this. And contraceptives are carved out from the daily bundle. Why not antipsychotics? So that's a critical area and a huge opportunity in the balance of the states and territories in the United States.
Yeah, where reimbursement is key. And hospitals would be reluctant to initiate a therapy if it's got to come out of the DRG because that's a loss for them. So certainly a driving financial consideration. Anything else on the patient side that you think is critical?
We don't have enough time to go through the critical things, but yeah, we'll get to some more here in a minute, yeah.
Yeah, good. So examples of state legislation or regulatory changes that have improved access that you can talk about and what we can learn from them.
I'm going to let Fred go first on this one.
I just touched on the reimbursement carve-out within inpatient settings of care. And then we're working with MAMH in Massachusetts and Donna and her team and working on eliminating prior auth and steps for antipsychotics, right? I mean, you think of a disease state where, as Patrick pointed out, any delay in treatment potentially results in losing the patient, interrupting the continuity of care, compromising that continuity of care back into the community from an inpatient setting. And all of these setbacks, administrative setbacks, if we're truly patient-focused, brings the patient back to, in many instances, square one in their treatment journey. And so that's the work that Patrick and I are focused on: steps, prior auth, and reimbursement for antipsychotics.
And I'll add in there, it's if you went to the Medicaid panel yesterday, the Medicaid budget panel, someone made a joke you often hear. If you know one state Medicaid program, you know one state Medicaid program, right? And so there is no 50-state approach to these barriers, right? You have to be in the weeds and understand not only the Medicaid system, but that patient population in that state that is unique. And that's where we rely on many of you in this room, because you are the best connection to that community. You understand what their needs and what their barriers are, individualized to that, not just that state, but that city or that county, rural or urban, all present different challenges.
And that's where we need your help. I mean, is getting a champion within your states to take these issues on and lead. They don't want to hear from industry, right? I mean, Patrick and I and our colleagues are in the room, Sandra and Joey and others, Mary's from BMS. We work on policy. So a lot of the work I do benefits Patrick's company, but that's okay, because the patient ultimately is what we're focused on, and we're truly patient-centered in our work. And that's what's fabulous about the work that I did as a police chief around the flawed policy of criminalizing mental illness and addictions, and now being able to do this work for Alkermes is truly rewarding, but we can't do it alone. That's where we need you all and your voices.
Yeah, so one of the things that we've been doing, and along with our Mental Health Coalition, is to help legislators really understand the impact of what prior authorization can mean when it doesn't work well. And it doesn't work well very often. And there's a lot of national attention and state attention on the fact that prior authorization is highly cumbersome. One sidebar example: New Jersey's in the process of carving in their behavioral health services into managed care. We've previously been a carve-out state. Well, it's not working. The prior authorizations are just not working, so they had to extend the deadline of individuals just getting a pass and not having to abide by that, because the administration of these programs are so highly cumbersome that individuals can negatively get impacted by having gaps in care. That's what we help legislators understand: boots on the ground, what happens to people with these decisions. So it's really important that we do have these partnerships. Just one aside, so in New Jersey, where we do not allow pharmacists to administer LAIs and where family members have come to us, we are going before the Board of Pharmacy, and we are going to do advocacy and ask them to really reconsider their archaic policies of not allowing pharmacists to administer. So,
and you have pending legislation. Thank you for getting that introduced.
Working on that. Some states we talked about. Do you want to talk about the states introducing legislation to eliminate prior auth?
Yeah, and just a little bit of a background, if you haven't worked on step therapy reform, the genesis was really out of Connecticut back in the early 2000s with a broader step therapy reform bill, right? Just not disease specific, just about the appeals process, right? Which is layered in multiple layers, right? You have your internal, external appeals, and then appeals with the states. And now the National Psoriasis Foundation still has their website up. They've got a great map. You can see where all the protections are. It's truly become a 50-state campaign where there's more than 40 states that have that. The second iteration became in the cancer space, what's referred to as the Jimmy Carter bill, which carved out cancer. Then the serious mental illness bills, and some have been around for the protections have been around for quite some time. But the serious mental illness bills started getting a little bit of steam. Right? Michigan's had protections for, nearly 2 decades in place through their budget, and then they codified it. And there's a patchwork of over a dozen states that have protections within their Medicaid departments, right? Or Medicaid programs. Some of it is as simple as a DAW, a dispense is written, right? Some of it is very complicated in how they structure their formularies so that there's only a preferred formulary. And some of it just says straight up, we will not allow for the use of step therapy and prior authorization, for these certain diseases or the AP class, right? And there's been some success in a couple of states. Colorado, with the help of a great mental health coalition out there, passed a single-step bill, which often is not the worst compromise, right? Gets around some of the issues we'll talk about with these bills. We've had some success in Maine in the commercial space due to some of the people in this room. We've had some barriers too, and we've run against some walls. And what's going on in with the federal government right now and the big bad bill, HR 1, is going to significantly complicate our future efforts. But where we have been successful in getting these bills across the finish line has, to Fred's point, has not been because there was an army of pharma lobbyists there. It's because there's been small coalitions of mental health groups, and that has been the mechanism that has got us across the finish line.
And access, just always to keep that front and center, why is it that in New Jersey, if a psychiatrist prescribes an LAI, but they don't have the capacity to store the drug and to administer the drug in their offices, and many don't, why then does that individual have to then find a nurse practitioner and make a separate appointment to get the drug administered when pharmacists are perfectly trained and capable and able and have the resources? They're able to give immunizations. So what's behind this denial? What do we think it is? Stigma. So, we're very concerned and want to really keep on this and go public if we have to, because pharmacists want to do this. And it's really important. They're such a vital role in our community in terms of access. And we know that this will help people to really be able to utilize the drugs they need to. Yes?
I just want to piggyback onto what you just said about New Jersey, and just to do a shout out to Mental Health America Colorado, where I worked with them. My name's Sandra Western. I'm with Alkermes. I'm Fred's colleague, but we worked hand in hand with MHA Colorado on a bill in 23, really around pharmacy, the pharmacists being able to administer LAIs. They had the legal authority, but didn't have the ability to bill for it, and to make it be a pharmacy benefit. So we worked hand in hand with MHA Colorado, and it wasn't. I mean, it's just so important, this partnership that the patient advocates and MHA Colorado kind of brought forward. That was really in a state like Colorado, where they are very patient forward and patient focused. I just wanted to put add a little, so if you want to talk to your friends in Colorado about what they did there and maybe steal some ideas for the New Jersey playbook.
Sounds great. So any emerging data that supports the legislative concepts?
Yeah, so I mentioned some of the barriers. The fiscal notes on these bills are the problem. It is the resistance point. And it's only been, we talk a lot about what the insurers think and how we're going to negotiate, and those are all important tactics, right? And the patient voice is incredibly important as well. But the fiscal notes are not something you can just plow through. Now, some states will actually just ignore it and not put it in a budget, and that's positive that we have that mechanism in some states. But even in New Jersey, where we got an indeterminable fiscal note, and a potential for cost savings, it's stalled in the Senate right now because they're worried about cost, right? So at OTSCA, we saw this problem years ago and said, where are we going to get the data? Because we know that step therapy and prior authorization is costing the system money. Everyone's been saying that, for years. There's a small study out of Georgia from 2004 of schizophrenia patients, very small. That was basically all we had. So we conducted what is now essentially a 3-year process to compare a set of patients that are on an AP in Michigan, what that population is costing the state for everything, for hospitalizations, for doctor visits, for their prescriptions for serious mental illness, but they're for prescriptions overall. And then we compared that to states. And reminder, Michigan's had open access for a very long time. So we compared that, and not me, by the way. Political science does not mean I'm a scientist or a data analyst. So we contracted out with a third party to do this. And we compared it to 5 different states that have varying degrees of prior authorization and step therapy requirements. Some very strict, some a little bit looser. And shocker, what did we find? Michigan is spending less per patient. Now, in some areas, they'd be spending a little bit more. In some states, they'd be spending a little bit more on serious mental illness medications, right? But their overall prescription costs were down compared to other states. So we're now, this data was actually just published in a journal. I'll make sure that, in the follow-up that we can get that sent out. But we now have this data to show legislators and to show the fiscal office and say, we're calling your bluff. The problem it can be is that the Medicaid departments are stretched. And so when the legislators go to them with, their 1,000 bills a year that they need analysis on, who does the Medicaid department go to? They go to the PBM, and then the PBM says, oh boy, that's going to cost $50 million. You better not do that. It's always a round number, by the way. There's never a sense in there. And if you ask them to challenge underlying data, they can't answer your questions, right? And I do feel bad for the Medicaid departments. They are stretched thin, and they have a lot to be dealing with in the next few years. But we have this tool for them, right? So what we're doing now is we're meeting. I'm going down to Tallahassee. We're meeting with the ACA secretary there in the next few weeks. And we're going directly to the leadership and saying, here's this data. We know that these fiscal notes it was 20-something million in Florida this year. We know these fiscal notes are true. And also, here we are providing a solution to you. You're strapped on your budget. Here's cost savings. So that's the data, and it took us 3 years to get it put together and published, and we're very proud of it. We think it's going to make some serious change this year in the process or the progress of these bills.
And you need the right people to look at it and understand it, too.
Yes. I can present that one pager, right? But putting it in the hands of the mental health advocates that can talk about it, but then also talk about their personal stories and connect them to the data is the sweet spot.
So it's cost and access, both. How about what all these people here can do to help on both the access side and on administration and cost?
Well, I mean, you're our champions, right? And so with the data that Otsuka has done an extraordinary job putting together, because I couldn't agree with Patrick more. We started working in Virginia. My colleague Michelle just walked into the room, and we got it past the House with an outrageous fiscal note. It died in the Senate. This is the reimbursement, inpatient reimbursement for LAIs. And we got to the executive agency, to the Secretary of Health and her staff, and everybody in the room collectively agreed the fiscal note was nonsense and not based on evidence. And when we started having an adult conversation about what the actual cost savings would be in terms of driving down rehospitalizations, driving down emergency room visits, driving down ambulance trips, incarceration, and all of the other, services that this patient population draw upon, it became abundantly clear that this policy saved the state money rather than cost the state money. So this study is going to be huge. We intend to try to get approval to use it. I'm not sure whether we'll be able to or not. But taking that data that Otsuka's put together and being our champions is really, that's an ask. That's a Fred Ryan ask to our MHA affiliates. We need your partnership. We need your advocacy, and we need you to help us champion these good policies. And yeah, all the fiscal conversation's great, and at the end of the day, for me, it's about the patient, right?
Yeah,
it's about the patient.
Can I share a real quick story? So, in New York, a long time ago, when the step therapy bill was there, the broader step therapy bill, it was languishing for quite a few years. It had a huge coalition behind it, huge. I mean, probably about 24 patient groups, patient and provider groups, all doing incredible work. We couldn't move it. And at one point, we found one patient advocate who had an incredible story, and she had a connection to the right legislative leader, and we had an advocacy day, and there were like 100 people there, all sharing their story. But this one woman's story, she sat down right outside the chamber, sat in some chairs for an impromptu meeting with the legislative leader, and just told her story. And then he looked at her and said, "We're going to get this done." And the bill passed like 2 weeks later. That's all it takes sometimes. And so we need to work even harder to create those moments for these serious mental illness bills and for our reimbursement bills, right? All these access points, because it's only the stories are actually going to be easier to come by, unfortunately. Where we're heading with coverage and with Medicaid is going to be hard times for us. And so we got to lift that patient voice and that provider voice to make sure that it helps find solutions for us.
Right. In New Jersey, for example, on the step therapy bill, which is, we worked with all kinds of disease states, our colleagues really across the board in the area of diabetes, in the area of IBD, all the inflammatory diseases, because a lot of those are even more heavily impacted by step therapy. I have a personal story of a friend's son who was diagnosed with Crohn's, and they insisted that he go on a steroid first, and the pediatric physician insisted they go on Humira first, and so they lied, and they said this is what they do. I mean, they said that they put him on the steroid, and they didn't, and they put him on Humira, and that was it. So, that's just, it's not just in the area of SMI that step therapy is so impactful. And, what can MHA do? Work with our colleagues in the other areas too, because this step therapy and lack of access is just so negative in terms of treatment outcomes and what people have to go through to get the right medication. Just another side story.
Well, for example, in Maine, there's an oral antipsychotic that reduces the side effect of weight gain for bipolar populations. And now in Maine, they've added a 90-day step. Patient has to get reweighed at the prescriber's office. And if they've gained greater than 10% of their body weight within that 90 days, the PA is no longer valid. So now we have clinicians saying, "Oh, you must have your cell phone in your pocket. You're, 11% over your body weight, so we're going to," we're creating an environment in the clinical world where we're incentivizing being untruthful. That's a bad place to be.
That's exactly right.
Yeah.
And I know we're going to do questions here in a minute, but I did want to acknowledge, just in case I get a clinical question, I'm not going to answer it. We have Yasmin Togans in the back of the room. She's a licensed clinical psychologist, practiced here in the Boston area for a number of years. So if there's any follow-up anyone wants to do with her, please feel free.
Do we have any questions?
Go ahead, run that mic. Alicia, I'll bring that mic back. I'm going to start, because one of the things that really precipitated this panel was a conversation I had with Fred some months ago, where he told me in great detail the story of how the coalition here in Massachusetts worked with the governor's office. That is really novel. They moved that barrier out of the way through executive action. Fred, tell us a little bit more about that, because that's not something that usually happens.
Right. We had been approaching legislative leadership, around this inpatient access to LAI issue. And, part of the challenge that Patrick and I and our colleagues come up against, although we're well-intended and ethical business people, we're seen as industry by policymakers, and that's why they need to hear from you, not us. However, I did bump into the governor, talked a little bit about this issue. She suggested we schedule a meeting with she and her staff, and it really became a very informal cup of coffee, educational conversation about access to LAIs for this patient population. We obviously talked about the economics of the policy and all the things Patrick talked about, and that resulted in follow-up conversations with advocacy organizations and really educating an enlightened governor, right? And when the governor learned about this, she directed her policy staff, a woman by the name of Gabe, to work with the state Medicaid agency to fix this problem. And I was shocked. And this illustrates what executive agencies can do, Medicaid agencies can do. This thing got done in less than six months. It was effective April 2024. Hospital systems are now getting reimbursed for administration of long-acting formulations of antipsychotic medications. That was a joke, for those that missed it. In these settings of care. And so it can be done, right? And Virginia, Michelle's here. Same thing. We met with the governor's staff and the Secretary of Public Health and her staff. So it can be done through executive action. And the notion of an executive order is, we think executive order, we think of the current administration, comes with a negative connotation to it. Executive orders can be our friend in this access world. Thank you.
Deb, you had a question?
This gentleman back here.
I wanted to share another path to access for long-acting injectables. A clinician in Northern Illinois used one of our template medical necessity letters when they were encountering an issue with an insurer providing authorization. And I had just recently had a conversation with them about having a webinar for her and her clinical team, clinical colleagues. And she said, I'm going to pull out that template. She used the template, documented the medical necessity based on clinical standards, risk to the patient, which would include also potential economic risks associated with not doing it. And the approval came through within, I think, a day.
And that was private sector?
That was a private sector insurance.
And I think that's an excellent point, because all of this is a lot. A lot of it, we're talking, a lot of it is Medicaid when it comes to funding, but it also is in the private sector. Don't forget, individuals under 26. I mean, there's a lot of other people, your example, where private sector is also, we have to have access and have to have it reimbursed as well. So, good point. Thank you. Any more questions? Great. Well, thank you all.
Thank you.
Yeah, sometimes we really get into the weeds on this geeky stuff, but everybody in this room, we're the ones who are out there knocking on those doors, and I love success stories. It's wonderful. And I love the fact that we can always work together. That is so meaningful, that it's the people who need access to the medications, it's the people who provide the medications, and it often seems like we're really pushing against the people that pay for it, for sure. And it's just so wonderful to see us all come together and work together. We're going to switch gears a little bit. We were talking about things that have been around for a long time, like long-acting injectables, or that big long thing that Fred calls them. And we're going to think about the bleeding edge of what is happening right now. And that's technology. And what's happening in terms of, do we need to legislate things? Do we need to regulate things? What happens with this whole new world that is just unfolding faster than we can keep track of it? And we are really lucky to have our Kelly Davis, my colleague at MHA National, who is a terrific young adult leader, who is a terrific person who talks about how important lived experience is. And as Kelly says, because I'm going to quote you on this, Kelly says this, it makes me giggle every time. She says she loves acquiring more student debt because Kelly, on top of all her incredible credentials, is now getting an MPH at Harvard. And we are so proud of her. And she is doing a fabulous project that I think is going to really interest everybody in the room in terms of what is happening in technology and how we have to think about it in terms of the states. Coming up, Kel.
Is there? Okay, yes. I think I have one. Yeah, that's me. Okay, cool. Hi, everyone. It is great to be here with you all today. As Debbie mentioned, I'm going to be talking about what's happening in states specifically around mental health technology, and then what advocates can do, particularly around policy and influencing decision makers, because the field is growing really quickly. And as often happens with technology, a lot faster than government is or has the ability to act on. Okay, so today we'll review what we know and what we don't know, what's already happening in states and cities, some key considerations for decision making, and then pathways and opportunities for community engagement to make sure that we are minimizing harms and also maximizing the impact of technology. So, Debbie mentioned talking about and the importance of lived experience. I am a person with lived experience and like to share, what it's like on the other side of these policies and decisions that are being made that impact real people across the country. So I'm going to talk about some of the problems that technology in mental health is able to address, my experience with the benefits, and then some of the potential concerns that I learned about when using them. So as folks in this room know, from your own experience, from being a family member, from your work, finding help when you are struggling is really difficult. Most of us aren't like, I'm doing so good, let me find a therapist. So by the time you're asking for help, generally speaking, you're really struggling. And what happens is a couple things, right? If you have insurance, you reach out to your insurance company, they say, here's a PDF with 100 names, good luck. I'm not going to give you anything about who they are, what they do, and you're forced to navigate that on your own. And what we know from studies on ghost networks, right, is that what happens on the consumer side is you often don't get a response. They're not actually accepting insurance. They do not have any availability. And you have spent all of this time reaching out and end up not with any support. If you're not going through your insurer, the other pathway that often happens is you go through a platform like Psychology Today. You go to the website, this is what I'm struggling with, this is what matters to me, this is where I live, this is my insurance. You get your list of names, and again, you reach out. You send emails, you call people, and often they actually give you a bill that you can submit to your insurance. And they don't bill your insurance, right? They add that administrative burden, or they are not actually accepting your insurance. They might not necessarily really have the expertise that's listed on their profile. They might not be accepting new folks even when their profile says they are. And I think if you're thinking about two things when you're first asking for help. One, how time sensitive it is, because every email you send, every person you're waiting to respond to you, like I said, most of us aren't doing well when we ask for help. That's further and further out than you figure out when you can get access to support. On the other side, and I know many of us, in the peer community realize this and experience this when you're navigating any systems, is that often this also requires you to share over and over and over again in writing and on the phone some of the worst things that may have happened to you, or some of the most sensitive and painful things that you're dealing with right now. So it's pretty demoralizing. On the one hand is you might do all of this asking and not be able to get support, and on top of that have to repeatedly disclose the things that you're struggling with. And when it's your first time asking for help, often there's a lot of shame and distress that you experience on being the person trying to get help. So the first platform I'll talk about for me, as someone who has insurance, right, that's a whole other thing, and who lives in a state where there are providers in Virginia, I found a platform that, and I'm not going to name platforms, any similarities are purely coincidental, and we do not endorse or not endorse any platforms, but I'll say that I did find a pretty popular platform where I was able to say, okay, this is what I'm struggling with, this is my insurance, this is where I live, and then not only do they give you a list, they give you their schedule. So you go in, you read about these people, you pick the thing, you pick the time that works for you. If you're willing to wait, if you can't wait, right, you can see who can take you sooner. And I think the other thing that was really helpful for me with this platform is that the first therapist who I was working with went into like fully private pay. So this gap in care, right, that we would often experience, I just went on the website, right, and I'm like, all right, let me find someone else. So it really solves a lot of the logistical issues on the access side, but also for the providers, right? The platforms are doing billing, they're doing the scheduling and coordinating, right? One of the promises of technology in mental health is really being able to make it easier and more accessible on both sides. The other platform, I used a very well-known and well-advertised platform, and there were two major things for me. First, I logged onto their website and was immediately disqualified from their services because I had a history of suicidal thoughts and suicide attempts. On our side, I get why. When I'm looking for help, I do not care, right? And if you can imagine, when you ask for support, what it feels like to be told, we can't help you because something's too wrong with you. Because it doesn't matter what we say, that's what it feels like, right, on the other side. So then I did what we all do, which is I lied. And nope, never any of those things have ever happened to me in my life, and got a therapist through the platform. And so what happened was I had my call. It was not video, it was phone-based, and I heard a noise in the background, and I'm like, what's that noise? And she's like, oh, I'm driving to work. I was like, what? Okay. And the funny thing, well, it's not funny, now it's funny, that happened is she actually had, I was there for PTSD, she had the same trauma part, and she says, oh, I wrote a book about that. It's on Amazon. I'm going to give you the link. You can buy it, and we can talk about it. I bought it. It was not very good. But a couple of things happened for me, which is one, I'm like, when I get over this, it's going to be such a good story for me to use in presentations. I call all of my negative experiences field research. It's a very, very good, what's that, like a CBT skill I got somewhere. But the other thing is I got angry because I know it's not supposed to work like that. But for people, this is my only time I almost cry, I promise. If that's your first time asking for help, it's your first time saying you thought about killing yourself, and they say, sorry, we can't help you, that's brutal. If you feel really isolated and alone and like no one cares about you, and your therapist is doing like inbound marketing right through this mental health platform, you might never ask for help again. And you don't know, you don't have the experience and the knowledge, right? Like I have been in this stuff since I was 10. I've been in advocacy for 10 years. I know it's nothing wrong with me. But if you don't have that context, it feels like there's something wrong with you. So there's a lot of good, there's a lot of bad, and a lot of opportunity, I think. So just to go over, briefly, the state of mental health technology, what we know, what we don't know. I'm pointing in the wrong direction. I'm not a tech expert. Oh, this way, okay, thank you. Not a tech expert, but some of the examples of how mental health and technology is being used in mental health, right, in ways that I described for connecting with providers, reducing administrative barriers and burdens. apps with non-clinical support, so being able to do health management, self-help tools, kind of learning on your own. We have way more data that could be used to potentially predict things or help us make better decisions. And then finally, more options for people, right? Because as it stands, you're struggling, you try to find a therapist through the whole thing that I just mentioned, or a psychiatrist, and there aren't necessarily more options for people, or there haven't been, that meet their needs or maybe aid in the things that are most important to them. I always think it's important to name that a lot of people are making a lot of money on this, and that may or may not influence what they say they can do, and how they are influencing the world. And I think there is more and more money going into this field. So the problem is that we have some real foundational questions across these apps, these platforms. Like, number one, are they good? Are they good, right? Does this work? Is there evidence for this? Is it safe? Do I have protected privacy? Where's my information being used? Do people understand it, right? Health literacy, tech literacy. Do I even have the technology? Do they impact different communities differently? Are there disparities in who gets the technology, but then in how it impacts them? Do people want it? And do people use it? Because there's a huge problem within tech around people download things, sign up for things, and then there's massive drop-off. There's a huge continued engagement problem. And one of the most important things is who's deciding this at all? Because those are big, big questions. And interestingly enough, a lot of these platforms do not have a history of engaging clinicians in leadership, let alone their intended users and the people who will be impacted by the decisions that they're making. So briefly, just to go over some of the things that are happening within technology, right, is just like we saw with social media. There is always this balance that is talked about around innovation versus regulation, right? Is what might we do that could help more people get access to support versus put in a bunch of research requirements that mean we're creating barriers for things that could be helpful for people. Under the current administration, it does not seem particularly friendly on the regulation side, but this is just a screenshot from a report from the Commonwealth Fund about how many different people are involved in federal decision-making about this technology. There's a growing use of research and academia on some of the payer sides of being able to really demonstrate that what you're saying helps people. Some of the associations are putting out guidance for their providers, and the public doesn't have much education about what to expect, what's their privacy. Within state policy, there's been a lot of action specifically around artificial intelligence. A lot of it is either not including mental health specifically, but might impact mental health. A couple examples that have gotten a lot of attention are from Utah and Illinois, with work around creating parameters around what the use of AI and what we call things when we educate the public about what they're actually getting access to. Utah also provided guidance and guidelines for mental health professionals in the state. I keep pointing the wrong way, who are using technology. But the problem is, just like most of the people made ChatGPT their therapist, government is putting hundreds of thousands, millions, and hundreds of millions of dollars into these platforms. And we have all of those questions. And I said there's promise, but there's real downsides and things that have happened. So just to go over a few of them, within New York City, the city partnered with Talkspace to create something called TeenSpace that, very exciting, provided free access to support for teenagers across the city. With its initial launch, a child privacy group audit found that within their landing page, they were documenting user information and selling it to advertisers. And that shouldn't have been surprising, because it's pretty well known that these platforms were doing it, right? So how was that built into the decisions that they were making? Another example is the growing use of artificial intelligence to surveil student technology. I think we all want to prevent youth suicide, right? It's very important. It's why we all do this work. But the problem is, like, we're not good at that. These algorithms are not accurate in terms of what they're flagging. There's a lot of risks with that, like outing LGBTQ youth who might be looking into getting help for the first time. We know with artificial intelligence, like these models use data, and the data is from the real world, and there's lots of disparities in the real world, and there's evidence that they're showing up in this technology as well. And who's more likely to not have a personal computer to use outside? Critically, some of the platforms, like as part of their implementation, they partner with law enforcement. So it's outside of school hours, you get flagged, you're actually just like looking for help for a friend who's thinking about suicide, and you get a wellness check from a police officer. For me, that does not feel like a good way to inspire faith in or trust in mental health support. And also, during an investigation with the Seattle Times and Associated Press, they accidentally released thousands of unredacted student documents to journalists. So real issues with privacy. Other well-covered incidents that you may have heard of, National Eating Disorders Association chatbot gave people diet advice. Within Pennsylvania in child welfare, there was a predictive tool used within child welfare that discriminated against people with mental health histories. And then another example of a telehealth platform in multiple states, again, data breach released thousands of people's personal information. But I think at the same time, right, this is happening, but it is not necessarily clear. I mean, I see people in the room nodding their heads. Like, it's like, if you ask us, duh, right? Like, all of these things were going to happen. There's going to be all of these issues. But the problem is that whether or not they're actively making choices, they're making choices, right? It's like states are deciding what's good and what's good enough. How much information do I need about how helpful this is, right? In what way? Do people understand their privacy? Do people have access to the technology? What are companies required to disclose? All of these questions. And I think one of the most important ones broadly is like, this is government funding. Who are they answering to? And for what? I think these are all really important questions that we haven't really thought through. I'm not a tech doomer, which means that I don't think that AI is going to ruin all of our lives and technology is the end of everything. I actually think that it's a really great opportunity to, for the first time, maybe create an accountable mental health system. So there's a lot of critique of telepsychiatry apps, right? Because they're, some people will call them like pill mills. They're incentivized to provide as much as possible, but I feel like I hear all of the time, like the problem with fee for service is that people are incentivized for units and volume. So is it possible that, aside from their awful privacy and advertising, it's a whole other issue, is it possible that it might not actually be that different from what happens in real life, and it's exactly what would happen if we scaled, no matter what pathway you got to services? And I think, with this information, right, we want to get as many people as much support as possible. So I think it's, people need options, and I think because this is happening quickly, and we know the power of actually including folks impacted in by policy and making policy decisions, I think there's some really cool things that we can do to make sure that while we're investing in this technology, that it's really meeting the needs of people. So a couple examples that are being used that I think could relate to what we could do with the technology platforms within Washington State, their 988 rollout. They require someone with lived experience to be on their steering committee. They require a lived experience subcommittee. They are helping to evaluate and oversee the impact, the data, and then do public and community outreach to hear the stories of people and how they're being impacted. And I think we could do something similar with mental health technology, should we choose. A lot of states, including Louisiana, are building dashboards, right? So if you're in Louisiana, you can look online at a dashboard, and it shows how many 988 calls are coming in, what percentage of them are being answered, what people are talking about theoretically, right? We could have that kind of public accountability and transparency within mental health tech. And then finally, another example, right, and in this big push for quality and helping and supporting people to make the best choices for themselves, we already collect patient experience data within hospitals that many people don't know about, but could theoretically, if you did know, help you make decisions about where you go to get support. And I think if states are funding this, then it would be really important for people to be able to see what they should or should not use, and then this added piece of who is or is not being served by these platforms and why, or why not. Another example, right, engaging people with lived experience in the peer community to create more trauma-informed and empowering resources. So when seeing that school surveillance, whether, like, people have differing ideas about whether or not they should do that, but they are. And immediately, you know, we work with this youth peer organization in Oregon called Youthline, and they have a peer-reviewed, like, academic study where they were able to, through trained and supported teen outreach, engage thousands of young people who were expressing thoughts of suicide and self-harm online. So wouldn't it be better to get a message from another young person than to get a wellness check from a police officer, right? And then finally, community engagement. So key to mental health, right? Like we talk about clinical measures, quality of life measures, and when we're pushing folks to these apps, I think the money is the money, right? And we're going to put it somewhere, and I think it would be a really massive error to not also emphasize in community and in-person resources. So could we require these platforms to have specific partnerships or relationships, or to set aside specific funding so that we are, while we're trying to reduce people's PHQ-9 levels, we're like destroying the social fabric of their communities, and we know that that's actually really important. So how can we make sure that this is not just getting people to log onto their app that we're paying for, but to really promote and connect their well-being in the community? If we don't act right, I shared some examples. There's a lot of risk, harm to individual people, privacy violations, rights violations, poor quality, public trust. You know, everyone in here knows it takes like 1 or 2 stories to be like, oh, I'm never using that. So public trust is really important, right? Lowering the quality of services, and also the decisions that we make with that data. If we are now these like data-driven decision makers, and we're using predictive technology, if we're putting the wrong information in, we get the wrong answers. And then finally, a misuse of public resources. Like I said, we have X amount of dollars. We want to make sure that we're using it as efficiently as possible. Some of the ways I think that we could do this that currently do not exist are having folks with lived experience and advocates being involved in these responsible tech guidelines that states are already starting to do. Having people with lived experience and advocates developing and working with states on their procurement strategies. So what's required to get the money and what's required to keep it? And who are you asking and who's involved, right? Paid staff and advisors, engaging community members in evaluation, like I mentioned with the Washington's 988 work. They are literally talking to people in the community. Shouldn't we do something similar if we are scaling all of the support? And then finally, really making sure that as we do this, we are not destroying and taking all of the funding away from organizations in communities who are actually building communities, because we might be trying to solve one problem and worsening a whole massive other problem. So I think, you know, if we are really committed to collaborating, to supporting states, because part of the problem is like, not only do people not have the knowledge to make decisions about their own, you know, they don't have the knowledge about privacy. Has anyone here ever read a privacy agreement? I'm like, oh, now they make you scroll to the bottom. I'm like, oh my God, right? So like, people don't know. The people who are making the laws don't know. The people who are making these decisions don't know. So I think there's a lot to catch everybody up on at the same time. And if we do a good job, we can make sure that advocates and people with lived experience are at that table, so that we're effectively using resources, right, advancing real quality in a way that, again, we've never been able to see before. And now, with this massive shift, I think it's actually an exciting time, and definitely a lot can go wrong, but an exciting time for us to measure and hold mental health systems accountable for quality in a way that we've never been able to before. So this is my initial presentation. I'll be, Debbie mentioned, this is part of my practicum for my Master's in Public Health program. I will be speaking about the findings and more state examples at MHA Policy Institute before our annual conference. So if you care, you should show up. Just thank you all for listening and for all you do. And I think we're at an exciting and important time for everyone here to really help shape a lot of these big decisions that are going to be made.
Thank you. That was perfect. Thank you. Okay, we're getting to the end, but we might need an extra 5 minutes. I'm going to invite up some of the most important people in the room, namely our Regional Policy Council representatives who pull everything together, our dear Ben, who we've heard from, and Barb, and you're going to hear from Shauna, and you're going to hear from Shelley. I also am expecting a legislator to pop in who was going to be here this morning, but he texted and said, can he come over now? So come on up, guys and gals, but we might take, if everybody's cool, an extra 5 minutes to hear from one of the legislators who has done so much, and we're so proud to have as a friend from MHA, and if he pops his head in the door, I'll introduce him, but you want to hear about what all of our affiliates across the country are doing and how to share that information. So in any order you all would like, I'm getting out of the way.
Hi, everyone. I'm going to be really brief. Can you hear me? Okay. Challenging times, unprecedented times. It is very difficult, in my opinion, to get people to work on proactive projects when they are so busy being reactive to the environment. And so that is sort of my snapshot of the landscape. And it's true. So we are working very hard. So that's one thing that's happening. Also, I'm finding a tremendous amount of cooperation that I've never seen before. So, out of bad comes good. So we are working with so many partners now that we've never had the opportunity to work for before, because we all are banding together for advocacy, targeted approaches, targeted audiences, and the masses are really joining force on messaging. I'm very proud of New Jersey that we haven't done a lot of splintering off. Initially, we were very concerned about the hospitals kind of going their own way and looking for deals, and we haven't seen that happening yet. But, lots of coalitions going on. We're joining everything. We're being part of every team. We're leading some. And it is a real spirit of cooperation. So that's my take on the environment.
Shelley Polanco. I'm the Director of State Policy for Vibrant Emotional Health. I oversee some of the state team in the Public Policy Department. And this year, every state had their session this year. And one of the things that we do, basically kind of track across the country, it's a small little team of 3 people, checking out every state, working with our advocates, just to have states create funding for 988, to educate their legislators about 988 and behavioral health and just the need. This year has been different than most, but has been exciting to see that now 13 states have passed 98 funding. This year, Illinois and New Mexico kind of have some partial funding. It's a little bit different than other states, like with surcharges. They actually started like partial, taking some funding from somewhere else, but still a really big step forward. And even this year, 11 states introduced 98 like information or kind of some sort of funding. Although those didn't pass, we still see it as a success. Just starting that conversation and states kind of really educating people on what 98 is. And another thing that we also track in our department is just the access and awareness of 988 specifically for student IDs. So that's another thing that we've been educating folks on, just how we can create that access and awareness for our youth. So we've seen a really big uptake, especially this year, on just like states passing 988 on the student IDs or whichever way they want to add it. Some states have gotten very creative with that, but it's still a step forward. And last year as well, I highlighted up there that U.S. Virgin Islands also passed a fee, and that's going to be of $1 per line. Although they don't have an actual center, they are going to start basically creating that funding so that they can start and open up a center in the U.S. Virgin Islands. I did want to highlight a key milestone as well, that this year Texas and North Dakota actually started and introduced a fee bill. Although those did not pass this session, they did went on and create a trust fund. And the unfortunate thing is that they only meet every 2 years, but that conversation started, and our advocates in Texas really were amazing this year and did so much work to get at least just the trust fund passed. So that has been a successful thing, and just kind of, again, creating that awareness and just the opportunity for folks to do that. And just another thing that we have been also doing as a team is reading every single state budget. So again, it's only 3 of us, so this has basically been our summer project. And right now we have confirmed that 15 states have passed some sort of funding in their budget for 988 or behavioral health services in their state. So, again, still creating that awareness. It's a slow start, but has been a great way to see from when I started 3 years ago and 988 launching to where we are today. So I'll highlight that.
I got it. So one of the things I wanted to speak about is a quickly growing trend among states, and I got to tell you, Tennessee is late to this party, but a growing trend among states to legislate when cell phones can be used in schools, right? And so I know our Massachusetts friends are experiencing that conversation right now. Started in Florida, I believe, and a number of other states have picked it up. Of course, there are some pros to the legislation. Obviously, a focus in the classroom on learning, which is always good. That's what's supposed to happen. A secondary benefit, which is really kind of fascinating, when my kids were little and you were in the cafeteria having lunch with them, there was this red light, green light on the wall. And if the volume got too high, it flashed red. So it's kind of fascinating. Now what they've got in a lot of states is the kids aren't communicating because they're on their cell phones. So you take away the cell phones, and now what do you have? They have to use their verbal skills. They have to have a conversation. And so now the hallways between class are like that cafeteria when the noise got too loud because the kids are talking, which is really kind of fascinating. But the reality of this gets to, well, why are they doing this? And the reason to do it is to improve academic improvement and communication skills, but also to reduce the distractions, right? Now, if you've not thought this one through, you need to understand your Pavlov and the little doggy and the dog getting taught how to ring the bell and he's going to get fed. Same thing is true with cell phones. It's industrial psychology. That phone buzzes and someone's phone is going to buzz in a minute here probably, you're going to look at it. And so if a young person is in a text chain or a WhatsApp group or something like that with 5 other people, 10 other people, one person responds, another person responds, and it's ding, 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 ding. And so it's very hard for others in the classroom to maintain their attention. It's hard for your child to maintain their attention too. So those are some of the pros. Now, obviously when there are pros, there's some cons. So this is where the real opportunity is to help shape any legislation there to make sure you get the things you really need out of it. The safety issue is huge. You know, you're going to hear from families in your community about, oh, my child needs a phone in case something really bad happens at school, right? And that's true. But the way to control that is just make the legislation get it written in the legislation. The cell phones have to go into the student's backpack or book bag, right? That way they still have it, right? You can silence the volume. They still have it. So if there is a safety issue, then they still can do that. The same is true for any child that has a mental health need. They have an IEP. They are on a 504 plan. Again, that should be exempted from the policy and can be written into the legislation to protect those kids. The other thing is what my son, who's a high school teacher, tells me is we need to make sure the law gets in there that teachers need to be human and not police, right? And so that means if Sydney is going to walk into class and there's something going on with grandma, you tell the teacher, hey, you need to know I'm kind of distracted today because grandma's having surgery, right? The teacher's response should be, keep your phone. I want you to have access to it. That's being human rather than being police. And then the other thing about teachers and being the classroom cop is that, you know, it's easier to start out stronger and then ease up as the school year goes a little bit. And we've seen this with the school dress code for young girls with shorts and skirts. You enforce it in the first week, then everyone's behavior is kind of controlled, and then they can start to loosen that up as the class year goes along. So that's what I wanted to talk about.
Thanks, Ben. So I, in my last cluster meeting, we kind of mixed things up a little bit because usually we talk about policy things or funding things or, you know, what might be happening program-wise in our affiliates. And at the last meeting, instead, I asked the members of my cluster to talk about what they are doing to take care of themselves. And you would think it was the most challenging question I'd ever asked anyone in the world, right? Because for a bunch of people working in mental health, we are terrible at taking care of ourselves. And so we had this conversation mostly because it's just something I've been thinking about a lot lately. Because it's really challenging to do public policy work right now. It's just a really hard time to do this, and so I think it's important to name that and just to talk about that. You know, we all got into this work for a reason, and we bring a lot of passion to that, and so maybe it's personal. You know, we all work in this sector as well. Some of us lead affiliates as well, and so some of the funding cuts and things have made big impacts on our own organizations alongside the people we serve. So we may have had to cut programs or services or lay off staff. And you know, we put our blood, sweat, and tears into these things, and so it feels personal and it's stressful and it's hard. But even outside of all of that, and outside of the fact that most of us haven't stopped running since 2020, right? So setting aside all of that, it's just a really hard time, I think, to be working in public policy because everything we do feels under attack. And it feels like people are being blamed for their illness, like they're being blamed for needing basic things like food and health care. And that's gross. I mean, it feels icky, and it's really hard to go to work every day and fight against that, right? So we just talked a little bit about like the fact that that is hard right now, and so it is important that we acknowledge that and that we're taking care of ourselves. So we kind of talked about, how are we doing that? So we talked about it at the meeting, and then I talked with some folks sort of independently too. And for several people, their response was, I'm not very good at it, honestly, so if you hear any ideas you want to share, that'd be great. And one of the things that made me think about is, as leaders, what kind of examples we're setting for the rest of our staffs, and the people we serve, the people who work for us. And it reminded me of a friend of mine who works for a Fortune 500 company, and she and I were trying to plan a short vacation together. And she reports to vice presidents who report to the CEO. And she supposedly has unlimited PTO. So I was like, well, then I don't understand when can we take this vacation? Well, I can't take vacation, but you have unlimited PTO. She's like, well, the VPs don't take time off, so I can't take time off, and the VPs don't take time off because the CEO doesn't take time off, right? So what kind of example is the CEO setting? And I'm like, well, if you don't take time off, what does that say to your staff, right? So it trickles down. So those things just make me think about, what kind of example are we setting for our staffs if we're not taking care of ourselves, right? So just some things that I've been thinking about. Something else that one person shared was just the value of the affiliate network and how they really appreciate the fact that they've got folks to lean on who understand how hard it is right now to be dealing with all of this. So, I think that's what meetings like these are so helpful for. One person noted that she started using her gratitude journal and kind of diving in. She also noted that she's got one that's like a real feel-good gratitude journal and another one that's kind of like a snarky one, which reminded me that my CFO had given me one. I'm not going to read the title of it because it's got several curse words on the front of it, but it's funny, right? And so it's kind of a funny way to get home and be like, whoa, that was a day. One person, talked about, she kind of noted, I try not to work very hard. And I'm like, but I know for a fact you actually work very hard. So I think what you mean is you try not to work 24/7, right? So why are we calling those things the same thing? That's not accurate, but that's what it meant to her, right? So how are we naming those things in our heads, and how are we defining not working very hard? And for me, something that I did was to make a decision to step back from engagement in a board that I've been on for 4 years. So I needed to let something go. I just had too much on my plate. So I came up with a plan about 6 months ago and worked with the executive director to transition off this board. And so my last meeting was just last week. And I'm glad I did it. It was the right decision, but it felt really selfish. And to leave a charity board and all the good work that they're doing to spend more time taking care of myself. And yet it was absolutely the right decision, but I'm like, why does that have to feel selfish? And yet it did, So it was trying to kind of reckon with that in my head of that shouldn't feel selfish, just to step back. It can be someone else's turn to do something. It's not like I decided to step away to just do nothing else, right? I'm filling that time up with something else, I'm sure. But it just, I needed to let something go. And so sometimes it's not, in terms of self-care, it's not always adding things on. Sometimes it's letting stuff go too, So I just wanted to sort of challenge all of us to think about that, because I think it was an important conversation for us to have in my cluster meeting too, because it's just like it's a hard time right now to be doing this work. And I think acknowledging that and just putting it out there is important because we have a lot more to do. And if we just keep like sludging through, we're not going to be ready to like dig in and do more. So I appreciate it. Thank you.
Representatives would like to say? We need some beautiful pictures of them, Sid. Thank you. Thank you. Thank you all. So I hope everybody is going to join their cluster calls. You really want to hear from your reps. You want to hear from Shauna and Ben and Shelley and Barb. And not only do you want to hear their wisdom, they want to hear from you. They want to hear what's happening in your states, and they want to hear what you're doing. So I'm going to thank you, and I'm going to say your timing is impeccable, Steve. Okay, we got a special guest who I thought would be here earlier, and Steve, I'm thrilled you're here because you get to have one of the last words. So we heard in different things all throughout the day about things that are happening in terms of peers, in terms of preventing youth suicide. And Shelley just gave us, Shelley from Vibrant, what's happening in all the states for 988. I'm going to shut up and I'm going to let somebody who I am so honored to call my friend and who is a friend of Mental Health America, and that's Representative Steve Ellison from Utah, who has done so much in terms of youth mental health, in prevention, in crisis, and the guy that got the whole ball rolling on 988. Steve, come on up and tell us about some of the really cool stuff you've been doing. Microphone here or handhelds as you like. Okay, you bet.
Well, welcome. You know the old saying, better late than never. I kind of got caught up in the stuff across the street, and Debbie's always kind to have me come visit, so pleasure to be with all of you, fellow advocates. I'll share one quick story, and then I'll tell you a few things that we're working on that are really encouraging. So this is a story about failure and ultimate triumph. Myself and Senator Dan Thatcher tried for several years to get a 3-digit number for suicide prevention in Utah, and we failed. Utah only has 1% of the population. We couldn't even get it for the 1%. So big telecom flew in lobbyists to kill our bill, and I was meeting with one of their lobbyists, and he was explaining why this 3-digit, one of the N11 numbers, wouldn't work out on a state level, kind of regional basis. And I'm like, you know, he's making good points. And he says, but it's such a good idea, you should try to take this national. And I'm like, you know, sometimes the lobbyists will tell you anything to make you go away. But I was like, no, I think I believe him. And so in 2017, I ran a resolution calling on Congress to create a 3-digit number for suicide prevention. Our early ideas was actually 611. We were so set on that. Hardly anybody even knows that anymore. It doesn't really matter. But went back to DC, and we got Senator Hatch from Utah, Congressman Chris Stewart from Utah to run the bill, and hence the rollout of 988. You may not know that Canada's now adopted it. So from the tip of Aleutian Islands to Key Largo, we have an easy to remember 3-digit number. So somebody gave me the analogy. It's kind of like Michael Jordan. He tried out for the high school basketball team, and he didn't make the team, so he went pro. You know, we couldn't get a bill passed in Utah, so we're like, let's go to Congress. And growing up, my dad, when we have a really hard problem, he would say, this is going to take an act of Congress, which I was like, growing up, I'm like, then it's not going to happen. But we got our act. So a couple of exciting things that we're working on. In 2020, I ran a bill that gave a lot of funding for MCOT teams, funding for crisis receiving centers. We have those crisis receiving centers open up and down of the state now. And this past April, we opened up the largest, we call it the crown jewel. It's the crisis receiving center for Salt Lake County, where about a third of the state lives. 86,000 square feet, 30 recliners, 24 inpatient beds, an opioid addiction outpatient clinic, employment services, dental services, free legal services, and a number of other outpatient mental health services. And since it opened on April, Debbie, did you come out for the grand opening? Well, you should have. Okay, well, all right. Sorry, you probably didn't get an invite, but you have a personal invite the next time you come. I'll give you a personal tour. Since we opened around the 1st of April, we've now served over 3,000 patients. The inpatient unit is completely full. But I think the really good news is we're connecting people to services, trying to get them enrolled in Medicaid and provide robust discharge planning. So, and encouraging thing is the building is completely paid for, and we got ongoing funding from the state of Utah. So about 20% of our patients don't, even though we're an expansion state, about 20% of our patients don't have any funding. And we just tell them, you know what, you're covered. You'll get no bill. The state of Utah is covering this. And so it's a great model that, I know there's lots of frustration with federal legislation that's recently been passed at the state level. And I guess one of my messages is it's so difficult to control, what happens at the federal level, but you can make a difference at your state level. And I'll give you another example. Years ago, I was like, why is it so hard to train more psychiatrists from a workforce perspective? I'm like, do we need to add more seats in our medical school? And well, somebody told me, the chair of our psychiatry department at the University of Utah said, well, Congress, CMS quit funding medical residencies back in 1996. And it's just been kind of a desert since then. And naively, I said, well, can states fund medical residencies? And they're like, yeah, there's no prohibition against that. So through several bills, we created 16 new psychiatry residencies and a forensic psychiatry fellowship that they're all completely full, and now we have one of the largest training programs in the nation, paid for exclusively by state dollars. I don't want to sound like a doomsdayer, but government is massively in debt, and it's going to be exceedingly more difficult to get funding for anything, including, especially, mental health, in my opinion, programs. So looking to the states to step up and answer that call, I think, is a really critical thing. So let me talk about, we worked on the 988 bill. We only had one person who didn't vote for that bill in both the House or the Senate, just to show what a bipartisan, effort that was. I hope that guy's out of Congress now, but I don't even know his name. He's faded into limelight. So we're now working on part 2, and the bill's not public yet, but we almost a decade ago in Utah, again, me and Senator Thatcher ran a bill that created a program called Safe UT. And it had its origins in the Columbine shooting, and it was a way for students to submit anonymous tips about a fellow student who may be planning an act of school violence. Well, we did something, a lot of states have these kind of tip lines. Well, we decided, let's try something different. And so we added a crisis chat button. So you can submit a tip through the app, an anonymous confidential tip, or you can engage in a crisis chat. And we provided funding to have licensed clinical social workers staffing that 24/7, 365. No AI involved, just student to clinician. They had to be master's level trained clinicians. Well, that program took off. Students used it robustly. Over the past 3 years, we're averaging about 1 million threads a year. A thread is a one-way conversation, so that's 1 million back and forth. We've foiled numerous acts of school violence, but in the past about 6 years, our youth and young adult, which this program is for grades K through 20, all of our higher education institutions have it also, our youth and young adult suicide rate is down about 25%. And that's in an environment where, yeah, thank you. Not low enough, but it's going in the right direction. And this is with the backset of national rates going up. I can't say it's all because of Safe UT. We have Hope Squads. I ran a bill to create mental health screenings. A number of things that we've done. No one will ever be able to say exactly, what things are driving our numbers down, but they're going down, and that's what's critical. So we had such great success with the Safe UT program. We also rolled it out for we had another app, a bill I ran created Safe UT Frontline. That's for firefighters, law enforcement, corrections workers, EMS, and healthcare workers. They all have tremendous pressures and trauma in those jobs, and we've seen robust use from those individuals. And keep in mind that the call center, which is our 988 call center, is outside the chain of command for any of these individuals' employment. So if I'm one of my best gifts on Christmas a few years ago was my nephew, who's a corrections officer, said, hey, I spent about an hour on the phone with him the other day after one of my colleagues died by suicide. And they don't fear talking to somebody about their mental health issues because their boss isn't going to find out that they're having trouble, which sometimes is that stigma that prevents people from seeking help. We have another app called SafeUT-NG that's for members of our National Guard and their families. The basic SafeUT program is for students and teachers. And so with that background, we've had numerous states contact say, we want to replicate this. And so we are now working with a very effective U.S. Senator who's in the majority that is running a bill that Utah will donate this technology to the nation, license royalty-free. Any state can then implement it in their school systems as long, they have to meet certain criteria. It has to be connected with one of their 988 crisis centers, has to be implemented with fidelity, and a list of other things. But we hope that this is kind of like 988 version 2. We've just seen the success of students having that ability to text in a secure platform that's dedicated especially for youth and college students, so they can help connect them with either school level resources, community resources, encourage them to work with their parents as appropriate. And the way we're structuring it, we're hoping that bill won't even have a fiscal note, so hopefully it will go through pretty well. I was just working yesterday with the Senator's office on the bill title. I'll save that for later. But so anyway, that's the latest thing that we've been engaged in. Maybe the last thing that I mentioned two last things. One that I've spent now several years working on, I've got another bill file opened up, is mental health in our correctional institutions. Every state, our largest mental health institution is our prisons and jails, and too often the resources are far too little. I named a bill last session that I passed on getting more mental health resources into our prisons after a young man by the name of Oscar who took his life 2 weeks after he was paroled. He was the son of one of my former campaign opponents, and we've now become very good friends and working to make the world better for those individuals. They don't have a lot of lobbyists out there advocating for them, but they're people, and they need to get that help to hopefully keep them back into our community safely and not back into the correctional justice system. The last thing I'll do is I'll just give you a challenge. I'd referenced a few minutes ago the mental health screening bill. This is something I would love to see in every state across the nation. We screen for vision, we screen for hearing, some schools screen for dental, some screen for scoliosis, but like in Utah, the #1 cause of death for children is suicide. Nationally, that's the #2 cause of death. But do we screen for it? A lot of diseases emerge later in life, but we know mental health issues, the vast majority manifest during the teenage and young adult years. We also know nationally there's a 10-year delay between symptom onset and diagnosis and treatment. Whether disease state, do you go 10 years from onset of the disease to treatment? Imagine if we treated breast cancer that way. I mean, we screen annually for that. Yet for mental health issues, it's like a foreign concept, yet screeners are MHA. I don't have to lecture all of you about screening. So when I ran this bill, it was actually the most difficult bill I've run, and we had a state school board member trying to kill the bill when it was in the Senate, and I asked her if she was opposed to vision and hearing screenings, and she wanted to get rid of those too, and she's like, no, why would I want to do that? I'm like, well, those are issues that go wrong above children's necks also, but they don't kill them. Anyway, we got the bill passed. I just got the data last week, and in the first 2 years of the program, we've screened over 16,000 children with written parental consent, and about half have been referred to in-school or clinical community-based resources. So the bill had a zero fiscal note. Actually, I put money into the bill, so if children needed clinical help and they couldn't pay for it, the school could step in and pay for it. That was just icing on the cake. We didn't need that to get it passed, but that's a bill I'd encourage you to use our model legislation in Utah. Happy to work with your senators or representatives at the state level. But I think that's an easy takeaway, and it's a way upstream bill. So that's my challenge as I wrap up, Debbie. So.
Thank you, Steve. Yep. Come on now. Thank you for being here. Thank you, thank you, thank you. I'm going to just say thank you to everybody. Goodbye. Well, thank you for staying that extra 5 minutes. Thank you, Representative Ellison, for coming over. This is one of the magical things that happens. Oh, and by the way, of course, Representative Ellison has been honored by us, an award winner early on, and Senator Thatcher, who he mentioned several times, who's very wonderful, and what we've seen happen lots and lots of times. So I'm so glad you came over and you offered a challenge. We have seen states pick up learning from each other. They, modify it as needed for their state, for their particular populations, but it's one of those wonderful things. So I really want to thank everybody for coming out here. I want to thank again our industry partners. You can see everybody's name up there. I'm going to not go through it this time. And I really want to thank my colleagues who have been amazing. I want to thank Alicia, who got all the letters out to the representatives and senators who were here, who we honored this morning, and lots of logistical stuff. And I want to say a huge thank you to Catherine Reynolds, who just, I don't know how Kat does it. She's just wonderful. Gets all this stuff done. And to my colleagues who are here, Valerie, are taking care of our affiliates, and Jessica Jackson, who's working with our industry partners, and Stuart, who helped us get our press release out. By the way, all of the legislators' press release went out about them this morning and about how we honored them. And by the way, Steve, your name was in it too. Just saying. So I'm glad you came in, because otherwise it makes me not be truthful. And even though he's not in the room, I want to say a big thank you to Michael King, who stayed out there all day at the registration desk, and for Jessica Kennedy, who's out there. And if I forgot any of my colleagues, I'm really, really sorry, because we can't do any of it without everybody. And I hope you'll all join us at our next RPC meeting and be on the calls with your reps who are just up here. And we're going to be in Chicago along with Council of State Governments, CSG, in December. Our meeting will be on December 9th. And who doesn't want to go to Chicago in December? I mean, really. So we're excited. So thank you. And I hope to see you all soon.